medicine, about the history of emergency medicine in Saudi Arabia. I have nothing to declare. And you know, this is King Faisal Hospital. This is in 2010. This photo was taken. Okay. And at that time, as you can see, this is our emergency, the old emergency, and this is the protocol area. And this is the main hospital, the floors and everything. Okay. Recently, like 5 years later, there was a proposal to have a new buildings and to have a reconstruction of King Faisal. As you can see here, this is King Abdullah Center for Cancer Oncology Center and for transplant, renal, liver, lung transplant, as well as this is the research center. And you can see here, this is our new emergency, which was opened in 2018. And this one is the protocol area. So there was a total renovation. You know, King Faisal was established in 1975. It was opened by King Khalid. The foundation stone was laid by King Faisal. He donated the land of 450,000 square meters, and to make this service for Saudi people and not to travel abroad anymore. And since then, we have more specialties, and now it's considered #1 hospital in the Arab world. And one of the leading hospitals for transplant in liver, kidneys, one of the first 3 leaders in the world. And we have almost more than 13,000 employees in King Faisal. 10,000 of them, they are physicians, from consultant, assistant, resident, in different programs. This is King Abdullah. And this is our clinics here. This is the North Tower, we call it. Okay. And this is our new emergency building. It is a state-of-the-art emergency building. Okay. Which was opened on 2018 by the governor of Riyadh. This is the branch of King Faisal in Jeddah. And this was established, it's known before as As-Salama Hospital. Okay. Then our hospital, they took this hospital and they in 2000. And this is the proposal and the plan for the new hospital in Jeddah. As you can see, it is a huge city in Jeddah. And they already started, and in a couple of years, it will be ready to move there. Recently, just like 2 months ago, we have another branch in Medina al-Munawwara. This used to be called like Al-Miqat Hospital. And it was opened by the governor of Al-Medina. This is the day of opening. Okay, it was during the night time. And this is to reduce the load from patients coming from everywhere to Riyadh. So Al-Medina will help the northern area, because in the north of Saudi Arabia, and Jeddah, the western area and southern area. And we keep progressing. As you know, Saudi Arabia, it is a huge country. It's a big country. It's considered #2 largest country in the Arab world, and considered #5 in the Asian continent. We have more than 13 regions in Saudi Arabia. And for this reason, we have so many physicians, especially in the emergency and primary care. It is, 2.24 million square kilometers, and the population keeps growing. You know, in 2000, it was 20 million. in 2020, 35 million, and the expectation in 25 to reach 40 million population. Okay, and most of them, they are in the urban area. Okay, 80%, mainly Riyadh, Jeddah, Mecca, Medina, and Western, like Eastern area, Dammam, Khobar. And most of our population, they are under the age of 15, 40%. Okay, while the elderly were more than 65, about 2%. Most of them, they are living in urban area. And the health services that given to our population, it is mainly through the Ministry of Health. Ministry of Health will cover 60%. And 20%, the remaining 40%, 20% private, like Dr. Suleiman Al-Habib Hospital, Saudi Germany Hospital, other hospital, okay? And the other 20%, it's covered for their employee, like for example, and it is a specialized hospital. For example, we have King Faisal Hospital, we have Ministry of Defense hospitals, and we have Ministry of National Guard, which help their employees, and Ministry of Interior, and and so on. So before also, just, are we unique in our Saudi Arabia? Is there anything that we feel proud of in Saudi Arabia compared to other countries, and we feel like sometimes shamed of in Saudi compared to other places? I will show you. Sadly, we have a high incidence of diabetes. So this is out of our control. It is more than 25%. We have a high incidence of obesity, 40%. I think we are one of the major countries. I think in USA, they are also around this number, okay? Also a high incidence of cardiovascular disease, high incidence of vitamin D deficiency, 80%. I'm sure if you screen all of yourself, you will notice that you have some deficiency in vitamin D. High incidence of physical inactivity, and this is true, okay? Especially with the social media, now watching, and we are not moving a lot, we are not exercising, more than 70%. And high incidence of MVA, motor vehicle crashes, okay? We are unique, okay? We have our young, they are sometimes doing high risk behavior, and this is, none can do this, I can assure you, okay? They are changing the tire in a moving vehicle on one side, okay? And this picture, it got a prize actually in one of the USA programs, okay? Because they are very, doing some high risk maneuver. Accident, it's really bad, but we used to be one of the highest number of deaths among countries. Among G20, we were number one. Sadly, that was like in 2019. But with enforcement of the traffic regulation, and after our lovely ladies start driving, so there was an enforcement of the traffic rules. So the number of deaths from traffic accident, from a motor vehicle, it was decreased dramatically. I can show you here. This is in 2019. It used to be 28.8 deaths in each 100,000. This is from the traffic department. And we are, you see, compared to the G20 here, Russia, 18, in state 12 per 100,000, in Australia 5.3, in Saudi Arabia 28.9. But after our ladies start driving, this was like in 2018, I think, 2017, okay, and they got a license in driving with enforcement, because they were scared to drive with this risky driving people. So there was an enforcement of traffic, and This is our Minister of Interior, Prince Abdulaziz bin Saud. This was last year in April 21. And he announced that based on our vision, the government vision, the kingdom vision of 2030, there is a dramatic increase by 50% from 28 per 100,000, it reached 13.5 in 100,000, which is excellent achievement, okay? And we are hoping also to have less number. We are unique in Saudi Arabia. We have almost 3 million every year to come and gather in this small area, only about 2 square meters, okay? Doing, Umrah during Ramadan, okay? Or doing a prayer in Ramadan, and also doing Hajj, we used to call, okay? And within this gathering, there is rarely you can have victims or with the with the people coming here. So it was a unique for us, and we feel proud for helping our visitor to the holy area. Yes, recently in the last 5 years, we have a lot of changes in Riyadh, okay? A lot of buildings, I think you have seen it, okay? Those who came I think the last time you were here, Professor Marianne and Manoj, you remember that was in 2018, because 2020, we have a pandemic. So we didn't do anything like physical, it was online. Since then, there is a dramatic changes in our city, Riyadh, and there is a festival called the Riyadh Season, and we will hopefully take you there to visit and to see, okay? And it start to be a target from our Gulf region and even from the world. We have people coming from Russia, from state, from Europe to visit Riyadh, okay? Because they made it now easy to get like a visit visa, tourist visa, okay? So this is another achievement for our country, and we feel like we are proud to welcome our visitor from different parts of the world. This is like celebration in the Riyadh Festival, okay? This is just the pictures of Riyadh. Also, we have historical areas in Riyadh, okay? Some of us as a people of Saudi Arabia, we didn't know about these places, okay? Till recently, there is so many in different parts of Saudi Arabia, in the north, in the west, in the south of Saudi Arabia, okay? And the people, they keep coming and visiting this area because it wasn't being allowed before, okay? So as you can see, this is my home place. This is Haifa, okay? As you can see, it is in the south of Saudi Arabia, okay? And most of the people now, they are coming to visit this area. I hope one day you can come and visit us there. We did one course, by the way, there in Jazan, and we took all the group to visit this area, okay? We are unique dealing with COVID-19. We feel we are proud that with the policy and regulation from the Ministry of Health and help and support from all Saudi people, we are one of the first countries controlling COVID-19. Our number were almost one of the lowest number because taking all the measures, all the precautions for COVID-19. And most of our people now, they were vaccinated, more than 70% vaccinated. And even now kids, they are vaccinated, and they are not allowed to go to school or even to work without having a certificate of 3 shots of COVID-19 vaccine. Also, there is something that we don't like in our emergency department, I think, and this is why we have to discuss this thoroughly to encourage our emergency physician and our colleague in primary care centers to help us, because we notice in Saudi Arabia, each 100 person, they used to go to the emergency department, all of them. While the study showed, for example, in United States, each 100, only 30 to 40, each 100%, only 30 to 40 go to USA, to the emergency department in the USA. So our people here, they prefer to go to the emergency department because it is like a shortcut, okay? And to have the specialized physician and to have everything. They don't like to go to primary care because I think they are underdeveloped. They don't have like strong infrastructure. They don't have the strong referral system to the emergency department or to the specialized doctor. That's why they prefer to go to the emergency department. And this is what we like to discuss most of the time and help our friends in primary care center to improve their service to the public, okay? Because, you know, like for example, in King Faisal Hospital, we are seeing so many cases of liver transplant, lung transplant, cardiac transplant. And when they come to the emergency, they notice there is ahead of them like 5, 10 patients, and they have minor complaint, simple cough, or just, you know, flu-like symptoms. That's why it is part of our job to educate the society. When should I go to the emergency department? Okay, because not for any complaint you should go to the emergency department. Emergency for emergency cases, okay? And we hope we will succeed in that. We have a limited number of emergency physicians. That's why we are encouraging our newly graduate to join the emergency board program and to join also our pediatrician to join the pediatric emergency fellowship program. And this is just to give you an idea. In 2001, emergency medicine approved as a specialty under surgery. I remember Dr. Abdullah Hadib, he is the one who established this pediatric the emergency. And in 2005, I feel proud and honored with my friend, Dr. Muhammad Al-Hussein, we established the Pediatric Emergency Fellowship Program in Saudi Arabia. I was in National Guard, we established it there, and Muhammad was here in King Faisal, and we made it as a joint program. And since then, we have more than 14 centers all over the kingdom having the fellowship program. Like emergency medicine, it was started in 2001, and there was only four trainees. And this is one of the meetings of the board of the emergency program. At that time, it was under the surgery, okay? Later on, it became by itself an emergency board. Adult emergency, now, currently, we have more than 25 centers, because this slide, it is like an old slide. And it's distributed all over the kingdom. And we have a graduate more than 500 by 2021. And we have almost 300 trainee in the current, this is adult emergency residency program. In pediatric, we accept in the fellowship program, those who finish their pediatric board in general pediatric, or those who finish the emergency medicine. It's the same. It is almost the same like North American standard, state and Canada, USA and Canada. And this is a picture of me. I think it is like almost maybe, Muhammad, you remember this? It's about maybe 5 years ago. I don't want to tell how long ago, okay? So, and this is the National Guard, and Dr. Al-Umar, he was working with us in National Guard, okay? This is Dr. Al-Umar, Al-Hussein Muhammad, okay? And we decided to go ahead and do the pediatric emergency program, okay. Now we have, as I told you, 14 centers of pediatric emergency, and we have a graduate fellows, more than 130 fellows, okay? And we have currently 86 trainee, 86 F1, and 46 F1 and 40 F2. This is in 2018. The governor of Riyadh, he opened our emergency center, okay, in King Faisal, as you can see. And this is just a different, I think you have a tour yesterday there. Okay, this is a different picture of our hospital. Thank you very much. I just want to give you a highlight about our emergency
Thank
in
you.
Saudi Arabia. And if you have any questions, I'm
We'll
more
try
than
to keep the question to the end of the session.
Okay.
So for the sake of time.
Okay.
Give me a pleasure to co-chair this session. I'm Hussein, with my colleague. Give me now more pleasure actually with our next speaker, who is the international speaker, Dr. Mark Horvath. He's actually an associate professor of pediatric and emergency medicine at Yale University. He's the director of pediatric simulation, and he's the founder and the first chair of International Network for Simulation-Based Pediatric Innovation. He's quite actually expert in the field of simulation. He will enlighten us about the approach to multi-system trauma in children.
Thank you, and thank you, Dr. Al-Faifi, and our host for the gracious introduction and hosting. So it's very exciting to be here, and welcome to everyone that is online. Okay, and my slides should be coming up any moment. Our hosts have been very gracious, and we've really been enjoying the country and had a wonderful visit yesterday. This morning, I'm going to talk about an approach to multi-system trauma in children. I have no relevant financial conflicts of interest. I have leadership and some funding from the entities listed there. And my hope is by the end of this talk that as the attendees, you will be able to describe the approach to the describe the epidemiology of pediatric trauma, describe the approach to a critically injured patient, and report 5 common errors in pediatric trauma resuscitation. So really approaching this not from what to do, but actually what not to do and potential errors that may occur during this process of care. So when do injured children die? We spoke a little bit about this earlier on when we heard about motor vehicle collisions here. This is a continuum of care. So many injured children will die in seconds to minutes on scene. Many might die in that first 5 minutes or so en route, but the population that we have the opportunity to intervene on is really in that first minutes or up to the first hour, and we call that the golden hour of pediatric trauma. And then a number of them will die in days to weeks from infection, organ failure, ICU, and perhaps a reason that we see an improvement in our pediatric trauma centers, and we'll come back to this later, is the difference in care that we provide. That in our pediatric centers in the US, there's actually been a shift away from operative interventions, and that shift has really resulted in improvements in outcomes in the long term. So what do injured children die from? Traumatic brain injury is certainly one of the most devastating conditions and can be the most challenging to treat. Time-critical neurotrauma, there's many interventions that we have to do. Thoracic injury and then abdominal injury is really the most common injury that we will deal with, that we can intervene with. What do they die from? Again, it's the leading cause of death. We heard before about the number of deaths here. I wasn't sure about the number of pediatric deaths in motor vehicle collisions, but in the US, with the use of child passenger safety and restraints, we've seen a dramatic improvement over the past 20 years in terms of both the outcomes of the children on scene as well as when they arrive to the hospital. It's quite dramatic seeing some of these children come in from very high-speed motor vehicle with the passenger safety resources and the restraints. Many of these children actually will be quite minimally injured after a quite high-speed collision, but it still does lead to 5 million deaths a year globally. And why do they die? Again, today we'll talk a little bit about this from the approach of what we might do wrong and where we have opportunities for improvement. So some have a delay or misdiagnosis. Some have delay in treatments, and many actually have iatrogenic harms from some of our treatments. And those harms can be from an error where we do something wrong, maybe treat someone too aggressively or with the wrong medicine, or an error where we do not give a treatment that might be needed. So here's a picture that could be from any city. This could be from Riyadh, of a car traveling at 75 kilometers an hour. A child is thrown 5 meters after getting hit while riding their bicycle, and the pre-hospital team arrives on scene. So this, it can be a common occurrence in many cities. And your ambulance arrives, we'll sort of provide a case here for you. They arrive on scene within 5 minutes. They're about 10 minutes out from your hospital. The vital signs are what are listed there. This child has a Glasgow coma of 15, is awake, alert, and talking to them. So, what can we do to prevent this injury? There's a number of ways that we can look at this from a public health perspective. So prevention is absolutely the most effective treatment that we can do. So we said that there are, opportunities for improvement once they come to the emergency department, but a real effort in the United States has been on injury prevention for all types of trauma. And that can occur pre-hospital, actually pre-hospital, by the design of our cities, by doing things like installing traffic lights, by having police and other people enforcing traffic regulations, and that can decrease the likelihood of the event occurring. Then you can decrease the likelihood of the injury from the event. That's really from the injury itself. And that can be things like a bike helmet, which my children were not resistant to wear. I certainly would say in my generation, it was quite common to be quite resistant. My youngest is now getting to be, my oldest is getting to be 8 years old, so starts to give some feedback now that he maybe doesn't want to wear his helmet all the time. But truly similar to the car seats, children with helmets, much less common that they're going to come in with traumatic brain injury. And then lastly, where we'll focus today is decreased likelihood of harm after the injury. And that is from the wonderful care that I'm sure you provide here, both on scene as well as when they arrive to the hospital. So I know that this is a referral hospital, so this child could come in, restrained from within this medical center. From what I've heard here, from some of you online, that injury can occur out in the community. And then that can require emergency medical services to take them to an initial retrieval hospital. And this might be outside of Riyadh or somewhere else in the US. This is quite common in many of our cities where they're going to a community emergency department. After that, getting transported to the pediatric referral center where they might need operative intervention or inpatient observation, and then finally to rehabilitation. So this is what we call the continuum of emergency care. And thinking about this child going through this journey, we're going to focus today really on the pediatric emergency department and this concept of time within the pediatric emergency department and how we want to do things both efficiently but also effectively. And if we look at some studies from the surgical journals in the United States, up to 33% of errors, so a third of errors leading to death and trauma, can occur in our emergency department setting. So we really have the opportunity to save many lives by improving our processes of care. So pre-arrival, what happens in your ED? I know in our ED, even as a level 1 pediatric trauma center, there can be a lot of anxiety, a lot of pre-preparation that can be sometimes detrimental. So you want to prepare the people, you want to assemble your team, and from a team perspective, it's very interesting. In a prior talk, I actually used that slide that Dr. Alfifi shared before about changing a car tire while the car was driving. And sometimes this is what this feels like, because you're going into that trauma room. The ED doesn't shut down at that point. You still have patients in your ED. You still have many activities that are going on. You still have your cell phone getting social media updates, but you really want to assemble the team, define your roles, notify your specialists, and then you're going to move on to having those teams function in their roles. So similar to changing that tire, there's a gentleman that was, getting the tire out, another gentleman putting the tire on, so my slides seem to be skipping forward, sorry. But there's going to be someone, hopefully a nurse or a physician, assigned to get the appropriate equipment in the right size, the appropriate medications, and then prepare those systems downstream, making sure radiology, the operating room is prepared. And then little things like warming the room up, which we'll come back to later, that can actually have dramatic impact on care. Getting blood ready, that can have dramatic impact on care. So in the top 5 trauma errors, I would say that looking at the literature, one of the most common errors is teamwork, communication, and preparation. And I'll come back to this in a talk later in the conference, talking about simulation, which is an area of passion and interest to me. So teams that train together, just like that changing the tire on the car, or just like a pit crew in NASCAR, are going to function at a very high level together very efficiently and effectively. So in our emergency department, we have a guide for that. So similar to that pit crew mentality, we have a set of team roles that are assigned. This is a map of our team and sort of how we lay out that team. Then we have specific instructions for each of those roles. And then we actually have stickers that when people walk in the room, they're putting on those stickers to designate what roles they're in. Who is the team leader? Who's the airway provider? Who is the bedside provider? Who's doing the FAST exam? So this role clarity and role designation has been extremely helpful, and it requires ongoing training and preparation and then feedback or debriefing after. These pre-arrival checklists have really actually been quite helpful, and these are available on a number of apps and a number of other places. And a trauma pre-arrival checklist has demonstrated evidence to improve outcomes because it gets the team on the same page. So you're going to get out that equipment, but use a checklist to ensure that you're not forgetting anything. And I think we're all accustomed to our ABCDE, our trauma primary and secondary survey, but going through that and having a team leader or a team nurse leader that is actually looking at that checklist and saying, hey, we forgot this element of not only the survey, but potentially this element of preparation or downstream preparation. So our primary survey, effectively, we'd like to do this in less than 5 minutes. If you've taken ATLS, we talk a lot about not moving on until you have addressed one issue. With our large team sizes in many of our trauma centers, we can do things concurrently. So I would say that we're going to move through here through airway, breathing, circulation, disability, exposure, FAST, and then in our pediatric emergency department, we actually put family in there as well, where hopefully by the time in that first 5 minutes, we're getting through our primary and primary survey, moving on to the secondary, we can get some information from the family and provide them an update. And really, to get this done in less than 5 minutes does take very clear roles. It can take actually making sure to do what we call flatten the hierarchy. So if there is an intern that's coming in at our department, they used to start the survey, then the more senior doctor would come in and restart the survey, then the surgeons would come in and restart the survey. And we've really worked a lot to train together to improve that efficiency and get it less than 5 minutes and make sure that we're finding any distracting or secondary entries. So we're going to go through each of those elements. We would look, listen, and feel, and oh, there I am. We would look, listen, and feel, and look at, I'm not sure what's going on. I'm sorry. We would look, listen, and feel. And this child, we might have them strapped to a board and have a collar on. We've made a big effect in the United States by trying to remove those backboards and be more thoughtful about the placement of collars in our pre-hospital setting, because of the fact that, particularly in younger children, that might impact their airway and their airway positioning. Looking at this child, we see secretions in the mouth, so we're going to use our suction. We're going to Sorry, I lost the ability to advance my slides. Oh, okay, they're back on now. And after repositioning this child, their oxygen came up. We've suctioned them. We're going to move on to breathing, and with our pediatric assessment triangle, looking at that child, trying to understand, are they in respiratory distress? Are they having compromise? Are they in shock? In this case, the child has some pallor. You see a bruise on their abdominal wall, and they have a respiratory rate that you notice has decreased. So it started out at 30. They were anxious. Sometimes we've given pain medications that might cause this to decrease. Sometimes this might be a continuation of their illness or injury. We are going to then intervene. So we're going to get our chest x-ray, potentially getting our FAST concurrently or after that to look for lung sliding and seeing if there's a pneumothorax. And with our deterioration in mental status and respiratory rate, while we're doing breathing, we might move to bag valve mask and, if needed, treating a pneumothorax. So one of the things that often happened in our department was a child like this would go from bag valve mask from an airway management standpoint to intubation. And I think this is another major area for improvement. And we really have stressed this concept of resuscitate before you intubate. So this patient has a very poor reserve because they're critically injured. We'll get back to what that injury is later, but likely going to be some type of hemorrhagic shock. And by putting a tube into that child's throat and giving them medications, there's a likelihood that that child may go into cardiac arrest. So really, I would say that this child does not get a breathing tube for their airway assessment. They get bag valve mask. We continue on supporting the breathing, and intubation will physiologically decrease their systemic venous return, so may actually decrease blood flow to the heart, is going to increase intrathoracic pressure, but actually almost as importantly as the two of those very important physiologic factors is it's going to take time, and it's going to distract the team from that pit crew mentality. So really can lead to decompensation and death. The airway provider can prepare. We want to make sure that they're ready, that that process is started, but continue on with our processes. So airway intubation adverse events, including missed intubations, delays in intubations can also be problematic, but at least in the US, I've found that looking at our research that intubating too early sometimes is highly associated with those missed intubations or delays in other intervention. So as we continue on, we are bagging, now we're moving to circulation. We see that the patient has strong pulses, but a 4-second cap refill showing some signs of shock with cool hands and feet. The heart rate is increasing, so now pretty profound tachycardia of a heart rate of 170. And the blood pressure now is 85/70. So we have our circulation providers placing our large bore IVs, sometimes an intraosseous line if they can't get access, giving, and the nurse asks if in terms of your next steps, if you want IV fluids or blood. And in penetrating somber situations, which unfortunately we do see in the US, not when someone's struck by a bicycle, but for other reasons, this is where we would put tourniquets in, hopefully on scene and not at a later point. I've lost the controls again, sorry about that. So as we're moving on, and hopefully I will get control back of the slides, but with the circulation of this child, you see them continuing to deteriorate. You will likely see a change in their mental status as they deteriorate from a patient that was having good perfusion to their brain and heart, but entering a shock-like state. So their GCS decreases to 9, their pupils are still reactive, so you're thinking less of a neurologic injury, and you notice they're not moving their left leg, and there's an obvious fracture in that leg. So how do you prioritize management in this patient? This fracture might distract you. You might want to get focused on that. But you want to think about initial bolus of fluids, but then really quickly moving to blood, treating the pain, and beginning to get the operating room and other downstream aspects ready if they are going to be needed. So when you log roll this patient and remove all their clothes, you notice this obvious femur fracture, but also the abdominal cavity is increasing in size. Sometimes in our center, after getting the initial fast, we may get a serial fast, and that's where it can really help you to show you that you might see an expanded volume of blood. And unfortunately, this patient's temperature is now down to 35.5 in the room. So you're going to intervene, and one of the key factors in intervening in that child that is often naked and exposed in the room, many of our trauma rooms are warmed up in their temperature, is by recognizing the need to actually warm the child more directly, like we might in the operating room. So placing that child in a bear hugger, putting on the overhead lights, turning the heat up in the room. I would always say in our trauma room, you should be sweating if you're in there. So failure to keep warm, the ACS, American College of Surgeons, recommends keeping the temperature above 27 degrees Celsius. Also, I would recommend using a central thermometer if you can in this patient in shock. So thinking about a central rectal continuous measurement of temperature like we would in the operating room. In terms of your updated vital signs, as you see here now, our A, B, C, D, E are listed there. So we have a cold patient that's in a shock-like state with poor perfusion and deteriorating mental status, depressed respirations. So they're in a state of shock. There's an inadequate tissue delivery to the tissues. And in pediatrics, I think it is important to remember that this does not require hypotension. Hypotension is usually that cliff where we're getting close to cardiac arrest, so not waiting for a patient to go into hypotension. And in pediatrics, we are not following some of the adult guidelines, at least in our center, of the permissive hypotension at this time. So they're compensated, they have decreased perfusion to the brain and to the skin, and often our blood loss is underestimated, and this is where that serial fast can be helpful to give you an idea if there's active bleeding, potentially from the liver, spleen, or catastrophically from a large vessel like the aorta, and they can rapidly crash. So hypotension, as I mentioned, is going to be a late finding, and being prepared for cardiac arrest when you start to see hypotension, but really escalating the degree of interventions of things like blood products. Thinking about other etiologies of shock is critically important as well. So failure to appropriately treat hemorrhage, and that treatment of hemorrhage can be mitigated by a variety of factors. So one is we want to limit our crystalloid, that in our center, we often were giving a 20 cc per kilo bolus followed by another 20 cc per kilo bolus of normal saline. And our surgeons for a long time were saying that we probably need to give blood more often. And then data came back from the battlefields, actually, pediatric data came back from some of the battlefields that really showed some of the adult protocols of 1-to-1-to-1 infusions of a massive transfusion protocol was very effective in limiting saline. So in our center, we've shifted to this model as we're getting into that second bolus, or even the first bolus if we're giving as a 20 cc aliquot, then moving very rapidly to packed red blood cells. So this patient's losing blood, we need to replace that with blood. Otherwise, we're going to decrease their oxygen carrying capacity and potentially worsen their shock state. So on the right side of the slide here, I have shown what's called the deadly triad. And I think it's very important to understand how the temperature is going to interact with some of the acidosis and coagulopathy. And this is a vicious cycle. So that cold patient that is bleeding out and potentially losing blood factors and becoming coagulopathic will then become to get acidotic, which is then going to precipitate poor thermoregulation, which is thereby going to precipitate poor coagulation function and more hemorrhage. So really in our center, we have moved very quickly to get not only blood, but actually a massive transfusion protocol for that patient. Hopefully we have that PIC crew that can get the patient to the OR when and if they're needed, if they're in shock that cannot be reversed. So we want to order these blood products, get the blood bank to thaw them, get them ready. Some centers have started to move more towards whole blood, which is very interesting and has been demonstrated to be very effective. Some have even started to use whole blood in the field, which can be quite helpful. So in our center, we're giving the packed red blood cells, platelets, moving on to FFP. We're being careful about calcium and potassium. Our center in these severely hemorrhagic shock patients, we are using TXA. The studies are really still out there in the younger children. We're hoping that more information will come. We find the risk benefit towards the benefit and have started to use TXA again in these patients that are going to the operating room, not the mild to moderate injury, but the severe injury and impending death. So for our FAST exam here, we are likely going to see blood. I know that you had a wonderful ultrasound course yesterday, but again, looking not just for a positive or a negative, but looking how that is changing over time. And also looking at the cardiac function, looking at the IVC and SVC to see that how severe the state of shock is. This patient may end up getting a CAT scan. If you were to get a CAT scan, they likely are going to have a high-grade liver and or splenic injury. And one of the key findings going back from some of our pediatric emergency care applied research network studies are really how profound that bruising should be too. So that's something in that earlier slide of seeing bruising on that abdominal wall should really set you off that this is a patient I should be worried about even before they decompensate. And in the US, our practice is to have the family present. That improves both the child as well as the parents' psychological outcome and actually some of the child's medical outcomes, which is quite impressive to see that having the parent in the room, having the parent there to support them, or at least giving the parent that option. So this patient, after your packed red blood cells, platelets, and FFP, their heart rate decreases. They are now sleepy because you've given them morphine or fentanyl, but they're more alert overall. And now they're less alert overall. It's hard to say, is that because of your pain medications or is that because of the shock? And that can be a difficult thing to differentiate. But now it's time to intubate. Now you need to come back to that airway. You've been bagging. You don't want to be bagging for this patient going up to the OR or the ICU, and this patient likely is going to need more pain medication. A very simple and easy thing to do if they don't have facial injury is decompress the stomach, which gives you a much easier opportunity to pre-oxygenate and hyperoxygenate that patient and preparing your equipment. So as you're preparing to intubate, you want to consider some of the injury patterns that we can see. So like in anything, there's pattern recognition. And in this child hit by a bicycle with this intra-abdominal injury, with that leg injury, if you can have a scene of the crime sort of videotape, which we now see sometimes in social media, likely this patient flew backwards and may also have a head injury. And that patient, unfortunately, in this case, was not wearing a helmet. So traumatic brain injury, again, is the leading cause of mortality. So that abdominal injury can be pretty impressive as you're seeing that fast expanding. The femur fracture can be pretty impressive as you might see something like an open fracture or distracting injury. But the primary brain injury has already happened, and our goal is really to prevent secondary injury. So my approach to this patient would be presuming blood in the brain and doing things that are consistent with the neurocritical care best practices, like limiting stimulation, limiting pain, elevating the head of the bed. So delayed or misdiagnosis, I would say TBI or brain injury can fall into that. Here we might get distracted not only by the femur, but also that abdominal injury. So this is a patient where we really need to be considering herniation, not waiting for herniation. So doing some of those neuroprotective measures. So as that patient progresses in being obtunded, is that from pain or is that from blood in the brain? We don't want to wait until we have pupillary dilatation. We learn all about Cushing's triad. We don't want to wait until that's there. Hopefully we've intervened and done some neuroprotection before that with some of those basic life support maneuvers like elevating the bed and giving pain medication to decrease stimulus to the brain. So if that patient does progress to hypertension and potentially bradycardia and irregular respirations, then we're thinking more of ICP and more aggressive interventions like 3% saline or mannitol to intervene. But really basic things like elevating the head of bed. Another thing that I've learned from our neurocritical care guidelines is opening up that C-collar or making sure the C-collar is not actually obstructing venous return from the brain. And then osmotic agents and being very cautious about hyperventilation. So we really have made end-tidal capnography our standard. I would say in our trauma review, I don't think I've ever seen someone hypoventilating a pediatric patient. We all tend to ventilate at our heart rate. So most of the time that end-tidal helps us to appropriately ventilate, not hyperventilate. So aiming for an end-tidal of no less than 30, and then considering getting neurosurgery involved again from that systems of care standpoint. Other really important things for neuroprotection, avoiding hypoxemia. So hypoxemia is going to decrease the amount of ATP getting to your brain cells and potentially cause more brain injury. Again, temperature comes in here, so you really want to have a nice thermostat in there. For this, it's unfortunately a little bit more challenging. You can't just go too hot. If the room is too hot, that can also affect brain injury, and avoiding hypotension at all costs. So from a neuroprotective measure, there is some literature going back that had guidelines that supported a really complex process here with things like lidocaine given pre-intubation, and actually arguing that things like ketamine, which we did for many other patients, were contraindicated. Fortunately, the literature really now demonstrates that we can sort of do many of the things we do for other patients. So in RED, we are okay with using ketamine. That ketamine actually, ironically, may have some neuroprotective effects, while before we were thinking that ketamine was actually harmful. We have not used lidocaine. If you are going to give lidocaine or atropine, both of those need time to work. So those would need to be given 3 to 5 minutes before, which usually you don't have 3 to 5 minutes in the situation. Whatever paralysis you'd like to use, if that's rocuronium, if you're in a pediatric institution, if you are in a general institution, that might be a different agent. And then making sure to use a cuff tube. That's really another change in practice in the US, that at any age now we are using cuff tubes. And really not just thinking about the tube, but also it's critically important to think about post-intubation sedation, because that post-intubation time period is a time where that child may be suffering more pain, more anxiety, and having a spike in their ICP. So maximizing our first pass success rate in intubation. I saw the video laryngoscopes that you have yesterday and really was impressed with the intubation training that I heard about from Dr. Al-Faifi. But again, one of the barriers to intubation that as a simulation specialist, one of the things that we do is practice very often, but I've recognized that one of the most challenging things is actually getting all the stuff ready. So putting the tube through the cords when someone hands you all the appropriate equipment and resources and positions that child for you is not very challenging. It's more like a video game, on the video laryngoscope, but really making sure to always have a backup plan and have all that equipment ready. So if that's video laryngoscopy, having backup with a direct or potentially anesthesia backup. The tools that our team has started to use from the adult literature that have really helped a lot in pediatrics and the older children are things like a bougie. So actually, this was something that came from some battlefield medicine from some of our military medics, is actually using the bougie as a stylet, so that if you look in, you can't see because there's blood in the airway, using the bougie, not having to take the stylet out and put a bougie in. It's very uncommon that we can't intubate, can't ventilate. I know many of us are often thinking about needle cricothyroidotomy. To me, that's the wrong answer on the multiple choice test of what is your backup plan to intubate. The only time that we're talking about needle cricothyroidotomy is a very different patient than this patient, something like a dog bite to the face or some type of trauma where we might not be able to anatomically get to the top of that trachea. So absolute last resort. Again, there's sub-checklists for airway. This is one from Boston Children's Hospital. And in their hospital, they actually have a really robust process. And I'm hoping that we can copy this at some point in time. But what they do at Boston Children's, and Dr. Negrovich can comment if this is correct or not, their attendings even have to demonstrate proficiency in airway placement. But they actually have really a guide through the airway procedure. And this is due to some work by Josh Nagler and others, where that guide is reading aloud the items here, knowing that provider has actually been deemed competent in placing endotracheal tubes. And they do this in a really neat way by requiring them to record their passage of the tube and looking at what type of view they have. But having the providers, having the airway, having the patient, and this is another borrowed resource from our colleagues in Children's of Colorado, where actually they make it quite easy. On top of their airway cart, they have sort of this map where you basically need to put each piece of equipment. So instead of finding each piece of equipment and hoping that you have it, they have a little map that you just need to fill in the pieces on the puzzle and make sure that equipment is ready. So after intubation, I would say, we talk a lot about the dope mnemonic, but I really wanted to focus on that pre-intubation and peri-intubation, where I think many more errors happen. Again, this is an acronym that we've all heard many times, and just to reiterate, so thinking if that patient has been intubated and is now decompensating, it could be progression of their disease. It may also be displacement, obstruction, a pneumothorax, or equipment failure. So, we hit these 5 errors here of poor teamwork communication, airway, intubating too early, having challenges with equipment, failure to keep warm, sometimes maybe getting too warm later on for neurotrauma, failure to treat hemorrhage, getting massive transfusion, getting platelets, packed red blood cells, and FFP, and potentially TXA, and thinking about misdiagnosis. So I hope I've hit the epidemiology of pediatric trauma, thinking about blunt trauma being the most common, and abdominal and brain injury being causes of morbidity and mortality. An approach to the critically injured patient, which just to highlight that this critically injured patient, while they had blunt abdominal injury and a grade 4 or 5 liver lac, in our department, the dramatic change, and in the US, the dramatic change is that this patient would likely go to the ICU, and unless they had shock that was not mitigated by blood, would not go to the operating room. So if the patient continued to be in shock, and there's a trial called the EAST trial, if you're interested in looking at EAST, which are some states in the western part of our country, which really demonstrated that non-operative management helps in both short and long-term mortality, because taking out their spleen increases the risk of infection. Opening the abdomen really can actually oftentimes cause that patient that has auto-tamponaded to restart bleeding. And I've hit these 5 common errors. So I guess I'll take any questions at the very end. This is New Haven, Connecticut, Yale. It looks a little bit like Harry Potter to some people. Welcome any of you to come visit at any time. We have a beautiful fall and certainly a beautiful spring that's starting now. Winter's not necessarily the best time, but thank you so much.
Thank you, Mark. Now, we react with me. She's a professor of clinical medicine and pediatric at David Freeman School. She was the medical director for Angeles County University, and she is also the senior editor of known and currently she is the president of the American Board of University. She also co-chairs this conference on COVID-19 in children.
Thank you so much. It's so good to be here in Riyadh again. This is my 5th time to the kingdom, and it's good to see old friends here. So thank you for having us. We're very excited to be here, and it's been a wonderful visit so far. Today, I'm going to talk to you about a subject you all know well, We've all been through the COVID-19 pandemic. It's been a very difficult time for people globally. And I think it's affected everyone, either personally, their family, their friends, etc. So what I'm going to do is walk you through the timeline a bit of COVID-19, talk about the impact on children, some of the epidemiology that has occurred, and also the therapeutics that are available. Remember when the COVID-19 pandemic began, we didn't know what would work. And we kind of threw everything at it initially, and we've learned quite a great deal about the care of these patients, and especially about the unique needs of children. Oops. Sorry about that. First of all, I have nothing to disclose, and I'll try to, okay, I think I got it, where to point this. This is the basic timeline. You can see here, the first COVID-19 case was identified in China in December 2019. You can see that the genetic sequence was shared in January 12, 2020, and the first pediatric case in China was reported in January 2020. The WHO, the World Health Organization, declared a public health emergency of international concern. And again, first pediatric case was reported in Korea on a worldwide level. And again, this was reported by this all timeline was reported by our CDC, or Center for Disease Control. As we move on, you see by March 2nd, the first pediatric case was reported in the United States. This time, there were obviously many adult cases on a worldwide level. And the global pandemic was declared by the WHO on March 11th. On March 13th, the United States declares a national state of emergency. And I know that in 2020, as we were preparing to come to this conference, we all had our tickets, we had our lectures prepared, and we had to cancel. And kudos to Dr. Al-Faifi and all of his colleagues who really gathered together and worked with us to create an online virtual 2020 conference for the 6th International Conference. So I want to say thank you for that pivot. And I think we had more than 1,000 people online in 2020. On March 24th, the first pediatric death was reported. We often think that children, at least in the beginning, were immune to COVID-19. I know we went over 9 months in Los Angeles without any pediatric deaths. And one of the theories around why pediatric patients don't get COVID-19 is that the way the virus gets in is through the ACE2 receptor, and that it takes a while for that to mature in children. And it turns out that obesity, being a risk factor, is a risk factor for children. Obesity upregulates your ACE2 receptor, and that is a reason why children with obesity are higher risk for having severe complications. And as you can see, on April 26th, and this is something very important because this seemed to be unique in children. However, we know it also occurs in adults, but the National Health Service in the UK reported a syndrome, a multi-system inflammatory syndrome in children. And these were patients who were approximately 4 weeks out after COVID-19 infections developed this syndrome, which include multi-organ failure, especially cardiac issues as well. And the first reported death in the United States was reported in May 8th. And again, the CDC on May 14th released that they were seeing multiple cases in New York. I know Italy reported this as well, the multi-inflammatory syndrome in children. So that's the whole timeline. I'm going to move on just to see the impact of COVID-19 on a global scale. This is from the 13th, actually, and by the 21st, there have been more than 460 billion cases, million cases, sorry, that's a lot of people, a lot of infections, 460 million cases of COVID-19 with over 6 million deaths. And this is a map of the world. You can see the darker the blue, the more infection or cases there are. And it's quite disparate all over the world. And I think the reason Africa shows lower case numbers is lack of reporting and testing within the region. As we all know, there have been multiple surges. You can see the 4 surges that have occurred initially with the initial infection and later with various variants. We had our biggest peak in Los Angeles with over 8,000 individuals hospitalized with COVID-19 in January 2020. Indeed, there was another peak with Delta in the summer, and you can see that on here. And you can see where the peaks occurred in various places of the world. And the last peak occurred with Omicron, with many, many more cases, even in patients who had been vaccinated. And we saw a large number of children on a daily basis infected with the Omicron variant. This just shows in the United States some of the diversity around our country. Even you saw it we've seen it on a global scale, but also we saw it in the United States in terms of the number of cases. So let's talk about the impact of children. These are statistics from the US. I tried to get World Health Organization statistics, but it was very, very challenging to get that. So this has been reported by our CDC and the American Academy of Pediatrics, along with the Children's Hospital Association, has really a nice dashboard of information as well as information on therapeutics. So if you go to aap.org and put in COVID, it is public facing, and so anybody can get this information. There's been more than 12 million total cases of COVID-19 in children in the United States, representing about 19%. Initially, it was a much, much lower percent of infections. And that may have been related to what we call the stay-at-home order or isolate in place. And many people stayed in their homes and weren't out and about. In terms of the hospitalizations, you can see somewhere between 1% and 2% of all COVID-19 admissions are children. And again, most of these cases, I will tell you, are generally supportive care. We saw initially a lot of children with dehydration syndromes, gastrointestinal disease, and also respiratory disease, especially those kids who are high risk. Now, the good news is that the likelihood that a child is going to die of COVID-19 is extremely low. And you can see about 0.25% of all COVID-19 deaths are children, and the mortality rate for children in general is extremely low. And this just shows the United States the number of COVID-19 cases that were added in the last week. So this goes through, I believe, March 3rd of 2022. And you can see that with Omicron, we saw a huge spike in the number of children. The good news is that we had tremendous capacity in the United States, but I'm sure that that is not true worldwide. And in the kingdom here, I imagine that you had great capacity to care for children, whereas in other countries or poor countries in the world, that may not be the case. I love this slide because it was a group of PICUs that got together to begin to gather data on children and to track them to see what kind of therapies they received, also what their mortality rate is. And this just demonstrates that there were about 3,300 cases admitted to the PICUs. And I believe this is all in North America, Canada, and the US, in which they gather data. And you can go to vps.org and you can join. There's an opportunity for PICUs around the world to join. So let's just talk about some of the testing recommendations. Typically patients with symptoms, although I will tell you that with the Omicron variant, the issue was how old they were there issues of high-risk individuals at home? And we became somewhat overwhelmed because of workforce problems. I don't know if you had this in the kingdom, but We saw many people getting ill that were healthcare workers as well, and people who'd been vaccinated with Omicron. And therefore, the healthcare, although the number of cases were high, the severity was relatively low, but it still inundated our healthcare system in the United States, and it was really, really challenging. So sometimes patients with symptoms got tested, other times they did not. They were asked to, after evaluation, to go home. And then patients who are asymptomatic, but with close contact to a person with COVID-19. And typically, as you know, the incubation period is about 2 to 14 days for COVID-19. But generally by day 5, if they've been exposed, they should be positive at that point in time. And as we all know that antigen tests, if they're negative, you probably need to retest because their accuracy is about 30%. If positive, their accuracy is much higher in the range of 70%, and PCR testing is considered the gold standard. So what do we do with newborns? And in many hospitals, they test prior to discharge, typically 24 and 48 hours. But in some areas in the United States, patients are discharged within 24 hours after delivery. So the standard is to test them prior to discharge, as the young child is at a higher risk. And then finally, there's been routine testing for school and in childcare or congregate living situations. There's been routine testing. What about clinical presentation? As you can see here, this is a reprint. This shows what we call COVID toes. It's essentially aligns with chilblains, which is considered probably the pathophysiology as it relates to COVID-19 has to do with the vasculitis or a microvascular disease, microvascular inflammation that results in what you see with either red or frankly cyanotic looking toes. Generally, those respond well without therapy. The most common presentation in children was fever. We did see a lot of kids early on. I'd like to, in our question and answer session, I'd like to see what your experiences are here, but we saw a lot with fever, GI complaints, URI symptoms, of course, and then some with shortness of breath, others with petechial syndromes that like their bodies were showered with petechiae, which was really interesting, and papulovesicular rashes as well as urticaria. As you're aware, it was around April and May that the multi-inflammatory syndrome in children was reported, and on May 15th, WHO came out with a report on multi-inflammatory syndrome in children. And the case definition, as you can see here, an individual less than 21, we do see multi-inflammatory conditions very similar to this in adults as well. And as you know, with adults, they were more likely, although children still had effects from the cytokine storm and the massive inflammatory process that beget COVID-19 infections. But generally we say under 21, and they're typically older than you see with patients with Kawasaki's disease. So laboratory evidence of inflammation. And when I talk about fever is 38 for greater than 24 hours, or the definitions also include subjective fever for greater than 24 hours. And then laboratory evidence of inflammation. So what does that mean? C-reactive protein or ESR, erythrocyte sedimentation rates, procalcitonin elevation, D-dimer, ferritin. These are some of the, oftentimes we do a kind of a stratified approach, those that we think could have multi-inflammatory syndrome. We, again, with some of these labs, especially C-reactive protein and ESR, and then move to the more complex labs such as troponin, procalcitonin, D-dimer, et cetera. So again, with multi-inflammatory syndrome, I'd seen a number of cases. This one child came in that I saw basically was totally awake and alert, but pulse ox was low, just like we see in the adult population. And he had reactive airway disease. We started treating that, and his blood pressure never came up, and we ultrasounded him, and he had severe myocardial dysfunction and ended up requiring an epinephrine drip and intubation. Now, the good news, he was discharged 3 days later. So that was one of the things that we did see with multi-inflammatory syndrome, that some of these kids got severely ill. And if they were appropriately supported, they were able to be discharged. It was pretty remarkable to see him awake and alert with a blood pressure of 60, and yet talking to us, wheezing. And then ultimately we realized that we needed to intubate him. So we supported him, gave him pressor agents, intubated him after we tried with fluid support and inotropic support, and then he went to the PICU. So anyway, there's no alternative plausible diagnosis for these patients. So it's kind of a diagnosis in which you need to consider all factors. And as you know, there's a number of causes of myocarditis besides what we see with multi-inflammatory syndrome, but it is something we need to look for. And then the other thing would be a positive for current or recent SARS infection, and generally it's within 4 weeks, or they could show antibodies. The other thing that you see is reduced lymphocytes and low albumin. When we look at the various diseases, I think it's important to see that there's overlap between Kawasaki syndrome as well as toxic shock. So some of these patients early on presented as if they had toxic shock. The other thing that there's overlap, and this is a severe condition that is sometimes congenital, which is the hemophagocytic lymphohistiocytosis and macrophage activation syndrome. We do see hereditary versions of this. It can be acquired, but there was some overlap with this. But that has a much higher mortality rate than we see with the multi-inflammatory syndrome in children. So what are some of the key differences you can see on the slide? With Kawasaki's, they're often younger, and these kids were over 5, and we saw teenagers with this. Presence of abdominal findings, as I mentioned before, and I saw many patients that had GI symptoms. We had several that had pretty severe colitis that were COVID-19 positive. And then as the case that I quickly told you about is higher rate of cardiac involvement on presentation. So you really have to balance your fluid resuscitation with your pressor, and that can be very problematic. And some of these kids are on afterload reducers as well. And again, like our patient presented in profound shock, although he was totally awake and talking to us, which I found very remarkable. Just like I saw with many, many adult patients for which they had pulse ox of 60%, and yet they were awake and talking to you. I had never seen that before in my career until COVID-19. So it's clearly a unique disease. And then thrombocytopenia and obviously increased cardiac markers. And this is just some of the screening that you see. Generally, the CRP is elevated, ESR, the lymphopenia, thrombocytopenia, hyponatremia, and abnormal creatinine, just stating that it's multi-inflammatory and it involves multiple organ systems that we saw. And there's a huge number of signs and symptoms of MIS-C, as you can see here. And some of them are typical of Kawasaki's, such as conjunctivitis and lymphadenopathy. Other labs that we would consider, I would certainly get an EKG on them to look for signs of ischemia. I did not see that. We initially saw tachycardia, and this child became a little bradycardic, which made me very scared for a while, but it came up with our therapy, including really oxygenating him appropriately. But you can get troponin, you can get BNP, obviously the COVID PCR, and then consider other causes, because some of these kids, is this toxic shock? Could this be septic shock? It can be really challenging. So we often did blood cultures and empiric antibiotics. So in terms of support of these patients, it's really supportive care. Studies now have shown that using IVIG is very useful along with steroids, that combination in particular. And as you can see, the methylprednisolone dosing is there for you. And then for some of the thrombotic complications that we saw, aspirin for young children, and then enoxaparin or Lovenox for older kids. The other thing is we see that the long COVID syndrome is definitely real for children, and this is something to consider, kind of that neurologic fog, depression, those types of things, I think, difficult in terms of being able to exercise and some of the respiratory symptoms. And there was a study looking at the multi-system inflammatory syndrome in children worldwide, and the UK sponsored this. And there were really well over 100 children worldwide with this syndrome, although it wasn't, and who knows, that was what was reported. I'm sure it was more common than that. When we talk about COVID-19 in general, some of the diagnostic studies that we often use, depending on their presentation, was getting an ECG, certainly chest x-ray with those with respiratory symptoms. Most of the children I saw were young, febrile, looked like they had a viral illness, were COVID-19 positive. We saw a lot of kids with croup that had COVID-19, also some that seemed to have more of a bronchiolitic syndrome with COVID-19. So again, you would treat based on those symptoms, and certainly use of steroids in kids with croup seemed to be useful. And then finally, using point of care ultrasound, looking at the lung and cardiac. And as you can see here, you get with the lung, what you often see with COVID-19 is you get an irregular pleural line, and you can see that here, and these B lines, okay? And there at times were areas of consolidation as demonstrated here. So it could be quite useful in order to diagnose this. Originally in China, they were CT scanning all the children, found ground glass appearance, but stopped doing that because, again, you should treat them symptomatically. And some of these children got radiation that really didn't need it. So I think just a simple chest x-ray is fine, and then treat symptomatically. So now we're going to talk about therapeutics, and certainly oxygen, use of high flow nasal cannula, and intubation as needed. But early on, we were intubating everybody. And they thought early intubation was the way to go for adults and young adults, but that really wasn't the case. And we moved to a high flow nasal cannula. And the rule was 2, 4, 6, 8, meaning, and then you have to intubate, is how we thought about it. And then approximately May of 2020, remdesivir became available in the United States. And this was, this and the fact that they showed that dexamethasone decreased mortality in patients in the ICU was a godsend, because it just meant that we had something that we can give that might make a difference. And probably what we've learned over the pandemic is that the earlier you give remdesivir, the better. And as you might be aware of, the indications at first were the most ill, and then we backed off to anybody who needs oxygen, and then anybody who's hospitalized, and then anybody who's high risk, who's not even admitted to the hospital. So I think the earlier you give remdesivir, the better, and it's done on a milligram per kilo basis. You can either do a 5-day or 10-day course, although studies in adults have shown that there's no real clinical advantage of going 10 days, but some would go 10 days. based on the fact that they were critically ill. And then dexamethasone is given. You can see the max is considered 6 milligrams a day, which is the adult dose up to 10 days. And again, the IL-6 inhibitors have also been used for adults and children. What about some of the antivirals? And I think there's going to be expanded use of the antivirals as we go along, as well as the monoclonal antibodies. And as you know, the monoclonal antibodies have been a bit of a moving target. We started out giving bamlanivimab, and then etesevimab we added, and then there was resistant to that, Regeneron, which is casirivimab and indevimab. And so those were given, those were quite effective with Delta. But in California, we had a California variant, which was a UK variant, and we could only use, we could not use bamlanivimab early in the pandemic. So we had to switch to Regeneron. But now we don't use either one, right? So I'll talk more about that in a second. But who should get these? Again, these are the newer monoclonals are approved for children 12 and older, and at least in the US. I think that's probably true globally. And it would be great to have a discussion of what's available here in the kingdom. But as you can see, obesity was a big risk factor. Immunocompromised disease is really important. Neurodevelopment disorders, this is different than what we do in the adult population typically. And then medically related technological dependence. So those kids who, especially with tracheostomies, or require positive pressure ventilation at night or during the day, and those with gastrostomy tubes. Sickle cell, chronic disease, very common in the adult population as well. Diabetes, common in all age groups, again, as well as chronic kidney disease and liver disease. So these patients are high risk. So if they had COVID-19, they could get it within the first 5 to 7 days or so. So we're going to talk about outpatient therapies. The remdesivir I talked about, as well as the IL-6 modulators, and dexamethasone are inpatient. But outpatient treatment, remdesivir can be given. It's on a milligram per kilo basis, very similar to what is done in the inpatient, but it's only done for 3 days. And these are for high-risk individuals that have a chance of getting severe COVID-19. And that's the list I just went through with you. The Paxlovid, sorry, I'm getting too close to the mic. 12 years or older, and again, within 5 days of onset. And this has been shown to be highly effective. And I think we'll see much more use of Paxlovid, maybe even very similar to how we use Tamiflu for influenza with the high-risk populations. And then molnupiravir, which is another antiviral, initially looked very promising, but the efficacy is much lower. And it's complicated by the fact that you can't take it with many, many other medications that are given, including statins. So this really has limited its use in the adult population, and it's really not used for children, but I just thought I would mention it. And the monoclonal antibodies that we're using now, the sotrovimab, which is something that we have allocated to many, many centers in Los Angeles. And this is given over 30 minutes. And then the bebtelovimab, which recently came out, both of which are effective against Omicron. And the thing that was really great about the bebtelovimab is that it can be given in a single injection, which is fantastic news. And then finally, Evishield, which is given differently than the other two. And these are pre-exposure prophylaxis. This is a combination monoclonal, as you can see, and it's given in 2 separate IM injections, and it lasts for about 6 months. So these are for the immunocompromised transplant patients, those who really can't mount a response to COVID-19, and it can be given before they get it. So if they're undergoing chemotherapy, if they are post-transplant, these patients can be given this even before, and it's supposed to be given before they develop COVID-19. And finally, this talk about COVID-19 would not be complete without discussion about vaccination. As you can see, children have very low mortality, but we really don't know the full impact of COVID-19 in the pediatric population in terms of long COVID or other long-term complications. But what we do know is that the vaccines are very effective. And the three that I'm most familiar with are Pfizer, Moderna, and the J&J vaccine. And as you know, there have been multiple reports about the myocarditis, pericarditis that you see post COVID-19 vaccination. We have seen that not that commonly, and most of these children they have chest pain, they may have shortness of breath. They may have some cardiovascular complications, but they generally do quite well within a couple of days. There have been some concern about some of these kids dying, but it's very, very rare relative to this, extremely rare. And if you think about that, over 10 billion doses of vaccine have been given globally, the fact that there are in the range of 1,000 cases of the myocarditis syndrome reported is extremely low, and the risk is very low. When you look at those approved, you can see that Pfizer is really the one that is approved for children. Otherwise, the 5 to 18-year-olds, and otherwise Moderna is available. And that's the end of my talk on COVID-19. I know this has been a challenge for all of us. I really appreciate that we've hung in there throughout this time. These are various snapshots of things. We had a flyover by our military for all of our healthcare workers, and literally people all over the United States and various things. They came in and they honored healthcare workers. It was quite moving to have that done, and that was during the week, EMS week. And we also had our U.S. naval ship Mercy come to Los Angeles to help us during the pandemic. And you can see in the lower left, this is our medical alert center. We were really on call 24 hours a day, probably for over a year in the beginning, working 7 days a week. And it was really impressive to see the number of people who really chipped in to try to help with the pandemic. And then on the lower right is our warehouse. We distributed over 60 million pieces of PPE to Los Angeles and all of the therapeutics. So it was a busy time for me during COVID-19, but it was one that I think, as Dr. Alfalfi said, that he was very proud of the response. And I feel proud of all of our healthcare workers, both in the United States and abroad. And thank you for all that you do. Thanks.
Is Professor of Pediatric Medicine, Texas. He's also widely involved with research and important to become the hospital CEO. Could you have any thought to us or enlighten us about the state of patient asthma?
Thank you. It's a pleasure to be here today in Riyadh to speak with you about state-of-the-art asthma treatment. And I have no conflicts of interest to disclose. It is estimated that the lifetime prevalence of asthma in children in Saudi Arabia is anywhere from 8 to 25%. And so therefore it is a common and chronic illness that is dealt with in pediatric emergency medicine. And I know in my own practice in the United States, it is quite relevant since who have acute asthma care in the emergency department. And so So as the slides are coming up, I can share with you the objectives of my lecture are, here we go, to define currently recommended asthma treatment for children with an acute exacerbation, to describe the potential benefits of non-standard treatment for emergent asthma, and then to identify areas of where emergency care for pediatric asthma can be improved. And so as the slides are coming up, I want to share a case with you. So let's consider this case of this boy. He is 7 years old and he comes to you by ambulance. He has a history of eczema and mild persistent asthma. He's had frequent cough, congestion, and fever for the past few days. And today he began having difficulty breathing characterized by shortness of breath, chest tightness, and wheezing when breathing. And the parents noticed that he was drowsy and tachypnic with significant indrawing of the chest or retractions. And he was given one short-acting beta agonist treatment before arrival of EMS. And then en route to the hospital, they continued giving short-acting beta agonist. And so he has the classic signs and symptoms of asthma in children: chest tightness, shortness of breath, frequent coughing, wheezing when breathing. And in our setting, the emergency department, pulmonary function testing is not something that is typically feasible to do. And so, typically we rely on these common signs and symptoms to determine and to differentiate, is this asthma or is this something else? And so typically, if we see these common signs and symptoms in a child who's 2 years or older, then we consider that to be an asthma exacerbation as opposed to something else. And in addition, though, sometimes we're seeing these children for the first time that this has happened to them. And so sometimes we have to try a trial of a short-acting beta agonist to see if they're responsive to treatment to determine if that is the diagnosis. So in the emergency department, other things that we can use to determine the diagnosis, however, are other things. So are there comorbidities? So history of atopy, such as eczema or seasonal allergies. Is there a past medical history of having frequent wheezing associated respiratory illnesses in infancy and early childhood prior to diagnosis? I frequently will diagnose asthma for the first time. A parent will say to me, oh, I've used albuterol. My child's had difficulty breathing multiple times in the past. And they'll say, but nobody's ever diagnosed them with asthma. And so I say, well, I'm diagnosing your child with asthma today. And so I think that happens sometimes, is that people have their child taken care of, but no one's labeled them with the diagnosis of asthma, even though they have the classic signs and symptoms. I think other things that are important to consider are family history. So we know that having a significant history of atopy in the family, eczema, seasonal allergies, and asthma go together and are hereditary. And then responsiveness, as I mentioned, to short-acting beta agonists. However, chest x-rays are not something that are necessary in the diagnosis. And so when I'm managing a child that has an asthma exacerbation in the emergency department, typically the only times I'll get a chest x-ray are when I'm suspecting that something else may be going on. So for example, if I think that there might be a concurrent pneumonia happening because they're not responsive to treatment, they have a fever, they have asymmetric breath sounds, or perhaps they're having a complication related to their asthma, such as a pneumothorax. Or in other situations, again, if they're not responsive to the maximum treatment that we can give them, they're still not improving, not showing any signs of improvement, perhaps something else is going on, such as pneumonia or heart failure, or if there's other uncertainty about the diagnosis. So I think it's important, before we talk about treatment, to understand pathophysiology. And so to give a brief recap of the pathophysiology of asthma, allergens and respiratory viruses are the typical triggers for an acute asthma exacerbation. And so when either or both of these things occur, that causes airway edema. It causes mucus and cellular debris to be released into the airway lumen, and also to have bronchospasm. And so this combination of edema, debris, and bronchospasm leads to airway obstruction. And so these pathophysiologic changes are generally reversible, however, with the treatments that we have available to us. And so that's what I'm going to talk about first with respect to what are all the treatments that we have available to us to treat asthma. And so to do this and to talk about it from the state of the art perspective, I think it's important to look at what's currently defined in guidelines. I did find this article by Al Muammari on the Saudi Initiative for Asthma, or SINA. It praises the evidence and makes recommendations for both children and adults in the management of asthma. And so I've reviewed these guidelines and I will comment on them with respect to what I typically do in my practice in the United States. Also, I think when assessing a child with asthma, it is helpful to use an objective validated scoring tool to help guide management and to help communicate to other healthcare professionals about the severity of the exacerbation that you're treating. And so the Pediatric Respiratory Assessment Measure, or the PRAM score, is one tool that can help determine acute asthma severity in children. So it's been validated in children 2 to 17 years old, and it is based on a 12-point scoring a scale that incorporates suprasternal retractions, scalene retractions, air entry, wheezing, and oxygen saturation, as you can see here. What we know from the validation of the score is that if you have a low score of 1 to 3, that your risk of hospital admission is less than 10%. If you have a score of 4 to 7, that risk goes up to 10 to 50%. And if you have a much higher score of 8 to 12 on the extreme end, that your risk of hospitalization is greater than 50% in the setting of an acute asthma exacerbation. So reviewing the published guidelines, all of these medications are listed. And so rather than go through the treatment algorithm based on the PRAM score, what I'm going to do is discuss each of these medications with respect to the severity of the asthma exacerbation itself, and then talk about some nuances in management with respect to them. So starting first with mild to moderate asthma exacerbations, I think the mainstay of treatment is the use of a short-acting beta agonist like albuterol or salbutamol, using ipratropium bromide, and using some sort of systemic steroid. So when it comes to albuterol, although the use of a meter dose inhaler and a nebulizer, they're equally effective, from a practical point of view in the emergency department, I find that it's helpful to place the child on a nebulizer because you can mix in the ipratropium with it, and it's easy for our respiratory therapist or our nurse to then step away from the patient instead of having to assist them with the meter dose inhaler with a spacer and having to use 2 different inhalers to administer the treatment. And so from a practical point of view, for the emergent management, we typically in our practice use a nebulizer because it's easy to then step away, see other patients, and then come back and see responsiveness to treatment. And typically, even in the young child, we will start on with a dose of 5 milligrams for the albuterol and for ipratropium 0.5 milligrams. And we'll do this back to back every 10 to 15 minutes, up to 3 times. Most of the patients that we see in our practice, because the more minor patients get triaged to our on-site urgent care, when we see a child with acute asthma exacerbation, it's usually at least at moderate level, if not severe. And so in addition, I think it's important to also consider the use of systemic steroids. Now, although steroids don't take an immediate effect, there is good evidence that the early administration of steroids is impactful on decreasing risk of hospitalization and shortening time for treatment, especially when it's given at emergency department triage. And so that is our practice. When a child presents to the emergency department with an asthma exacerbation, they're given the dexamethasone upon arrival. We had previously used prednisolone, which is a 5-day course, and between prednisolone, prednisone, or dexamethasone, they're equally efficacious. But because dexamethasone can be administered over 2 days, our practice is to administer that first dose at triage, and then if the patient ends up getting discharged, we will discharge them with that second dose so that they don't have to go to a pharmacy to even fill it. And that helps to enhance compliance, because we know that many of our patients, when we prescribe them something, they often fail to fill that prescription for various reasons at a pharmacy. And so having the ability to dispense the medication upon discharge has been helpful to enhance compliance and prevent emergency department recidivism. So for that reason, we did switch to dexamethasone. And a little bit later, I'll talk about the use of dexamethasone even in the pre-hospital setting. So when it comes to moderate to severe asthma exacerbations, if a patient has required 3 breathing treatments of albuterol mixed with ipratropium, then if there are ongoing signs of bronchoconstriction, then the next step for us would be to give continuous albuterol and to use IV magnesium. Now, in terms of the amount of IV magnesium, there are different studies that range from 25 to 75 milligrams per kilogram. Typically, most studies quote a dose of 40 to 50 milligrams per kilogram given intravenously over 20 minutes. One downside of this is because magnesium can relax the smooth muscle, is that you can get hypotension. And as well with the continuous use of albuterol as a beta-2 agonist, it relaxes the smooth muscle. And so you run the risk of hypotension with both treatments and having a widening pulse pressure. So it is important at this point, if you are giving continuous albuterol, giving magnesium, to give IV fluid boluses and or start the patient on at least maintenance fluid to prevent hypotension and that widening pulse pressure. And then when it comes to the severe asthma exacerbation, parenteral beta agonists such as intramuscular epinephrine or terbutaline are rarely needed, but in these severe cases, they can be helpful. And so epinephrine given IM may be more beneficial than terbutaline in severe cases. There's limited evidence, but I'd say in situations, especially with there might be a concurrent anaphylaxis as a trigger, giving intramuscular epinephrine can be helpful in that situation. I found that when I've gotten to this point of needing to give something for a severe asthma exacerbation, this patient may have already been on continuous albuterol for so many hours, then the benefit of terbutaline at that point is limited. We know that from the evidence that terbutaline, if given early, can be beneficial, but at this point, if beta receptors are saturated from the use of continuous albuterol, then the benefit of then adding terbutaline at that point may be limited. And in situations where respiratory failure exists, non-invasive positive pressure can be a good strategy, such as BiPAP, before proceeding to something that could be even riskier with this disease process, like intubation, which with the barotrauma can lead to pneumothorax or just difficulty in ventilation. So in terms of non-standard treatment, there is insufficient evidence to support the routine use of things that I've noted here, like Heliox, ketamine, leukotriene receptor antagonists for acute asthma exacerbations. However, there may be unique situations where you may want to use them. So Heliox, it's something I would say I rarely use, but mixture of helium and oxygen, when co-administered with a beta agonist, to those that don't respond to conventional therapy may be helpful. The theory is that that lower gas density of helium results in decreased flow resistance to allow more oxygenation at the alveolar level, but it shouldn't be used in patients that are requiring more than 40% oxygen. In terms of ketamine, ketamine has, as you may know, has bronchodilator properties. When I'm going to the point of placing a patient, escalating even beyond BiPAP and having to intubate the asthmatic patient, my typical go-to agent in terms of for use of rapid sequence intubation is to use ketamine for that reason. And in terms of leukotriene receptor antagonists, however, it's not supported in the existing literature for either urgent or emergent acute asthma exacerbations. Can be helpful for preventative treatment, however. So I think there are opportunities for improvement, however, in what we do. So I've described what the standard treatment for asthma is, but I do think there are some gaps in how we deal with asthma along the emergency care continuum, and also how we deal with asthma asthma post-discharge and the risk of asthma that can occur with comorbid conditions such as influenza. So I'm going to touch on each of these over the next few minutes. So in terms of the emergency care continuum, I think you've heard from each of my colleagues, Dr. Arbach, Dr. Gaucher-Hill, about the importance of that concept of the emergency care continuum. We know that care does not begin in the emergency department when it comes to emergency care. It occurs well before that in the out-of-hospital setting. And so this is true even for asthma. And so when it comes to that, I'm going to share with you what we have done in my own city, in the city of Houston, to help improve asthma care for children. So back in 2012, we reviewed the evidence to create an evidence-based guideline for asthma management in the pre-hospital setting for children. And so we implemented these guidelines that you see here of what to do and what not to do. And so you'll see on here many of the things that I already said: use of albuterol, use of ipratropium, use of steroids, use of magnesium, and use of intramuscular epinephrine in severe cases. So prior to this, our treatment mainstay in the EMS setting in our city was just to use albuterol and just to give intramuscular or intravenous methylprednisolone, and that's it. There was no use of ipratropium, there was nothing else. And so we implemented changes, and one of the main changes that we made was implementation of oral steroids on the ambulance. So before, we only used intramuscular and intravenous methylprednisolone. Well, as you may know, starting an IV on a child in the pre-hospital setting can be challenging for a paramedic who mostly takes care of adults. And then it also creates a barrier to administration of the medication. So to be able to provide them with an alternative route that is much easier to administer in terms of the oral route was helpful. And so I'm going to show you some of that data. So we implemented the use of oral dexamethasone on the ambulance back in 2014. Eventually, when we were able to implement the dexamethasone piece to the guideline. And this has actually been incorporated into national guidelines that we have for EMS through the national model EMS clinical guidelines that we have in the United States. So we actually studied this. We studied this in about 482 patients before and after. And what we saw in this study that we did is that the median total hospital time after the protocol changed decreased. We also saw that more steroids were given after implementation of the guideline. It increased from just modestly from 11 to 18%. But what we saw is that the paramedics started to exclusively use the oral route. And so really in talking to the paramedics, this was a big shift in being able to give them the opportunity to give oral steroids by another route. And so, but what did we see in terms of more long-term outcome that led into the hospitals? That their total hospital time after the protocol change decreased by about 1.6 hours. Total care time, defined as time from ambulance arrival to hospital discharge, also decreased by about 1.4 hours. Patients were also less likely to be admitted to the hospital. And with the more severe exacerbations, they were less likely to be admitted to critical care unit. And so, although this was a single site study before and after trial, what we saw was some promising results that others are planning to study in the United States as well in terms of implementation of oral glucocorticoids on ambulances for the pediatric patient. I think another opportunity for improvement is how are we preventing emergency department recidivism? Many of the patients that we see in the emergency department have poorly controlled asthma, and yet sometimes we fail to ask them about the chronicity of their symptoms. And so there is good evidence that shows that discharging our pediatric patients who have chronic asthma symptoms on an inhaled corticosteroid does prevent bounce back visits or ED recidivism. And so it's important to screen those patients to find out how many asthma exacerbations have they had in the past year. Do they have frequent nighttime cough? And so one quality improvement measure that we have implemented in our own emergency department is really focusing on identification of the chronicity of a child's symptoms and then discharging them on with a prescription for an inhaled corticosteroid. Another thing that we've implemented as a quality improvement measure is integrating influenza vaccination orders in our asthma order set, because we know that children who have who have asthma and then get influenza have worse outcomes than those that do not have asthma. And so I think it's a great opportunity. Many of the patients that we see often don't have an influenza vaccine when they come in for their asthma exacerbation. And so being able to screen them for their vaccination status and then ask them, would you be willing to get the influenza vaccine during your emergency department visit? And so I frequently have given the flu vaccine to asthmatic patients in that situation. And so that can be helpful as well. And then I think the last thing in terms of opportunity for improvement is what sort of anticipatory guidance are we giving to our patients in terms of discharge planning? And so we are try to be very good about sending every patient home with an asthma action plan so that they know, okay, under normal conditions, what am I supposed to do? And so if we're sending somebody home on an inhaled corticosteroid, I'm supposed to take that medicine twice a day to prevent symptoms of chronic asthma. If I'm starting to have cough congestion and signs of attack of wheezing, shortness of breath, to use albuterol as needed. And then in situations where it may be more severe, to then escalate and then even seek care. So in summary, I think that there are several things that we can do to improve how we treat pediatric asthma exacerbations in the emergency department setting. Timely initiation of proven asthma therapy is essential. I think it's also important, though, as I mentioned, to consider the whole continuum of emergency care and how can you improve that care before the child even gets to your emergency department. And then finally, providing clear discharge recommendations upon discharge, and then using those opportunities to discharge them with an inhaled corticosteroid if needed, and to ensure that they're vaccinated against influenza is also important. Thank you.
There is no question right now until they prepare the question. Oh, there is a question. Till we get the question, actually, we've seen quite significant jump of cases of COVID for Maryam. At the beginning, actually, we were like enjoying in the pediatric. We see our colleagues in the adult, they are bombarded with a lot of cases at the beginning of 20. Then actually in January, February 22, we are actually the one who suffered more than the adult. And we see quite actually, we will be like overwhelmed, at least in our hospital. I'm sure our colleagues also can share that. A lot of cases, thanks God, most of them actually were mild cases. The only things we were afraid that our hospital actually were dealing with the transplant patients, organ transplant, oncology patients, and we're actually so scared that we're gonna actually fill up this hospital. But thanks God, most of those actually who got COVID-19, especially the Omicron, those who are like organ transplant or oncology, been admitted just for like more of like safety, but rarely actually they needed ICU, or rarely they ended by very devastated course. What we have seen also, we've seen quite significant number of bulbar conjunctivitis in those patients will be able to say this is COVID from just looking at the eye, without even just like testing them, but definitely we were testing all of them. And it's just like non-suppurative bulbar conjunctivitis was common, definitely GI symptoms also, they are almost, and the quite variant of the temperature also. Some of them, they are like low grade fever, some of them up to 41 plus. So it's actually was like, you cannot say this is like a specific sign and symptom for this COVID. And definitely the other viruses have almost been lost in between. And we're not, some of kids also we have seen like COVID plus 2 other viruses at the same time, which is, I mean, the majority or the seriously maybe for the other virus rather than COVID. We've seen neonates, a lot of neonates with like 2 weeks, 1 week old with COVID, and most of them, they went home without any major problem. Questions?
My first question would be, so thank you for very history for this. That was kind of really inspiring. So thank you for establishing this. This won't be complete stand. And what is the future for our care capabilities? We know where the organization see a lot of regard to that mindful platform, I think vaccine will develop. And my question is, what is your messages to those who will vaccine those also? And for that, my question is, we have seen the impact of COVID-19 directly and indirectly. And my question would be, how did COVID-19 impact care? We have seen delayed access to care. We have seen lower case numbers that is consolidated but obviously massive to healthcare. And last question is about asthma. In Saudi, we have big fear of public any systemic corticosteroid. And I do believe that it's on its own might be really helpful because it's 1 or 2 doses. Can you expand on that? And if you don't mind, enlighten us, what is the role of the listener and welcome to Saudi. I hope you enjoy the stay and try something. So we can try to set up this. So thank you for this. Vision to match the resources. So some interventions. Training people next to the system and trying to make the system. So if possible, that's a standardized approach. Trying to standardize that. Unpredictable, but it's predictable. So I think as I mentioned before, hence the system, naturally repair the system. So operative procedures, does not have blood products, how is the synthase? Thus, have an opportunity for
So then what we found was that we often had delayed diagnoses and complications and things. I'm talking mainly about adults, but it also could such as asthma, sickle cell. In addition, the Omicron saw is everything got used to coming back to the very long disease. So we had to message again. The other thing that was a challenge was testing. Testing. They had the same problem. Certainly had issues with access to testing, even though tests that were being done states. And so we again had to message. And some of the hospitals actually said, we're not going to just go, we see you, but just come for the test. We have to go to the testing centers. And I'll let my colleagues comment further. And those were the challenges that one of the lessons from COVID need to message that this is a dynamic, very much uncertainty. Uncertainty and size becomes change what our findings are, and that's okay. That's amazing. So, in my mind, messaging change all the time, mistrust in the public. So make up to do.
Just a quick comment. Pediatric office. I heard that you will see sick patients. I think that access to care primary care center as well as with the textbooks, you're able to evidence.
And I think because we all work at different centers, all some perspective on the challenge. I think in the beginning for us, we had challenges with the even to the point that our perhaps were wrong and only allowed to use them for specific types of as the healthcare workforce spoke up. That quickly went away, but fortunately, I think those first weeks there was this reluctance, this fear. And so our volumes were down significantly. But we did have similar challenges in access. We had to, in the first couple of weeks, we had to have the whole from infectious disease. That quickly went away after a couple of weeks. Small. But then really, I think the message today. What is the risk of COVID? Is COVID different than influenza? Yes, it is. And there was a lot of misinformation. Yeah, it's a challenge for us. I think first year, steroids and some others, and the opposite extreme. In some ways, unfortunately, there was a mistrust because set expectations. This is science. Science, you get evidence and have to adapt and change your recommendations. And I think that was missed in our messaging on a national level at least. And so I think there was a lot of mistrust.
Okay.
I'll go ahead and answer your question.
Any more questions? We got, I think, one question over here.
Sure.
And our colleague anesthesiologist. We prefer, especially as a medication for the patient, still prefer ketamine. And also we like ketamine for some procedures. But still they are negotiated with us, and this is kind of called raised intracranial issue. Really, in many pediatric resources, in BARS 2016, and many also other pediatric, I said no more, there will no more cause raised intracranial issue. So please, I need your final opinion on this. Thank you for that question. So, I think that a hot topic in the United States is this concept of implementation. Now, it can take many years, sometimes up to 15 years of practice. I would say that what I recognize in pediatric emergency medicine is that deep implementation, taking something out of practice, probably takes more 25%. So much more challenging to change habits. I would say that one of the opportunities that we've had to prepare is through our trauma simulation program, through these cases, discussions and evidence-based reviews with our trauma and anesthesia colleagues, and come up with some guidelines and practices. But I think the guidelines and practices sometimes are not
believe that, and allowing people to have that discussion and talk it out. I would say that that was really ingrained in many of us, that ketamine was the wrong answer on the test. So it's hard to undo that. But I would say that in our institution and really throughout North America, there still are some individuals that bring that up. Oh, you use ketamine, this patient might have neurotrauma, you can't use that medication. And not everyone has read the evidence. Some people might interpret the evidence differently, but my short answer would be that old habits are hard to break, and that probably requires some interactions beyond just emails, and maybe a simulation or an experience where you get to go through that case, but then have a place where you can discuss the care that might be helpful. But I don't know about the two of your institutions, but ketamine is really our go-to agent for this population.
Thank you.
I
Any more
would just-
question?
Oh,
We'll take the last question, then we'll start our next session. Yeah. For asthma, over there.
Oh, I can respond to the prior question about asthma. So there were two questions. There was the question about the steroids and question about the epinephrine. For the epinephrine, really, I would say the evidence is limited relative to the other treatments that I talked about, the short-acting beta agonist, the ipratropium, the steroids, the magnesium. The evidence is limited for the use of epinephrine, and really in guidelines and limited studies that I've seen, there may be potential benefit in the fact that it can reduce airway edema and bronchospasm And so if you've got to the point of respiratory failure where you are considering BiPAP or intubation, that is when only I use it. And I would say that it's quite rare that I use it, but I would say in the past month, because we do see some severe asthmatics at my institution, I've used it twice in the past month. But most of the patients I see are not of that severity. In terms of the steroids, I think they're again, this comes down to expectations and misinformation. I think we know that if you use steroids for a short period of time, that there aren't long-term complications, and I think that that's important to explore that with patients when they express hesitancy. If they say, "Oh, I don't want a steroid," well, can you tell me what your concern is about that? And then that's when you get deeper to the issue of perceived fears that you can help dispel myths with the patient about. So, but I do think that the benefit of using the dexamethasone, because it's just 2 days rather than 5, is you can say, well, you're only using it for a short course. And so if you're concerned about long-term complications, yes, it's a shorter duration. But even 5 days of prednisolone is safe. And so I think that really getting at the heart of what are people's fears and concerns is important in our care when we take care of patients, when people are reluctant to follow recommendations that we make. There's usually some underlying concern there that we need to explore.
Last question. Oh, you wanna comment?
Yeah, the only other time we use epinephrine is if there's diagnostic uncertainty with anaphylaxis, and I'm sure you did too. And so if somebody comes in and it's possible they were exposed to an allergen and they're wheezing, someone that we might consider.
I actually want to make one more.
I think they are not hearing you.
Hello? Okay. Oh, so I was saying that the patient in respiratory failure, that are not having any albuterol hit their bronchi because they're not breathing deeply enough, or they have such a severe state, that intramuscular epinephrine has the benefit of actually providing some beta effect via the vasculature. So I do think that in that really severe patient that comes into triage and crashes, that's the patient that I think epinephrine really has become my practice for. And I haven't seen evidence in that population. Frankly, I don't expect to. I think it's a pretty small subset.
I think we have one more question and 3 more questions from the online attendee. So because they already listening to us, so, and I think they have, I don't know who's, yeah, he will give the question. So the last one from the audience here.
My name is Badr Al-Fard, pediatric specialist. Thank you for the amazing presentation. And it was amazing and very informative. I have 2 questions about asthma. The first one, what is the role of 6 doses of salbutamol instead of 3? There is a theory that says the first doses, due to the bronchoconstriction, it will be not effective. How about repeating those? Is there any benefit, or is it false belief? The second question, working in remote areas, I work in the southern region. There is this phobia of inhalers, that the patient, if he starts to use inhalers, he will not discontinue for a lifelong. How can we overcome this issue? Thank you.
So let me make sure I understood your first question. There's a belief that if you use more albuterol, that it won't be effective. Is that what you were saying?
The first doses, due to the bronchoconstriction, it's like it's not gonna reach, or beneficial.
Okay. Yeah, I think this also touches on what Dr. Auerbach was mentioning with the epinephrine, that yeah, if you have such severe bronchoconstriction that it's possible that in those first doses that you're giving, because the airway is not relaxed enough, that the medication may not be able to get as far down into the airway to be effective. And so this is where it's important to just reassess your patient. So after you've given a short-acting beta agonist, what's the response? And so some patients will respond to just one treatment, two treatments, but if you find that they still have diminished air entry or they have prolonged expiratory phase, it is necessary to repeat and to further relax that smooth muscle to allow the medication in. And so sometimes many patients that we see, we have to give them hours of treatment before that bronchoconstriction resolves. And in terms of you're mentioning phobia regarding use of inhaler. So I think this, again, relates to what is the underlying concern. So, if you're using a short-acting beta agonist, that is a rescue medicine, and so that it doesn't mean that you'll have to be on it forever. Some people, their asthma symptoms go away as they get older, and a lot of times it depends on environmental triggers and things like that. So in terms of inhaled corticosteroids, even that, just because you may be prescribing that to prevent chronic asthma symptoms, doesn't mean that somebody needs to stay on it for years. Sometimes being on it just at certain times of the year when they're more prone to have those chronic symptoms with weather changes or things like that, it might be useful in those situations. And so I think that's where also having long-term follow-up with their primary care physician is important to help monitor that, because for us in emergency medicine, we don't have that long-term follow-up and that benefit of a relationship to explore those deeper concerns and to monitor and to reassess for modification of long-term management. But I do think that there isn't, just because you prescribe an inhaler doesn't mean that you're committing a child to be on it for their lifetime. No, and so I think that's a myth that you can try to dispel by educating the patients that you see.
Thank you. And I will take that question of the online attendee, and representative will ask the question. I think he has to read it from the laptop, so sorry.
Oh, the first question would be Mr. Sayed. He's asking, in the case of asthma worsening due to suspected heart injury, is there a role for an inhaled beta agonist?
Asthma worsening in what situation?
Due to suspected heart injury, cardiac injury.
Cardiac injury. Well, I would say that would be, in pediatrics, that would be quite rare. We do not, in pediatric emergency medicine, to see concurrent cardiac disease and asthma is very uncommon. But again, if there are situations where children have congenital heart disease and they have asthma, you have to treat their asthma. And I didn't mention this earlier in terms of modifications to treatment. I would say the only modification to treatment that we sometimes make is if someone has a known congenital heart disease and we're giving a beta agonist. In those situations, our cardiologists have asked that we give levoalbuterol instead of albuterol. There's controversy over whether that really changes an outcome. We do it, I think, more to be collegial and accommodate that request. But again, if someone has congenital heart disease and they have asthma, you have to treat the asthma if they're having an asthma exacerbation.
Okay.
Yeah.
The next question.
Okay, another question. From Ms. Dr. Rehab Al-Jawad, after discharging patients from the ER with bronchial asthma that have been treated with inhaled corticosteroids, do you prefer referring them to a general pediatrician for follow-up, or do you prefer more subspecialized care? And after how long should the referral be?
So I base that on their severity. So if it's a child that has chronic symptoms but has not been intubated, has not been frequently admitted to the hospital, I think in those situations, with the way our healthcare structure works in the United States, it would be very appropriate for them to follow up with their general pediatrician to have them monitor the frequency of use of that medication and if other medications should be used. For the patient who's had more what we call life-threatening asthma, where they've been intubated, been in the intensive care unit, or just had multiple admissions for asthma, in those situations where it's more complex, we will refer them to a pulmonologist in our healthcare system.
Thank you very much. We are now finishing the first sessions. Next session will just start. May I ask you just to go back? Thank you.
So because of time, so we'll second session. So it's a pleasure now to introduce the next speaker, Dr. Manoj Mittal. So Dr. Mittal, he's a professor in clinical pediatric at Children's Hospital of Philadelphia and University of Pennsylvania. He will talk about approach to respiratory failure in children. So welcome, Dr. Mittal. Mic is yours.
Hey, Assalamu alaikum. كيف حالكم? Can you hear me? So I'm happy to be back in the Kingdom of Saudi Arabia, back because I'm glad to report that I actually began my medical career in Saudi Arabia. Soon after graduation, I was working for Ministry of Health in Asir province, in the lovely mountain town of Al Namas, if anybody is from there, and a valley village called Behban, where I first encountered sail, or what's called flash flooding. So happy to come back here and give back to the community a little bit. All right, if we can have the slides. Can we have my slides? So we're going to talk about approach to respiratory failure in children today. This is a big topic, so I'm going to, as the title implies, I'm going to be talking about the approach. So I will not go into details about anything. Okay, so I have no financial relationships to disclose. I hope that following my presentation, you would be able to understand the definition, the pathophysiology and signs of respiratory failure, recognize and manage respiratory failure, and outline various techniques of providing respiratory support. So what is respiratory failure? Any infant or child who presents in acute respiratory distress with either acute hypoxia requiring supplemental oxygen to maintain saturation more than 92%, or acute hypercarbia with PCO2 of more than 50 is basically defined as having acute respiratory failure. What are the main causes? Upper airway obstruction like croup, epiglottitis, lower airway obstruction like bronchiolitis, status asthmaticus, lung tissue damage, parenchymal disease, that is pneumonia, pulmonary edema, or disordered control of breathing, that is hypoventilation, as happens following seizures, coma, muscle weakness. The key in respiratory failure management is early recognition. So watch for any signs of cyanosis on clinical examination, hypoxia. If the patient is on monitor, you want to watch for falling saturation of oxygen, increased work of breathing, and the worst case, developing apnea. So this slide is important because it shows us how a child is different from an adult, and within the child, the various patterns. So if you see in an adult, for the saturation, if suppose you stop the adult from breathing, it would take almost 10 minutes for a regular adult to come to a saturation of 0. Whereas in a normal 10-kilogram child, a 1-year-old child, this would happen within 4 minutes. And the other key thing is for the saturation to drop from 100% to 95%, it will take almost 2-3 minutes. So the majority of the time till the full saturation drop happens for the saturation to drop from 100 to 95%. And after that, you can see the fall is very steep. Oops. All right, so this slide demonstrates the same thing. So time to 95%, you can see in 3 months to 1 year, it's pretty much the same, 2 minutes, but then from 95 to 95 to 90%, 8 seconds. So again, the importance of early recognition. Remember, respiratory arrest is the most common cause of cardiac arrest in children. In children, heart disease is very uncommon. So often the predisposing factor is respiratory arrest. And amongst patients with cardiopulmonary arrest, outcomes are worst for patients who develop this because of respiratory deterioration. This is the pediatric assessment triangle. Anytime we get a sick patient, we should look at the appearance, the work of breathing, circulation, and manage accordingly. In terms of support, airway, so any child who comes with respiratory distress or concern for respiratory failure, provide 100% oxygen. Allow the child to assume a position of comfort. If needed, open the airway, clear the airway as needed, and insertion of an artificial airway as needed. You want to put the patient on monitors, monitor oxygenation, monitor ventilation by end-tidal CO2 if that is available. More and more, we can do it even in patients who are not intubated. And then administer medications as needed. For example, if he has asthma, administer albuterol. If he has croup, administer epinephrine. And then if the preceding measures fail, then and the patient is getting into impending respiratory failure, then that becomes an indication for positive pressure ventilation, which would be started with bag valve mask or flow inflating device, like Anderson valves, to oxygenate and improve ventilation, and then endotracheal intubation. Now, what I'm going to be talking about much more in this lecture is about non-invasive ventilation. So selected patients with respiratory failure can often be managed with techniques that are considered under non-invasive ventilation before proceeding to invasive ventilation. These include CPAP, BiPAP, and then a related modality that many of the speakers have previously mentioned, high-frequency nasal cannula oxygen. What are the advantages of non-invasive ventilation? It has the ability to reduce work of breathing and improve gas exchange while avoiding the risks and complications related to ET tube. Remember, for intubation, you have to sedate the patient, you have to paralyze the patient so that the patient is apneic and not breathing on his own. So if you have difficulty intubating him, the patient can have complications, the patient may die. During the intubation, the tube can shift out, become displaced again, all the associated complications. So if we can avoid intubation and still provide help with the ventilation, that is very useful. Of course, we have to remember that non-invasive ventilation is not suited for patients in cardiopulmonary arrest, in patients who have actively impaired, acutely impaired mental status or the deteriorating mental status, those with high aspiration risk and need for airway protection. Back valve ventilation, just in brief, you want to do the face mask sizing. Remember, in children, that is the disadvantage. You can't just use a standard face mask. There are two kinds of ventilation bags, self-inflating and flow inflating. We have to become familiar with whatever modality we have in our emergency department. The bag size is 500 ml for infants and young children and 1000 ml for older children and adolescents. You have the 1 or 2% technique. You want a tight mask seal aiming for chest rise. That is the bottom line. And this is a good slide because remember, sometimes you wonder where to put the towel roll under the shoulder, under the head, here, there. So the key thing is if you align the ear to the sternal notch, as long as you get that right, that is the position that you want for bag valve mask ventilation, intubation for any modality. Airway adjuncts are especially useful if there is concern for upper airway obstruction and if you're finding difficulty with ventilation with bag valve mask. You can use oropharyngeal airway if the patient is unconscious, or nasopharyngeal airway for conscious or semi-conscious patients. This is especially appropriate in patients who are post-ictal and may have mild hypoxia related to hypoventilation. Putting in a nasopharyngeal airway often improves the airway and brings the situation under control. Endotracheal intubation would be indicated if the child is unable to maintain effective airway oxygenation or ventilation despite the interventions that we discussed earlier. So again, like Mark had talked about, it's useful to divide intubation into pre-procedure preparation, which involves mainly hyperoxygenation, preparing equipment, the procedure itself, inserting the ET tube, and then post-procedure, confirming the tube position and securing the tube. Medications, just in brief, Vagolitec, like again, Mark implied, the use of atropine is debatable and more we are giving up on it. Sedative, there are various sedatives, ketamine, etomidate. Those two are pretty much applicable across the board. Etomidate use is sort of not considered of choice in patients with sepsis. Paralytic neuromuscular blockade, most of the time in children, we prefer to use non-depolarizing agents like vecuronium, atricuronium. I just want to introduce this, it's been talked about CMAC video laryngoscope. That's the preferred laryngoscope in RED. It's a wonderful laryngoscope. We like it because you can use pretty much similar to, the blades are similar to what we use already, Macintosh blades or Miller blades, and you can see it on the screen. So there's a mentor or supervisor can see actually how the tube is going in. You don't have to stand behind the shoulder. You can see it on the image on the monitor. One thing that hasn't been discussed so far too much is the use of laryngeal mask airways. So why do we need laryngeal mask airways? So the guidance is that when back valve ventilation is unsuccessful and when ET tube is not possible for whatever reason, the LMA is the sort of airway rescue modality of choice. Not cricothyrotomy directly, but LMA. So this is what it looks like. Again, unfortunately, in children, as compared to adults, you have to size them. So their sizing is a little bit sort of less than ideally intuitive. I'm giving you some pictures. So this is the LMA sizing. So you need to be familiar with them and have them available along with your intubation supplies. It has to be available, if not outside the cart, at least the cart has to be available next to you when you are intubating any patient. Now we come to the non-invasive ventilation modalities. So one of the situations where we use high flow nasal cannula oxygen is in bronchiolitis. And as you're aware, bronchiolitis is the clinical practice guideline that recently came up, has recommendations about mainly what not to use in bronchiolitis, right? We shouldn't use albuterol, we shouldn't use epinephrine, we shouldn't use steroids. What do we do? Nasal suction as needed, that's it. And then if the patient needs further support, that is when, our role comes in. If the patient is hypoxic, not working too hard, then we can use regular 1 to 2 liters per minute nasal cannula oxygen. But as we see, most of the time, the problem with young infants with bronchiolitis is their increased work of breathing. And to help with that is high flow nasal cannula oxygen. So, we have by now extensive NICU, PICU, PEDS floor literature on safe use of high flow nasal cannula oxygen. These are the two main systems in use in the US, Vapotherm and Fisher-Paykel. So what is high flow nasal cannula oxygen? This is a good mnemonic that tells you. So this is heated and humidified, as against traditional nasal cannula oxygen, which is not heated, which is not humidified. So if you're using it for a prolonged time, heated and humidified gas is more easily tolerated. It matches the inspiratory demands. So 1 to 2 liter in a young infant is enough if they are breathing at tidal volume. But if they are breathing fast, they have a lot of inspiratory demand, then that 1 to 2 liter will be diluted and the FiO2 would be very low. So if you can give them high volumes, then that can meet their inspiratory demand. It increases functional residual capacity, likely via delivery of PEEP. So that is how one of the touted mechanisms of action. It's a much easier system than for CPAP and BiPAP. All you need is a little nasal cannula, so it's not heavy, it's very convenient. Patient can be fed along with using HFNC and wash out of dead space. So as you can see, on the left part of the graph, you can see the 1 liter per minute where the partial pressure is about 0, but if you use 7 liters per minute or high flow nasal cannula oxygen, your partial pressure of basically the PEEP increases. And in terms of esophageal pressure, it reduces pressure swings, and that contributes to reducing the work of breathing. How much flow is enough? In infants, we tend to use 1.5 to 2 liters per kg per minute. We would often begin with 1.5 liter per kg per minute. And if there isn't a significant good response, then we would go up to a max of 2 liters per kg per minute. So bottom line, high flow nasal cannula oxygen can be used as a supportive therapy. Remember that it does not have any effect on the disease course or on the length of stay. It mainly reduces symptoms. It reduces the distress, escalation, distress both for the infant as well as for the caregivers, the parents, and even the medical providers. It's safe to be used on inpatient floors, so which is very important. The patient does not have to be transferred to the ICU. And most hospitalized patients who are started on high flow nasal cannula oxygen do not require further escalation. So you can save lots of, especially from community hospitals prior to the use of high flow nasal cannula oxygen, we used to see lots of patients would be transferred to PICUs, but with the use, that transfer rate has gone down. So we would use it if there was no improvement with supportive care or suctioning. We initiate it at 1.5 to 2 liters per kg per minute, up to 20 liters per minute for infants. And another good thing is that once you realize that the infant is breathing well, you don't have to wean it from 20 liters to 15 to 10. You can just stop it, completely discontinue it when improved. The other advantage is, like I mentioned, the infant can continue to feed orally or NG if clinically stable, and it's suitable for use in community hospitals. So this would be an illustrative case. We got a 3-month-old girl with trouble breathing, typical bronchiolitis, diffuse wheeze, crackles, working hard at the breathing, improved with suctioning in the ED care, but had work of breathing enough that she was admitted for observation. On the second day of admission, she had further increased distress, initiated on high flow nasal cannula oxygen, discontinued after 24 hours, went home happy. Hey, my slides are not working again. Okay. The next modality I want to talk about is CPAP, or continuous positive airway pressure. So what are the uses of CPAP? What are the indications for CPAP? Acute hypercarbia or hypoxia for any reason, because remember, CPAP basically increases PEEP. So if you have hypoxia, if you have hypercarbia, in both of those instances, improving PEEP would help. And the clinical indications are bronchiolitis, asthma, hypoventilation related to obesity, or in any patient with pulmonary edema. Basically, you're applying extrinsic PEEP to offset the intrinsic PEEP. The constant airway pressure maintains gas exchange, stents the airway open, increases functional residual capacity, and improves alveolar recruitment. So this is a good slide that shows, that over time in the study, they found that as the use of non-invasive ventilation modalities increased, and this was mainly related to CPAP, the rate of intubation went down. So, lots of cases of intubation can be averted if these modalities are used in time. So bottom line, for bronchiolitis, we use CPAP as a supportive therapy, again, similar to high flow, no effect on disease scores, but it is associated with decreased intubation rates, lower failure in ICU level patients than with HFNC. So often our approach would be, if we had a patient with bronchiolitis with severe work of breathing, first we would use high flow nasal cannula oxygen up to 2 liters per kg per minute. And if the patient did not improve enough for that, then we would go to CPAP, or we would start, I think we would talk about it. Yeah, so we initiated at 5 to 8 centimeters water and then increase in, gradations of 1 to 2 per minute as needed. Close observation is required for patients on CPAP. In our system, we would admit any patient on CPAP to the ICU, and we do not allow PO feeding for these patients. And then the final modality in this triad of modalities is BiPAP. As you can see in BiPAP, you have the PEEP raised as well. And in addition, the peak inspiratory pressure also comes into play because that is also supported. So we are supporting inspiration and expiration both with pressures. So it has the same effects as CPAP, but also helps in inspiration. And the main indication for BiPAP is in patients with severe asthma, as again, the previous speakers pointed out. It does not replace standard therapy. Remember, it will only come into play if the standard therapy has not worked. And the standard therapy, just to recapitulate again, are bronchodilators. If the initial doses don't work, we add continuous albuterol, ipratropium, IV magnesium, steroids, and terbutaline or epinephrine, subcutaneous or IM. The use of BiPAP, again, is very helpful in reducing work of breathing, often in patients with impending respiratory failure. It may require anxiolysis. So in some patients tolerate BiPAP well, but some patients are sort of more anxious because BiPAP involves a bigger circuit, bigger mask, etc. So a mild dose of anxiolysis may be indicated and may be safe in these patients. It becomes contraindicated if the patient becomes obtunded, combative, or the mental status starts failing. That becomes an indication for intubation. Again, we initiate it at moderate settings at approximately 10 by 5 centimeters of water, and then you can gradually tailor it to the response. So this was a recent patient where we used a 13-year-old with severe asthma exacerbation, developed sudden symptoms late at night, marked dyspnea despite maximal treatment. He was initiated on BiPAP 10 by 5. And the other advantage with BiPAP or CPAP is that you can continue using continuous albuterol as well. Our RTs can devise a system so that that can still continue. And he improved over the next 12 hours, and then at that stage was transferred to the floor, avoiding intubation. So to summarize for respiratory failure, the key thing is early recognition, like we said, because remember, it takes time for the saturation to drop from 100 to 95%, but after that, the drop can be precipitous if we've not rectified the cause of that fall in saturation. Infants deteriorate much more quicker than older children and adolescents, so we have to be extremely careful for them. You know, that general fear among adult emergency medicine physicians and even among PEM physicians to worry more about younger infants than for older children is completely legitimate, and respond to that. Rapid assessment and stabilization, consider use of non-invasive ventilation, and then if that is not successful, then going on to bag valve mask, intubation, or LMA. Thank you.
we talked about the picture. Yeah. So we
think someone else is driving here. So thank you, and thank you for the invitation to speak today. We're finishing up a morning talking about critical care, and I'm going to talk about septic shock. But it's a pleasure to be here. This is my first trip to Saudi Arabia, and everyone's been so welcoming. I also understand that we're going to have an interruption, so we may start out talking about septic shock, and we have a welcoming ceremony, and so we will break when the time comes. Are you going to pull the slides back up, or? See if I have control here. My apologies. Are you pulling the slides up, or should I drive from here? Yeah, okay, great.
والسلام على خاتم الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم. والحمد لله القائل في كتابه الكريم: يرفع الله الذين آمنوا منكم والذين أوتوا العلم درجات والله بما تعملون خبير. Your Excellency, Dr. Majid Al-Fayyad, Chief Executive Officer, General Organization of the Faisal Specialist Hospital and Research Center. Your Excellency, Dr. Muhammad Al-Hayaza, President of Al-Faisal University, distinguished international, national, and regional speakers, guests and colleagues, all attendees on site and online, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh, and good morning. I'm Khalid Shami, and it's my pleasure to welcome you this morning to the opening ceremony of the 7th International Conference of Pediatric Emergency Medicine 2022, which is organized by the Department of Emergency Medicine in collaboration with the American Academy of Pediatric and the Academic and Training Affairs Department, King Faisal Specialist Hospital and Research Center, as well as Al-Faisal University, our host of this event. We wish all our participants a fruitful and enjoyable conference. Without delay, ladies and gentlemen, Your Excellencies, I would like to call Dr. Muhammad Al-Fifi, Chairman of the Organizing Committee, for his welcome address. Please, Dr.
السلام عليكم ورحمة الله وبركاته. His Excellency Dr. Majid Al-Fayyad, CEO of King Faisal Specialist Hospital and Research Center. His Excellency Professor Al-Hayaza, President of Al-Faisal University. Professor Al-Qattan, Professor Marian, distinguished speakers and guests. Ladies and gentlemen, I would like to welcome you all to our 7th International Conference in Pediatric Emergency Medicine 2022. Thank you all for coming. This conference is in collaboration with American Academy of Pediatrics, Al-Faisal University, and Emergency Department at King Faisal Specialist Hospital and Research Center. 2 years ago, at the same time, as you are all aware, we had a global attack of COVID-19. It was an unpleasant experience. With this pandemic, the whole world suffered difficulties to cope with this health crisis. All conferences and meetings were canceled as precautionary measures since the curfew was announced like other countries. As part of these measures, our last conference, the 6th one, was at the same time 2 years ago. And it was during the surge of this pandemic. Nonetheless, during also these difficulties, we decided to continue ahead and do our conference with the help of our colleagues in the department and with the support of our administration. And we were the only conference in the region to broadcast online. Even our colleagues from American Academy of Pediatrics, they request to have the material of this conference to be broadcasted all over the United States to all the members of American Academy of Pediatrics. And this was a great achievement for us and for our colleagues from American Academy of Pediatrics. Today, as you know, we are joined by distinguished speakers, educators, and leaders in the field of pediatric emergency medicine from USA and nationally from Saudi Arabia. The organizing and scientific committee have prepared a program that includes lectures, workshop, which is very interesting topics for the pediatric emergency staff working in the emergency department and dealing with sick pediatric patients presented in the emergency department. As most of you are aware that pediatric emergency medicine, it's a unique specialty. and needing a highly specialized critical care provided by a highly qualified pediatric emergency physician, and need an update on the current clinical evidence, which is vital to all healthcare providers. This conference objectives are to provide participants with an up-to-date review of the most recent clinically relevant developments in research, therapy, and management of pediatric patients presented to the emergency department. Our Prophet Muhammad said, "He who doesn't thank people does not thank Allah." I would like to thank our colleague. First, I will start with our department, emergency department, those who support me for preparation of this conference. Also academic affairs, chaired by Professor Shinefi, who was give us unlimited support. Dr. Al-Shihri, Dr. Al-Ubaid, Ms. Niveen. Also, I would like to thank Al Faisal University, headed by Professor Al-Hayaza, Professor Kattan, and not to forget the facility manager, Engineer Malik, and the safety and also director, Mr. Musa Al-Malki. I hope I didn't forget anyone. Also, Ms. Safiya from Public Relations, who helped us and give us a tour for our international speaker throughout the university. And finally, I would like to thank you all for joining us in this conference, and I wish you an interesting and beneficial program. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Dr. Muhammad Al-Faifi. Your Excellencies, ladies and gentlemen, I would like now to call Ms. Dr. Marian Gush-Hill, Medical Director of Los Angeles County EMS Agency, to give the welcome speech and address for the American Academy of Pediatrics.
Thank you so much. Again, what a pleasure to be here. I want to tell you that I first met Dr. Al-Faifi back in, I think it was 2011. And he asked me if I could work with him as a scientific director from the American Academy of Pediatrics. And could I gain support from the American Academy of Pediatrics to support this? And I can tell you it's been a wonderful relationship since 2012. I think we've worked really well together to bring really speakers from all over the United States here to the Kingdom to share our expertise with you and for you to share your expertise with us. I think I can state to a person, they've enjoyed their visits, and not only that, they've learned from the experience. And I think it creates a global world of colleagues. And as I see many of my colleagues over and over here in the Kingdom, I'm so happy and joyful to be a part of this global society. With that, I would like to say a couple words and thanks. First of all, representing the American Academy of Pediatrics is an honor. I have my 5 colleagues with us from all over the United States. Just so you know, we represent really the breadth of the nation, starting in Los Angeles, California with myself, Chicago with Dr. Florin, Dr. Matal is in Philadelphia, and Dr. Arabach is in Connecticut, and then Dr. Shaw is in Houston, Texas. So we really are north, south, east, and west, and we're here to represent the entire United States here at this conference. In addition, I would like to say that the AAP is the largest professional organization in the United States that represents the well needs of children. There are almost 70,000 members of the American Academy of Pediatrics, whose mission statement is to obtain optimal physical, mental, and social well-being for all infants, children, adolescents, and young adults. And I think this conference goes a long way to meet that need. And the AAP is very interested in the international community to make lives better for children everywhere. I want to thank Dr. Al-Faifi to put on and to organize such a conference as this is, is very complex. And he has the organizational skills and can pull people together really from all over the world to make this happen. In addition, I want to thank our distinguished colleagues that are here with us. Professor Ali Hayaza, who greeted us as the president of Al Faisal University, which indeed is very impressive for their, really their goal is to increase higher education here in the kingdom as well as in the region. In addition, the Dean of the College of Medicine, Dr. Al-Katan, greeted us, and his vision of having the medical school be one of the top in the world is being met, and I really appreciate his vision. And finally, Dr. Al-Fayyad, Professor Al-Fayyad, who's here, or the CEO, excuse me, of King Faisal. We thank you for your hospitality. We've toured the facility and we really think it is one of the top in the world. So we appreciate being able to come here with you today. I want to thank all of you for being interested in improving care for children. We are colleagues in this search together, and together we can make a difference in the world. Thank you so much.
Thank you very much, Dr. Marianne. Ladies and gentlemen, it's now my pleasure to invite His Excellency Dr. Majid Al-Fayyad, Chief Executive Officer for the King Faisal Specialist Hospital and Research Center for his address, please.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I'm delighted that I could join you today in person for the opening of the 7th International Conference in Pediatric Emergency Medicine. And this conference organized in collaboration with the American Academy of Pediatrics and with the support of Al Faisal University, our colleagues and partner, and also with King Faisal Specialist Hospital. I'm honored, Your Excellency, by you hosting our conference and be part of it, and year after year. I'm also honored that we welcome our guests from the United States, all the way from the West Coast to the East Coast, joining here. So I thank you for enduring the trouble of travel and making it here. And this comes at the heel of the, I hope, the heel of the COVID. Precautions are far less than what it was in the past 2 years. March 17th marked the day the first patient of COVID was admitted to King Faisal Hospital. And since then, we at the hospital here in Riyadh in Saudi and the world has endured the pain of COVID. This is our first international meeting after the lifting of the restrictions of indoor meetings. And it is fitting to have it as an emergency room, especially pediatric emergency room conference, because the emergency room was at the forefront of the fight against the COVID. The emergency room endured the pain of meeting sick patients with the total uncertainty back 2 years ago about how this disease is transmitted, how much it affects people. Yet they took the challenge ahead and took care of our patients, took care of our families, took care of themselves by also adhering to the precautions. And 2 years later, I am personally so proud of how we did as a medical community, as King Faisal, especially as at the emergency room. So I am indebted and grateful. I'm also grateful to the American Academy of Pediatrics. If you have 70,000, you have one more member. I used to be a member of the American Academy of Pediatrics. I don't know if I'm still is, but proud member has always been. But so I'm truly pleased that we are now back to close to normalcy. And I hope for the next meeting, we will have the online attendees come and grace us with their presence and fill this auditorium like the previous meetings. But I am also pleased to see how many are joining online, and I hope that they find it as beneficial as those who are attending in person. And I look forward to having the COVID as part of the history. The speakers that are joining us are elite speakers, and as I said, not only coming from the United States, but also the national speakers and the guests. They will enrich the program over the next 3 days to bring the latest and the cutting edge knowledge, and also to refresh the memories of the rest of us. So it is, as usual, and as we have seen from previous meetings, going to be successful and enriching and making a difference, a meeting that will make a difference. As you all know, but some of you know more than others about King Faisal, which is a tertiary center. And we care for the sickest. So we host the most complex patients, complex therapies, when it comes to cancer, to transplant. We're proud that we're the only center in the region that, for example, provide CAR T-cell therapy, that we are a center that provide gene therapy, treat 1 in 4 patients with cancer in the kingdom, do more than about 65 to 70% of transplant in the country. That all reflects back to how busy the emergency room is and how sick our patients are going to be coming in. As good of a job that we do, we try to do, yet some of them will end up in the emergency room. And this conference is addressing those patients who will come in need and providing the best of management and best of care, best of plan. Last year, 144,000 patients. 144,000 patients walked through our emergency room doors. And we anticipate that will be more this year and years to come, because we have been increasing the acceptance, increasing our, opening our door and being more efficient. So with this number, there is it's a fertile area for knowledge and training. And this meeting is one that will also contribute to that. So I not only thank you, Tawfiq, and as chairman of the emergency room, but also Dr. Mohammed for organizing this meeting, for the program directors for training our residents and fellows and providing the good care to our patients all along. So it is the fact that the pediatric emergency and the emergency room in general is a unique specialty, because it's sort of it's, by the way, something I could never do. I hated my rotations in the emergency room because of the pressure and my lack of knowledge and lack of competence. Nevertheless, I have managed to go through it. And Dr. Mohammed, I know one of your children is going through an emergency room residency, so he must be a smart person. But the thing is, it is truly a noble profession where we receive patients at their sickest and their weakest and their most worried, in addition to the most compromised health-wise. Not only the care that is provided there, but also the passion and compassion makes a huge difference. I don't want to take more of your time, so I want the learning to begin. I want this meeting to officially start, and we start beginning of 3 days of knowledge and wisdom that hopefully will be spread through this hall and online. Once again, I welcome you. I thank you, Dr. Mohammed, and the organizing committee for organizing such an event. And I thank everybody who participated in this, and especially those who are attending. And I wish you a successful conference. Thank you very much.
Thank you, Your Excellency, Dr. Majd Al-Fayyad, for your inspirational words and for also patronizing this event. And now, ladies and gentlemen, the organizing committee would like to award and recognize all those who are behind the success of the conference. And we would like to start or to begin with the international speakers. Are you ready, guys? Dr. Marianne Koch-Hill, Chairman of Scientific Committee, 7th International Conference in Pediatric Emergency Medicine, and Prof.
Professor of Clinical Emergency Medicine and Pediatric in David Given School of Medicine, and Director of Los Angeles County EMS Agency, and President of American Board of Emergency Medicine. Someone help me. Dr. Liz Elbert, the Associate Professor of Pediatric and Emergency Medicine, Boston Children's Hospital and Harvard Medical School. Dr. Manish Ishwar Shah, Professor of the Department of Pediatric, Division for Emergency Medicine at Baylor College of Medicine and attending physician in the Emergency Center of Texas Children's Hospital in Houston. Dr. Manuel Mittal, Professor of Clinical Pediatric and Children's Hospital in Philadelphia and University of Pennsylvania. Dr. Mark Aaron Orbich, Professor of Pediatric and Emergency Medicine at the Yale University School of Medicine and Yale Children's Hospital. Dr. Todd Adam Florin, Associate Professor of Pediatric at Feinberg School of Medicine of Northwest University and Director of Research of Pediatric Emergency Medicine at Ann and Robert H. Lord Children's Hospital at Chicago. It's a long title. And now we'll go to our dear local national speakers, and we'll start with Dr. Muhammad Al-Hussein, Consultant Pediatric Emergency Medicine, Department of Emergency Medicine at King Faisal Specialist Hospital and Research Center. Dr. Ahmed Al-Saleh, Section Head and Consultant Pediatric Emergency Medicine, Department of Emergency Medicine at King Faisal Specialist Hospital and Research Center. Dr. Saleh Al-Shehri, Consultant Pediatric Emergency Department at PSNMC. Nobody told me what PMMC stands for. Dr. Hamad Al-Madi, Consultant of Pediatric Emergency, Prince Sultan Military Medical City, and Assistant Professor, College of Medicine of Al Faisal University.
الحين عرفتها.
Dr. Mohammed Al-Ataibi, Assistant Professor at Faisal University, Consultant of Pediatric Emergency Medicine, Department of Medicine at King Faisal Specialist Hospital and Research Center, and EPC Chairman at King Faisal Specialist Hospital and Research Center. Dr. Mohammed Mawjood, he's not here. Professor Samil Haider, Pediatric Pulmonologist, Department of Pediatric at King Faisal Specialist Hospital and Research Center. He's not here. Dr. Fadi Al-Khattabi, Consultant of Child Abuse and General Pediatric, Department of Pediatric at King Faisal Specialist Hospital. Dr. Ilham Al-Qahtani, Consultant Pediatric Ophthalmology at KFSHRC. Dr. Abdullah Akkam, Pediatric Emergency Consultant at King Saud University, King Saud Medical Center. He's also Chairman of Local Supervisory Committee of PEM Fellowship Program. Dr. Abdullah Al-Malki, Pediatric Emergency Consultant at PEM Fellowship Program, Director of KMMCH. Lots of abbreviations. Dr. Ahmed Al-Ghamdi, Consultant Pediatric Emergency and Head of Pediatric Department at KFH Al-Baha. And now to Al Faisal University and the company. Now for our host, His Excellency Prof. Muhammad Al-Hayaza, President of Al Faisal University. Professor Khalid Gattan, Dean of College of Medicine at Al Faisal University and consultant and head of carotid surgery at King Faisal Specialist Hospital and Research Center. Dr. Bassam bin Abbas from King Faisal Specialist Hospital and Research Center. Dr. Tariq Al-Thibeti. Engineer Malik Al-Mabrouk, Senior Facility Manager, Facility Department at Al Faisal University. Is he here? Mr. Musa Al-Malki, Dr. Omar Abu Omar. Dr. Abdullah Al-Hazza. Mr. Wael Al-Awfi. And now from King Faisal Specialist Hospital and Research Center, those who have participated, Ms. Noor Al-Malhouk, Director of Experience Office at King Faisal Specialist Hospital and Research Center. She's my boss, she's not here, okay. Dr. Osama Swelem, Chief Information Officer at King Faisal Specialist Hospital and Research Center. Professor Saud Shnefi, Executive Director of Academic and Training Affairs at King Faisal Specialist Hospital and Research Center. Dr. Saud, he's not here, I haven't seen him. Dr. Ali Shehri, Deputy Executive Director of Academic and Training Affairs, King Faisal Specialist Hospital and Research Center. And Dr. Fahd Al-Ubaid, sorry, Dr. Fahd Al-Ubaid, Manager of Continuing Medical Education and Academic and Training Affairs at King Faisal Specialist Hospital and Research Center. And finally, His Excellency Dr. Majid Al-Fayyad, Chief Executive Officer of King Faisal Specialist Hospital and Research Center. Now we'll just take a group picture, please, with all the recognized speakers, please. Also, member of organizing committee, they can join. Those who are behind the scenes. And at this moment, we conclude our opening ceremony program, and inshallah, in a few minutes, the scientific program will resume. Thank you, Your Excellency, for patronizing this event, and thank you all for attendance. Shukran jazilan, wassalamu alaikum wa rahmatullahi wa barakatuh.
حطها في الأرض بس. حطها في الأرض. كمان في الأرض. هنا كانت برا شوي راح لا تصير معك سماعة صح؟ الله حبيبي. تبغوا تسووها هنا؟ Three, two, one, cue.
ايضا التعاون مع الذين اليوم يشاركون الحضور في امريكا، يشاركون
أنا ماني قادرة أسمع. هذا هو الحين. الحين تسمع يوسف؟ تسمع الصوت جو؟
في مصور على الكاميرا لسه انا اللقاء لسه هتبدا في مصور تاني شغال.
أنا كلمت شكلي هذا، أنا اللي كلمته شكلي هذا لابس أحمر. لا
شعبان لسه
هذا مو مسوي شير زوم صح؟ الحين أنت مو قاعد تشوف شير زوم. وش محطوط؟ وتسمع صوت؟
ليش؟
هذا اللي أنا قاعد أقول لك إياه من البداية، لأنه كيف فتحته من هنا؟ مو أنا اللي فتحته له.
انت فتحتي لابتوبك، انت الان سويتي شير لابتوبك انت.
أنا داري. هي سوت هناك قبل لا أنا أسوي.
ايش؟
هي سوت هناك قبل لا أنا أسوي، وأنا جاني قال لي سوي لي شير.
انت مو اي شيء يقول لك على طول سوي.
طيب الحين أنا يمديني أتحرك ولا لا؟
الان ترى كل الناس شايفين اللابتوب وهذا غلط، غلط يشوفون هذا الشيء. سوي شير سكرين عندها
لازم أسوي ستوب شير.
اي سوي، ادخلي على لابتوبها هي، لا تسوي من عندك انت، هذا حقك انت، هذا حقك انت. ايوه على لابتوبها هي كذا حتخربين عليها شيء.
هو شو ايوه
حتخربين عليها ولا لا؟ حتخربين عليها. هذا طالع لها الان. ها ايش هتسوين؟ تبين تسوين لابتوبك وخلاص؟ تبين تسوين لابتوبك؟ تبين تسوين لابتوبك ولا لا؟
بعدين وش أسوي؟
روحي الزوم، روحي الزوم.
هذا
الكاميرا شغالة. مين اللي هو؟ شوف ليش خلاص هو ظبط الكاميرا. مفيش حد؟ لا السنة فيها شغالة. صح هي شغالة شغالة. ابدأ الزوم في الأربع قاعات وأعطيني أرقام. أعطيني أرقام عشان أدخل عشان تسوي.
أنت واحد منهم صار بلك بعد 30 ساعة 30 دقيقة لازم نرجع نفتحه.
ما في مشكلة. أنت تبين. طب أعطيني أي
واحد حطوه.
أعطيني رقم عشان أدخل عليه عشان أعطيني الزوم.
أنا بيهم يجون.
أعطيني رقم اللي شغال. أي قاعة قولي لي أي قاعة ومليني الرقم.
قابلتهم هنا. وش صار؟ في واحد مو شغال.
مو جهاز القاعة.
اي
شغلت. ما لنا علاقة. ما لنا علاقة بإيش؟ نعم. شغلت كان أنا توصل بالله.
bulimic acidosis, which potentially could worsen to hypertension. So there's a theoretical reason the normal saline may not be ideal for the resuscitation of fluid. There's a very well done, published in the New England Journal trial of 15,000 critically ill adults where they were randomized to LR versus normal saline. And those that received LR have lower mortality as well as a proxy outcome. So very suggestive that LR might actually be better. The largest pediatric study included 36,000 children but it's not a randomized study. It's a retrospective administrative study where they tried to adjust for reasons that patients that received the two different types of fluids were different. And again, the lactated ringers was associated with lower mortality. But what keep pointing it. Got it before. Let's see. So what is the best fluid for children? We do not know. And I want to just highlight a really exciting study that's been launched. It's being led by the folks at CHOP, Scott Weiss from the ICU and Fran Balamuth from the emergency department. And they've received funding and have launched a study that's going to include 80 sites with a plan to enroll 8,000 children in the US, Canada, New Zealand, and Australia. And it's called the Prompt Bolus Study. This is the full version. And they're going to take children presenting to the emergency rooms of 80 different hospitals. And if they have suspected sepsis, they're going to be randomized to lactated ringers and normal saline. And they're going to follow them and look for outcomes. One of the really cool things about the study is that when children come in septic shock, there's not really time to do a full informed consent because of the urgency of the matter. So this study is actually being done under the waiver of informed consent. So there's a lot of novel information that we'll get from this study. But this will be the definitive study, and it will help us know for children which is the safest fluid to administer. The last question that this guideline highlighted, and I just want to highlight here, is how much fluid. Traditionally, we wanted to resuscitate patients with septic shock aggressively. So, data even from the 80s and 90s showed that those that received more fluids did better. I referenced a small retrospective cohort. But there's some recent data that actually more cautious fluid administration is better. And there's a large trial that was done in Africa. It's called the FEAST trial, and it actually looked at kids. And they randomized to boluses versus no boluses. Those that received boluses actually did worse than those that received no boluses in their fluid therapy. But this is a different patient population. About half of the children had malaria, and the fluid boluses with profound anemia from the associated malaria really may have affected things. So people don't know how to interpret these findings in a setting where malaria is much less common. But it has started to make us more judicious in our fluid administration and rate. So what do we do with this uncertainty? I think that we give fluids until tissue perfusion is restored, and we need further study and more evidence. All right, so I'll summarize and bring us back to the 1 o'clock panel sessions, but pediatric sepsis is hard to recognize. Children with benign viral infections look an awful lot like children with SIRS. And so we need to find those that are at risk of going on to more serious infections early. Hypotension is a late sign, and we really want to identify and intervene before that happens. What are the goals of care? We want to recognize septic shock and obtain access quickly, hopefully within 5 minutes, either an intravenous line or an IO line. Antibiotics should come within the first hour of care. We talked about broad spectrum antibiotics while we wait for cultures to narrow them. IV fluids are a key part of the initial resuscitation, initially in 10 to 20 mL per kilo aliquots until resuscitation is restored. And if those fluids don't work, early initiation of pressors, epinephrine or norepinephrine for fluid resistant shock. There are real questions about the best way to treat sepsis, and I raised the issue of what's the best type of fluid. Should it be LR, normal saline? And hopefully within a few years, we'll have some definitive evidence, which is exciting. And how much fluid, too much, too little, I think we'll also learn more with future studies that are planned. So with that, I'll finish up this talk on sepsis. I can hear you, but maybe not online. Yeah. 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 Those are great questions. Thanks for asking them. So in terms of the pressor for warm versus cold shock, I share practice with you, and I think children rarely fall in one bucket or the other, and it's not warm versus cold shock. And I think epinephrine as a first line pressor and increasing that and then adding norepi if you need a second pressor is the way that I often practice and is our guideline at our hospital. But probably they're relatively interchangeable. And at the moment when you're caring for a really sick child, you want to use a medicine that you're comfortable with and have easy access and you know about the dosing. So it's probably more important that you have a good pressor in place than which particular pressor in terms of survival. And your second question, which is neonatal sepsis, but really sort of the fever workup in the young infant, is actually the topic of the 8 o'clock talk that I'm giving tomorrow morning. So I will defer that question till then. So we'll have a little bit more of a chance to talk about that. Yeah, yeah. The speaker's right here, so.
Thank you very much. That was very enlightening talk as well. In our practice, we don't have access to RT, and that makes high flow hard to implement. And have you have any experience or nurse led and then a lot of success with CPAP, nurse led CPAP, which is more common. And the second question is about the idea of adding a compliance when the child has ended up intubated. So great questions. Again, comes about the first one I'll address first about resource use limitations. So CHOP at my institution, Children's Hospital of Philadelphia, we have respiratory therapists who sort of, this role has become differentiated, and as life goes on, we've become more and more specialized. So initially, till a few years back, nurses used to do all of these things. They would provide nebulizer treatments, they'll provide inhaler treatments for asthma, but now even those treatments in our setting are administered by respiratory therapists. But even in the US, in many community hospitals, and I'm sure we were actually just talking in many of other specialist hospitals as well, these treatments are administered by nursing teams. It's the same with high flow nasal cannula oxygen. I think it doesn't matter who administers it as long as he or she is well trained to do it. So it's if you get the training, I mean, I'm a physician because I've trained to be a physician, right? Anybody else who's trained to become a physician will become a physician. There's nothing special about me or anything. So I think if a nurse can be trained to administer high flow nasal cannula oxygen, then that would be completely fine. There are good and bad things about high flow. The good thing is that it's been found to be extremely safe, and it's been used in, like I mentioned, in community hospital settings and on the regular floor. You don't have to be in the ICU. But the one problem that you need to be mindful if you are just beginning to use it here is that you can realize that suddenly, like
almost every infant with bronchiolitis is being given high flow vesican oxygen. So within a few years, we found that we are greatly overusing high flow vesican oxygen, and it is expensive. Just everything that goes with it. So as you develop your protocols, be mindful of that aspect as well. The second question about antibiotics for cases of severe bronchiolitis, I would actually defer. I work only in the ED, so those patients are already gone to the ICU. I have no idea what they do there.
Right. From the recent guideline, that's an area that they qualified as very poor evidence and uncertainty. So I think the question is about giving a dose of dexamethasone in the setting of sepsis. What's your practice? Do you give it routinely? Mhm.
That's why sometimes we are giving as a diet. And really we saw some patients improving dramatically, especially if they are not responding well to
I think that's exactly when it's tried. So, initial resuscitation with fluids, inotropes, and when you have a patient that's not adequately perfused on both adequate fluid resuscitation and inotropes, I think consideration of corticosteroids is clearly indicated. The evidence is just a little spotty on improvements of outcome, but that's when I would use it as well.
Well, I think I sent the actual. Oh, okay.
Oh, it started. Okay. Is there two? Okay, I'm going to need some help in terms of getting our slides up. But we're going to start with some cases. I can do it without slides too. Is it possible to get the case studies up? It's challenging cases. If not, I will present them myself. Hold on. Hold on, let me see. You know what? I can do it off my laptop. Yeah, no, it's okay. Let me pull up my laptop real quick, and I know there's some slides that say challenging cases that are in my folder. Okay, all right. Do you have the cases that are in my? Thank you.
Presentation.
But it was already, I sent it days ago. Oh, you can put it here. Yeah. Okay.
Just to copy it from here. Into my,
Oh,
or you want to
it was in the Dropbox days ago.
put the Dropbox.
بس ما استلموه استلموا كل البن ديسكشن اللي حقنا.
No, it's okay. It didn't need to be updated. It was in the Dropbox days ago. Is it?
كانت
I see what you have.
معك شغال طال عمرك اللي معك؟
لا
أنا قبل
هي خلاص
إذا أنا ما أدري قبل العطر أنا تبع رأيتي قبل العطر في المايك ما
You
أدري
know
سري
what?
ما عندك
Can I do them without slides? We find all. They were in days ago.
في لو حاب أصلك ورقة كلامك لو حاب إني أعرض الكمبيوتر حق هذا هنا بصافي حاسة عليكم. مشكلة مش خلاص مشكلة مش خلاص
يبغى سماح للجنس اللي هنا.
اللي هنا قصدك هذه مش خلاص.
لا في واحدة مش خلاص.
Oh, file export. It's not doing. Oh, up there. Yeah. Maybe this is it. Yeah. Sorry. Yeah, it was.
It's not from file up there.
It's done.
It's not.
I'm pretty sure. Just let me just. Okay. Yeah, it's right there. It's. Yeah.
Okay, why don't you go ahead and introduce yourself?
I'm Dr. Mohammed Pediatric consultant from Texas Children's Hospital. Inshallah, today I'll be with Prof. Marianne, presenting some challenges cases in pediatric. I hope inshallah you enjoy it.
Inshallah is right. Thank you very much. Okay. Sorry about that, a little technical difficulty, but we're going to go ahead and get started. And these are cases I saw, and we'll work together and also please interrupt me if there's any questions and yourself as well, so we can both do this. So one of the things I thought I would do is talk about how to evaluate a child with altered mental status, because this is a really challenging situation to be able to assess immediate night threats. We'll talk about rule out medical or metabolic causes, and we'll start out with a broad differential, but then we're going to narrow things down. And these are cases that I saw in the emergency department, and so I think it's very relevant to what we're talking about today. So it's a typical day in the ED. I walked into my shift. There was a 13-year-old that was being wheeled to the CT scanner for altered mental status. The patient had a history of juvenile diabetes, was on insulin, and complained of a sudden headache and altered mental status. Anyway, what happened as they were rolling him to the CT scanner, I talked to the family and I said, you know, several things. One, we wanted to get a rapid glucose, and two, I wanted to know, had this ever happened before? The patient was alert and non-diaphoretic, afebrile, but clearly was confused. And the mom said that his favorite course in school was math. And I asked him to add 2 + 2, and he could not do it. So he really wasn't cognitively there. And again, he was able to answer questions slowly, but unable to focus. Let's see if I can put it this way. The vital signs were normal for age, as I said. There was no toxidrome, so he didn't have, he had normal pupillary size and his skin was normal. He was able to state his name, but again, had trouble with commands. So when we think about the differential, I don't know if you use any type of mnemonic. I like AEIOU tips. Do you use a mnemonic at all?
I think it's the same.
Really? Okay.
We'll hear from other audience.
Anybody use some people use misfits for the, you know, undifferentiated sick head. I use AEIOU tips. Anybody have any other suggestions that they use? Okay, well, let's, I'll have to go ahead and talk about AEIOU tips. The problem with mnemonics is that you have to remember what it stands for after you have the mnemonic. But this one is, the first is A, which is, it could be alcohol, unlikely, but it's possible, certainly in a 13-year-old. Ammonia, abuse, and atypical migraine. Here, you don't typically worry about alcohol, but we do in the United States a lot. But ammonia would be very important here for urea cycle defects. Abuse is a consideration, and atypical migraine, and we'll talk more about that. And then E is electrolytes, encephalitis or encephalopathy. I is infection. O is overdose in oxygen. U is uremia, pretty unusual in children to come in uremic, but it's still a consideration. Trauma and tumor, and then I is insulin, and then depending on age, intussusception, and you always have to think about inborn errors of metabolism. Psychiatric and poisoning is P, and S is shock, stroke, seizure, shunt, and subarachnoid hemorrhage. So there's a lot to think about and unpack in this particular mnemonic, but I think it's pretty helpful. So some key questions I asked him, has this ever happened before? And the answer was no. And I think that's very important because recurrent syndromes could be a clue for not only inborn error, but there's other things like, as an example, petit mal status could present as recurrent episodes of altered mental status that the child recovers because they recover when the seizure is over. Has he ever had a headache like this before? And the answer was yes. The family had a history of migraines and he's had headaches, but never with altered mental status. History of drug use, depression, or toxins. You always have to think about toxins. We think about carbon monoxide, especially with home heaters, but that is probably not a huge issue here. And then no one else in the family with similar symptoms. The answer is no, and that would also be a clue that there's not an ongoing exposure in the home. So thoughts on the differential here? Any thoughts? What would be the biggest life threat, you know, to think about? What would you think the biggest life threat? I would worry about, anyone, subarachnoid hemorrhage was something that we were worried about. And in the second decade of life, this is typically something that we would see from an AV malformation, right? You don't typically see aneurysmal causes. You can see it. Typically, it's going to be after age 20, and that would be unusual and pretty young to have a subarachnoid hemorrhage from an aneurysm. But one of the biggest things we were worried about could be AV malformation, subarachnoid hemorrhage as a life threat. But with the history of headaches, we were also concerned about migraines. So we began the treatment for migraine. In the US, we would use compazine and then diphenhydramine. That combination in randomized trials has been shown to be very good. Some use ketorolac or NSAIDs as well. So what happened here is there was some improvement, but the patient remained confused. And we went ahead and did an LP. The opening pressure was normal, as you can see. The CSF results were normal, and the gram stain, there were no organisms seen. So we didn't think he really had meningitis or meningoencephalitis or encephalitis. It's possible to have a normal LP with encephalitis, but it would be very unusual. So I opted to give valproate. It turns out that valproate, it can be used for both seizures and migraines. It says second-line treatment for migraines, especially atypical migraine. And this patient, ultimately, what I felt had was confusional migraine. So the two things that I ended up, the CT was normal, the LP was normal. So subarachnoid hemorrhage was essentially ruled out. Okay, we could have done an IV contrast CT, but we typically don't do that in kids. And given he had altered mental status, I wanted to make sure that he did not have signs of meningoencephalitis. So this was a really cool case for me because it was something I had to really think out of the box. You know, he had a headache. And so this is a typical migraine. And it turns out that atypical migraines or migraine variants are a lot more common in kids. I don't know how many have seen some of these forms. Hemiplegic migraine, you can see where they come in paralyzed, or hemiparesis. Ophthalmoplegic migraine with eye pain and nerve palsies, generally the fourth or sixth nerve. Basilar artery migraine with vertigo. Confusional migraine is what I saw. It's more global. And I don't know if you've seen this, but it's called Alice in Wonderland syndrome. And I've had several kids like this, and you think they're kind of off, but they come in and things seem really small and then really big and then really small and really big. So distortions. And the way it can either go away spontaneously, that happens with migraine sometimes anyway, or you can treat it like a traditional migraine. And then my son had abdominal migraines, which are recurrent abdominal pain, headache associated with vomiting. There's also a torticollis feature that, and you always have to make sure they don't have posterior fossa tumors, ocular migraine with blurring of vision. And I think the challenge here is distinguishing atypical migraine from something else. If you have a patient with hemiparesis, you're worried about stroke or a metabolic problem like hypoglycemia causing neurologic changes. But so you'd want to rule those out. But I want you to consider that in your differential, because I've seen this any of a number of times in children. Has anybody seen a atypical migraine in children? Anyone here? Yes? Oh, a lot of abdominal migraines.
I have a question regarding neuroimaging. In this case, you limit your imaging to CT only. Is there any rule for MRI, MRV, just to rule out subtle vascular or neurovascular issues?
If you're worried about if you're really worried about neurovascular issues, I would consider doing a CTA, or you could do an MRA. Obviously, an MRI, right, and with contrast. So either an MRI with contrast or a CT with contrast if you're really concerned about central nervous system or some kind of cerebrovascular event. Some people have used the fast MRI, but I think that's a challenge. And especially in 13-year-olds, it'd probably be cooperative. Young kids, it's really tough to do some of these MRIs. Did I answer your question? Okay. So again, I ended up referring this patient to a pediatric neurologist as well, just to follow up for the migraines and make sure there was nothing else going on. Okay. No questions? Let's move to our next patient. We're going to run through these, okay? And please ask any questions as we go along. All right. Mother brings in an 18-month-old to room 3. It's funny how you remember what rooms they were in. Do you have that same issue? I can still remember all these different rooms that various patients were in. And on further questioning, you learn that the toddler was fine until 2 days ago, got a cold, a runny nose, low-grade fever, and then wants to lie down and seems weak. The toddler had normal vital signs, history of URI and low-grade fever at home, and now is afebrile. There's no other symptoms except just doesn't feel like eating and decreased urine output and lethargy today. So we asked mom, has this ever happened before? And I think that this is a very helpful question to understand if it's a recurrent syndrome. And the answer is yes. He had a cold and had to be hospitalized. And I said, how long? And she said, a week. And I said, a week? I said, what did they do? And they gave him fluids and he eventually got better and we went home. All right. And I said, that's so vague. What did they tell you was wrong? And she said, I don't know what was wrong. So what question might give a clue to the cause of the child's neurologic symptoms? Any thoughts? So you always want to ask about the siblings, right? Do the siblings have anything? And so do any other children have similar symptoms? And she answered, no, but I had a child who died as an infant of unknown cause. So what are the conditions you worry about with siblings and unexplained death? One might be SIDS, right? What else? Did you say metabolic? Metabolic, exactly. The things that we would think about are non-accidental trauma, okay, child abuse, inborn errors of metabolism, so metabolic disease, okay, and then channelopathies, so prolonged QT or something like that, although it's pretty unusual for prolonged T to cause death in infancy, right? So I was thinking, wow, So this, I was very worried. You have to keep the differential broad here. I happen to know what the end result of all these cases are because I saw them, but in the beginning, I wasn't sure what was going on, and the child was kind of limp. So I thought about botulism, although he was a toddler, he's not an infant. Could he still have botulism? It was possible. I thought about sepsis, and I thought about inborn error. So his muscle strength was overall reduced, and he had no cranial nerve findings. So you typically see cranial nerve findings with botulism. So I thought, well, I don't think it's that. He's kind of old, right? So signs of dehydration on exam, and I hydrated him up. And then I draw what I call my metabolic panel to rule out inborn error of metabolism. And I'm curious what you do here, because you guys have a lot more experience than I do, but it's amazing. If you don't think about this, you'll never pick it up. And I have multiple cases that I've picked up over my career only because it's in my brain to think about as part of a differential, especially in the undifferentiated sick kid who comes in with either neurologic findings like weakness, it could be seizure, right? So I get lactate, ketones, ammonia, and glucose. And some people add pyruvate. And I'm curious, pardon?
CK.
Oh, CK, I think CK is a great idea.
Fatty acid oxidation.
Yeah, okay, fatty acid. Oh, go ahead.
Fatty acid oxidation. Fatty acid oxidation, the effect usually they will have elevated CK. So it's part of the labs that you need to add.
Okay, excellent. So I'll make sure I add a CK next time.
Because I think this is one of the interested case here, especially anyone involved in emergency for sure if it's like this case. Because it's really,
Is this the typically what, I mean, is this the classic story?
This I think my question next, but I'll hear from audience.
Okay.
And I'll ask about especially the age. Usually they died earlier because they need like special diet.
You know, you're absolutely.
So I don't know if they reach like 18 undiagnosed or. So this is my question for you. I don't know.
Yeah,
like this.
Well, what's fascinating, it depends on what the deficiency is. And what we have seen, because they're screened in infancy, that the likelihood they present is really low, right? And they'll die in infancy if they, you know, it's difficult to treat or, you know. And so the ones that I've seen a teenager, 3-year-old, 18-month-old, a 4-month-old, and now I can't remember the ages of the.
They were in like special formula or diet?
No, they were undiagnosed, and I'll tell you why. And this is weird, and you should know this too, is that if indeed they have a little bit of the enzyme that's necessary to drive metabolism down the pathway, they are fine until they get stressed. So as an example, if they get a fever, if they have an illness. And so this child had some enzymatic activity, but did not have everything that was needed. Do you see what I'm saying? So for a child to either have a minor illness and have this presentation and have it happen over and over, if it's a major presentation like the 3-year-old who had an organic acid issue, she presented Kussmaling and had otitis media and a high fever, and she was altered, and her sister had been hospitalized with a similar syndrome at a children's hospital, and I called them and got the diagnosis that way, but we ended up treating her. But this patient was really interesting, so that's my explanation, right? You're right, because you know they're screened. Most of these patients are picked up early on and treatment is initiated.
Especially here also, we are doing the newborn screening, which is included most common cases in metabolic. So it's included in the newborn screening, so they catch them earlier.
Yeah, we do the newborn screen too, but what I'm saying is the newborn screen misses some of these kids that have enough of the enzymatic activity to allow the pathway to screen negative, and they only present when they're stressed.
Here, audience, did anybody face like this after infancy, undiagnosed?
I once actually saw Dylan. She was a 12-year-old girl. And when I asked the mother for history, has this ever happened before? She said yes, she was hospitalized since infancy twice per year for IV fluids, hydration, and then she gets out. But the mother always refuses follow-up, so she was never diagnosed, the girl. So she gets hospitalized annually for just fluids.
That, guys, that's a classic presentation.
Anyone else who saw after infancy, undiagnosed?
Yeah, it's interesting because the screening is so good, but if you don't think about it, so anybody who comes in, that is a classic story, right? Anyway, this was my differential, although it was very high on my list that this child could have inborn error, and especially because of the sibling dying at an early age, I thought this could be heritable and therefore inborn error. So when do you expect inborn error? And obviously during the newborn period, lethargic, coma, decreased failure to thrive, acidosis, tachypnea, all of these things that you see listed. And in childhood and adolescence, it's really this issue of recurrent syndromes. So stupor, lethargy, emesis, often with dehydration, responding to hydration. Unusual odors. I had a kid who smelled like urine and ended up having metabolic disease. This dystonia, seizures are, if a child has never had seizures and remains altered instead of recovery after the postictal period or treatment of the seizure, or unresponsive to most seizure treatment, initially, it's something to consider. Or a child that has developmental delay or CP without a clear etiology. There was a study done and was published in Pediatric Emergency Care that showed about 85% of children with inborn error had presented to the ED with recurrent neuro abnormalities, and it wasn't picked up. So the way I look at it is think about it with any really sick kid or one with recurrent syndromes. And to consider sending now we have an expanded list for inborn error. And this was the study published in Pediatric Emergency Care a number of years ago, but it just shows, kind of the pathways. And I don't remember all the pathways. I just know that if I can screen and one of these things are positive, I have to consider it in the differential. So you can see the ammonia lactate ketones, okay, and glucose, right? And it, in most instances, the glucose is normal, but in beta oxidation or in some of the renal acidoses, you'll see hyperglycemia. So I'm going to add CK to my list. And some people add pyruvate for the pyruvate issues. And so this is what you would think about. You send all these, and if you strongly suspect it or they're known to have a defect, then we give D10 to drive the metabolism towards carbohydrate and away from the deficiency. This child, here it is. Okay, the child had an ammonia of 800 and had a urea cycle defect. Ended up getting dialyzed, and I started D10, and then I called genetics. And I'm sure you have genetics here who's on call with you, and we do. And it's very helpful because we added some other agents in the ED and then admitted to the ICU for dialysis. So this patient had OTC, and I'm sure you've seen some of the urea cycle defects. So. All right, So now think about that, and thank you for backing me up on those recurrent syndromes. All right, shall we do another case? I'm rolling along here with these cases, but the next one is a 3-month-old boy. This is really an interesting case because this taught me something. You know, one thing in medicine, you have to be humble enough to know that sometimes you need a lesson, you know, and you can't always think you have the right answer, right? You have to say, you know, I don't know everything. And sometimes this child taught me this. So a 3-month-old boy, the baby had been seen 3 times in the last 3 weeks for similar symptoms by his pediatrician and told it was gastroesophageal reflux disease or GERD. These were first-time parents and just wanted to know why their baby keeps vomiting. The baby was triaged, emergency severity 4, which generally is kind of urgent care, right? It's like, oh, baby's throwing up again, you know, what's the big deal? 3 months old, otherwise looks good. But when I came in, I noted the baby was sleeping, and I said, when does vomiting occur? Throughout the day, with feeds, what happens? And she said, generally in the morning, but now increasing in frequency throughout the day. I said, is it after feeds? And it could be anytime. It doesn't have to be associated with feeding. And so I asked, and I'd learned an important lesson here that I've carried with me, and it's helped me make some unusual diagnoses. And that is assess development. You know, what would a 3-month-old kid be able to do, right? So generally they can track and they can coo. Some of them, they start smiling, right? They do social smile. A little early to roll over, but something to consider. So I said, what does your baby do during the day? And she said, the baby smiled and cooed, and now just a little over 3 months, now it doesn't smile at all, and feeds every 3 hours and sleeps almost all day. Anyone who has kids knows that you have tummy time, you know, right? You put them on the back, they play with things, and the baby had smiled, and now the baby had stopped smiling. It was only 3 months old, so the repertoire is pretty small, right? There's only so many things a 3-month-old can do. But I said, this is highly unusual, you know. The baby didn't have a decreased tone, had normal tone, and we could arouse the baby, but the baby wasn't interacting with me or the parents in any way. So I felt this baby had lost a milestone. So the lesson here that this baby taught me is if you lose milestones, you have something bad. I just didn't know what it was. And so, again, normal vital signs. And the question I had was the fontanelle a little full? It wasn't fully flat. But I thought, well, there was no torticollis, there was nothing focal on exam. And so when we think about abnormalities in mental status, I sometimes, not that I'm a huge mnemonic person, although I've done 2 mnemonics so far in the last 20 minutes, but tickles are tone, interactiveness, consolability, look, gaze, and speech and cry. If one of those are off, you have to think about potential altered mental status. And then with children with special healthcare needs, as you know, with developmental issues, you have to ask the parent, does the child seem normal to you? It can be very difficult to discern a child who at baseline has abnormalities, so you always have to ask the parent. So the milestones, when you think about it, I call this milestones made easy. You know, there's this whole Denver developmental scale when you get pincer grasp and, you know, when you can actually reach for something. But I kind of use this. So 0, it's tone and response to environment. You know, neonates, if they get cold, right? Or you touch them with your cold hands or your stethoscope, they cry, they're kind of flexed. A 2-month-old, they would track and coo, they can hold their head up. A 4-month-old smiles at faces and rolls over. 6 babbles and makes sounds and sits. 8-month-old, they may say mama, that may be a little early for them. They might be able to stand holding on. Certainly they should be able to sit unassisted, no problem. And then by 12 months, the words and walks, and we know that walking has somewhere between 10 months and 18 months, but typically the average is around 12 months. And 2 years old is verbal and runs. So they begin to definitely say words at 2 years. They may not be able to string some words together, but they say words. So I have my AEIOU tips again, and the things I thought about could be either abuse, that they seemed like a totally reasonable family, and they were very concerned and kept seeking care. So it didn't totally make sense to me. I thought about infection, but it seemed unusual. The child was afebrile and just had vomiting. Thought about potential trauma. I thought about tumor, potential brain tumor, and then shock or seizure, but that would be unusual given the presentation. So you can see everything was normal, and I ordered a head CT with non-contrast, and the answer was because of the loss of milestones. And the baby had medulloblastoma, and pretty unusual to see it at this age, but it's a very, very common tumor in the pediatric population. And the only reason I figured it out is the baby lost milestones. That was it, you know? And this was a really important lesson for me. Older children will present with ataxia. They can have head tilt or torticollis and visual changes. And this baby was admitted, underwent tumor resection and radiation therapy, but I don't know the final result of this child. But I can tell you that baby taught me a very important lesson that I've been able to help other children since this time. Has anybody seen situations like that? Comment? Medulloblastoma?
Okay, go ahead. Okay, go ahead. Yeah, we're currently in route to your facility with a 2-year-old female weighing approximately 11 kilograms, showing purple on her.
Go ahead.
LV was planned for this patient because lumbar puncture was planned. Yeah, because you did the CT and you discovered there is mass. But since he has full fontanelle, and I think it was in the sequence to go for lumbar puncture. And
The question was, why didn't you just consider an LP? Because maybe the child had, and I think that's an excellent question. I think given the time course, the likelihood that the child had meningitis, it was over 3 weeks, was pretty low in my mind. That I kind of, even though I thought the parents were reasonable, I don't know, I always worry about child abuse. They can present in very weird ways. And I thought about tumor, although tumor is pretty rare in this age group, but I thought the time course, right, was kind of long for meningitis. But I think your point is well taken. I opted to do the CT. I think that was the right thing. Did you have another question? Oh. The question is, because the fontanelle was open, the risk of herniation, even if the child had a mass, is relatively low. And I would say you're absolutely right. And you could have, so the answer to your question is yes, you could have done that. And I opted not to and do the CT first because I felt that the meningitis, given the time course, was low, but you are correct. If the fontanelle is open, the likelihood is that you're going to cause herniation is pretty low. Now, it was medulloblastoma, so that is a bit of a concern, but I still think you're not knowing that this child had medulloblastoma. The other things to consider are astrocytoma, Blastoma would be pretty unusual in this age group, but astrocytoma would be possible. Or I have seen craniopharyngioma as young as 4 years old. But your point is well taken. Go ahead.
I think it's a great catch. You know, for me and most of the audience, I think we'll do CT, not looking for mass, maybe for child abuse.
Yeah.
Rule out child abuse. Agree with you that the family is seeking the medical advice for the last 3 weeks, but you know, some child abuse family, they will lie for the physician. They'll say, okay, we went there and nothing done. After delaying like seeking medical advice. So maybe we'll do CT, but not looking for
Not looking for a mass, yeah. No, I was worried about that. Child abuse was still in my differential as well. So I think your point is well taken. You know, you always have to think about that.
Any question?
Okay, I'm gonna play a run. It's a 2-year-old who had several days of fever and now with altered level of consciousness, and her GCS is 111. Had a possible seizure, no history of trauma, past medical history, no meds or allergies. So let's listen.
Okay, go ahead. Okay, go ahead. Yeah, we're currently en route to your facility with a 2-year-old female weighing approximately 11 kilograms, showing purple on our Broswell. Our chief complaint this morning is an altered level of consciousness over the last day. We found the patient lying supine on a sofa at home with a total black of a 111. The patient is family Spanish speaking only. However, did have an interpreter on scene stated that there might have been a possible seizure activity, and our patient now is somewhat posturing at this time and is unconscious and unresponsive. Right now, we got a pulse rate of about 50. We're currently working on some other vitals for you. Our respirations are about 8 at this time. Right now, we're assisting back valve mask ventilation, and we're also assisting with intermittent CPR at this time due to the fact that she does respond to pain now. Let's see here. Her eyes are her right pupil is blown. However, the left one is feeble and responsive.
Okay, so 2-year-old altered at home, may have had a seizure, right pupil blown. Obviously is in cardiopulmonary failure. So if we, the heart rate is only 50. For a 2-year-old, that is exceedingly low. That's bradycardic, and the respiratory rate is 8. So this is a situation where you have cardiopulmonary failure, and the question is the cause respiratory? I would say with the respirations of 8, it could be respiratory. So they started assisting ventilation. This is a pediatric assessment triangle. We sometimes use this. You walk in the room and what do you see? If the patient, the appearance is off, work of breathing or circulation, this is something you may need to act on. If all 3 are off, like in this particular patient, that signals cardiopulmonary failure, and the initial management is very clear. You position the head, open the airway, begin bag mask ventilation. Check for a pulse. If the pulse is inadequate or perfusion is poor, you begin chest compressions, right? So they started bagging this patient, and by the time the patient got to the emergency department, the heart rate was up, and so was not in cardiopulmonary failure anymore. So it was probably a respiratory cause. So you can see, you know, the findings on the pediatric assessment triangle, unconscious, slow labored breathing, and colors pale. So when we put these all together, does anybody use this in their practice? For me, it's been incredibly useful to help drive initial management priorities, right? So if the work of breathing is off, they're in respiratory distress. You give them supplemental oxygen, Or it could be specific therapy, like with Strider, it could be racemic epi or steroids. If they're wheezing, you give them albuterol or ipratropium or combination, right? So, but with respiratory distress, only the work of breathing is off, right? They're otherwise alert and their circulation is good. With respiratory failure, as was pointed out earlier today by Dr. Mittal, is that you have abnormalities in oxygenation or ventilation or some combination. In those patients, you need to do something. You position the head, open the airway, minimally begin supplemental oxygen, and you may need to add bag mask ventilation. Shock, they often have their colors off, right? So what might you do for that? IV access, right? Fluid resuscitation. And then CNS metabolic, the things that we can do are point of care testing right away. And one point of care testing is obviously pulse oximetry. What's another one? What? Glucose. So we'd get a rapid glucose. In this patient, we'd get a rapid glucose for sure. And that was done in the field and that was normal. But this patient had cardiopulmonary failure. And so positioning the head, opening the airway, begin mask was really key. So these are the three things I thought about, but ultimately the child had cardiopulmonary failure. So what are some of the causes? You know, sepsis, trauma, metabolic, right? This is an undifferentiated sick kid again, right? Had a seizure. So we have to think about any of a number of things, including metabolic syndromes. But what's unusual here was the posturing, and the right pupil was fixed and dilated. Also, the left parietal region had no hair present. So that was unusual. Any thoughts here? Okay. I'm going to go past this. The glucose was normal. And the question is, you have a unilateral blown pupil, and you have to worry about a herniation syndrome. So generally, when we think about hyperventilation, we don't do it for long periods. The only time we would initiate it is with potential herniation syndromes. And with the unilateral decorticate pupil, we'd have to think about that in this case. And so I would begin, in this case, hyperventilation and see if the pupillary findings normalized. So here's the vital signs for assisted ventilation. The child actually had a reasonable blood pressure. With hyperventilation, the right pupil was now mid-position. There were no rashes. The history from the mom is she found the child next to the couch and she thought maybe the child rolled off a couple hours before. No previous history. Brother died at age 8 months of unknown cause. Again, this case has so many red flags for child abuse, it's really difficult to describe, right? One, we have sibling death. Two, we have a very minor mechanism and the child has basically is neurologically devastated. So again, we think about child maltreatment, inborn error, and prolonged QT. And what do you think about a fall of 25 centimeters or so off a couch? That's not really high enough to have a mechanism to cause this kind of severe injury. So very unlikely, and we know it's unlikely to cause fractures, such as femur fractures. So I thought about all of these things and started the differential, but I knew I had to get the kid to the CT pretty quickly. We ended up doing a quick rapid test to see if there was any metabolic issues, and there was not. We drew labs and I gave fluids and sent the child to CT. So here's the red flags here: delay in seeking care. Some families, though, there may be cultural issues, social issues, why they may delay in seeking care. So it's not a slam dunk in any one of these. The very young Those with any history of developmental delay can be at risk. And I would say the biggest red flag, two big red flags, is sibling death and severe focal neurologic symptoms out of proportion to history. So all of these are very concerning. So this child ended up having child abuse, had a head CT, which revealed subdural shift. And the child had so much brain swelling, underwent craniectomy. So I think the teaching points here are suspect child abuse in patients with vague histories or histories inconsistent with the level of physical findings. And that was very clear in this case. And then when to use hyperventilation, we used hyperventilation in this case to avert a herniation syndrome, which you absolutely should do. And that is the treatment of choice initially. One might add mannitol or hypertonic saline as well. Okay, I think we're almost, any questions on this case? Yeah, what we would do, like that, okay. What we would do is we would do ultimately a skeletal survey. I mean, obviously, this child ended up getting RSI and intubated in the ED. Then actually got the CT, okay, because the child was not breathing well on his own or her own. So we ended up intubating, going to CT, and then we did the skeletal survey. And there were other fractures noted. So when you do it, certainly 2 and under, that you should consider doing a skeletal survey, which is all the long bones and the chest to look for rib fractures and AP lateral skull, right? So that's what we did. And then there's an investigation. It's not our role to be the judger. Our role is to protect and report. So we reported, and then it was ultimately the mother's boyfriend who abused the child. So again, this is something, you know, it's very terrible to think about it, right? And,
It's common cases, and we are seeing nowadays child abuse. So,
what,
I think it's, as you said, it's not going with the history that the fall is, or the height of the fall is not going with what you find in the neuro exam. So it's like straightforward child abuse. We have some challenges cases, not child abuse per se, but like Munchausen by proxy. We face one case that keep coming for hematuria, investigated thoroughly, spend like around I think million on investigation, ultrasound, and then finally we found the mother is using her blood with a sample for the urine, just to make it positive for the urine. So there is some challenges cases, but still we are seeing a lot of child abuse cases.
that's Munchausen by proxy, that's very difficult, and often they have to be admitted, right, and have multiple exams. But we have seen it in the U.S. that the parent often is an allied health person. I'm just curious if you've seen that. Not a doctor, but they could be.
With some medical background. This is most common, but that mother doesn't have. But she's keep reading. And every time she overcomes mistake, we did it before. So they catch it only when they just collect the sample by the nurse itself. Otherwise, she's keep putting some drop of blood in the.
All right. Any other questions?
Any other question? Any comment? I think we are running out of the time. Thank you, Dr. Mariam. Thank you so much.
Yeah.
Sharing this interesting cases.
Thank you.
Thank you for the.
Yeah. I started, I felt like really dry and my eyes were watering. I don't know. It's maybe the air conditioning. Thank you so much. You like the cases? I got a whole bunch of them.
We are facing a lot, but it's very interesting.
Well, it's
Especially when it's about already maybe there. That's why we do face a lot of infancy.
Yeah. Well, what's fascinating, I've seen a lot of my same thing. Come in and fire and, college medicines.
Yeah, it's really affected by
Yeah.
once you go to just the listen and you can list for this is one of the challenges that was my first time. It's like it's normal group. Just to know the feeling of
That's a challenge. Yeah, that would be tough. Thank you. What do we? Oh, yeah. Yeah, I'll take that just in case. I've got that one all finished, but I just, for some reason, I don't know if it was the, you could tell I was like, oh my gosh, I'm gonna choke. Well, thank you for your help and stuff. That was
Thank you so
fun. It
much.
was nice to be able to,
Thank
you
you so
know, turn to you and say, okay. Right?
so much.
this afternoon session. We started by Dr. Mariana Boucher. She will talk to us about medical service, emergency medical service in children, models, and challenges. Welcome, Dr. Mariana.
Thank you so much. I'm going to talk about EMS, and there's several topics that we're going to cover today. Hold on, let me just make this go. Okay, things are not going. They're not going. Anyway, what I thought I would do is talk to you a little bit about EMS worldwide, and certainly we've all had experience with that. We're seeing expansion of EMS as we go forward. I'm going to talk a little bit about pre-hospital readiness and some of the activities that are going on in the United States relative to pre-hospital care of children and how to make our EMS systems more ready to care for children. Let me see if I can. Could you let them know, Manoj, that it's not advancing? Anyway, I'm just going to keep talking because I know the subject matter, but we'll see as we go forward. There are several things. First of all, globally, there's challenges in terms of EMS systems. They haven't been necessary. Here we go. Okay. Thank you so much. Thank you. This is not working. Oh, there it goes now. All right, as I mentioned, the EMS systems globally are really in its infancy. Many countries in the world are still trying to develop EMS systems. First of all, we see the emergency department is underdeveloped in many countries, and then we also see that EMS. I was going to talk to you also about EMS 2050, which is a vision for EMS going forward into 2050 and what might EMS look like. And I think some of this translates to emergency medicine, but I think it's helpful. I'll mention briefly the National Pediatric Readiness Project, which is something I've been involved with for many years, as well as pre-hospital readiness to care for children. So as I mentioned, EMS is really in its infancy in terms of its development on a world stage. Only about 50% of countries really do have EMS systems. And most systems favor BLS, and we do know that, or BLS plus, meaning BLS plus additional skills. And we do know that BLS is actually quite effective and maybe even better in some instances than ALS, although we know that there's some ALS skills that improve outcomes. Things like giving albuterol in the field. We heard Dr. Shah talk about steroid use in the field, CPAP for adults as an example, and certainly treatment of hypoglycemia has been quite useful as ALS skills. So what are the factors that impact what we do in the out-of-hospital setting? First of all, the medical resources and training, and that is going to make a difference in terms of what kind of protocols. Funding sources, and funding can be quite a difficult issue when you talk about pre-hospital care. And then the other issue will be cultural competency to care for patients of various backgrounds. On an international level, there's a number of different systems. Some call it, the Franco system or Franco-Germanic system, which is more in line with having physicians on board. When we think about the American system, which was really brought up with the idea that we'd have pre-hospital providers that are trained EMTs and ultimately paramedics. And that was developed from a medic or corpsman that occurred in the war theater, and they came back to the United States. And we realized that actually there were more deaths in our highway that occurred in the war theater. And we said, why is that? And the reason is that we didn't have rapid identification of injury and then transport to a center that could take care of them. So the different models are, you can see ALS, BLS first responder, lay provider, or physician. And some of the countries, you can see Saudi Arabia, also with Red Crescent, I believe, as my understanding, has physicians riding along. But there's some, like the King Faisal system that you have, has actual paramedics, which I think is really interesting. As I mentioned, the World Health Organization says half the world countries have no EMS system. So what do? You throw them in a vehicle and you somehow get them to a hospital. And when I was young, there was no 911. The first 911 call in the United States occurred in 1967. And what happened is I remember my sister put her leg through a glass window and cut her leg severely. It was bleeding, and my father wrapped it and threw her in the front seat and then drove as fast as he could. He was stopped by police because he was driving so fast. And my father said, "She's bleeding." And the policeman almost passed out when he saw the injury, and then said, "Follow me," and escorted my father and my sister to the hospital, where she had almost 200 stitches in her leg, but did well. Anyway, again, developing countries, organized systems are hindered by any of a number of things, and it may be poor infrastructure. And we do see that on a rural stage. Here we see nice highways, and in the US, you see pretty nice highways, but the issue is some of the infrastructure is not there to warrant vehicles traveling and picking patients up. And EMS for children is even more in its infancy. You can imagine on a world stage that if you don't have training enough or you don't have the infrastructure, you're certainly not going to have it to take care of children. So there's really a lot to do. And this is just a review that goes over some of these issues from a global perspective. What we do know is adding at least BLS care and some kind of transport makes a difference, and that has been identified in Canada as well as Mexico. And there was a large trial in the United States, the OPALS trial, which actually showed that BLS care was very important and possibly superior to ALS care in terms of taking care of patients in most instances. The difference was for cardiopulmonary arrest, the ability to do rapid defibrillation was really critical, at least for adults. For children, as we know that VFib arrest in children, the likelihood of that is relatively low compared to asystolic or PEA arrest. Now I'd like to just bring up, I mentioned earlier the Pediatric Readiness Project. And we have two types of readiness projects. We have one that's based in the emergency department, and that's the National Pediatric Readiness Project. And the other is a pre-hospital readiness project. And Dr. Shaw and myself have been involved in this effort nationally in the United States to begin to look at EMS systems and try to encourage them to do those things that are necessary to take good care of children. One thing that I found early in my career is they didn't even have the equipment that was sized appropriately, nor did they have the training to take care of children. So as you know, you take an adult mask and you put it on an infant and you're basically ventilating their forehead, right? I mean, it doesn't do much good. So what we found pretty early on is that we had to develop, first of all, objectives for training. And then we had to have equipment lists of what they might need to care for children of all ages, right? And then we had to reach out on a national level to say, can you mandate this kind of training? And so there's been any of a number of efforts over the last 30 years of my career in order to improve pre-hospital care for children. And what I saw early in my career is literally ambulances would pull up to EDs, to an emergency department, and somebody'd come out and go, we can't take care of sick kids here. You're going to have to drive down the street. And they would divert to another hospital, and eventually the pre-hospital providers would bring them in. And so a lot has been done since then, thank goodness. And so there's been any of a number of national courses developed and to train pre-hospital providers in the care of children. One is the PEP course, or pediatric education for the pre-hospital professional. And that has trained probably about 600,000 pre-hospital professionals really globally. And that would be something to use here to train both ALS and BLS providers. But again, the Pediatric Readiness Project in the pre-hospital setting is designed to try to encourage EMS systems to have certain aspects of readiness that we know from the ED setting that is important in terms of improving the outcome. And one is to have the processes in place, right? And the other is to assign someone the role to address pediatric issues. And what we found in the ED is that if you assign the role of a pediatric emergency care coordinator, that individual is more likely to ensure that the policies are in place and that they have the equipment and they get the training that they need in order to improve outcomes. So again, a shout out to Dr. Shah, my colleague, in really helping lead this effort. So the collaborators are, as you see them here, and as most things that are done that are worthwhile, you don't do them in a silo. You reach out broadly to those who are stakeholders and you get them involved. And indeed, that occurred with both the National Pediatric Readiness Project for emergency departments, as well as in the pre-hospital setting. And some of the domains of the recommendations you can see here: planning, medical oversight. If you're going to give direction in the field, someone who's actually giving that medical direction also needs to have the training. And I already have mentioned equipment education. There are patient safety issues that can be addressed, such as having a process to determine appropriate medications, and that may be through mobile apps. It could be through a length-based resuscitation tape or other methods. Family-centered care is always good in involving families because they can help identify potential safety events. In addition to that, it gives greater satisfaction and likelihood for them to accept care if indeed families are involved. So family-centered care is very important. And finally, as we all know, disaster management and pre-hospital providers were also on the front lines with all the emergency providers in terms of providing care in the disaster. What's great is that you could essentially Google pre-hospital pediatric readiness and there's a toolkit and there's a checklist, and they're actually really cool, and was developed by any of a number of experts in the United States. And this is just getting rolled out. So I think this would be a great time in order to help develop these kind of resources here. So some of the recommendations, I mentioned planning, getting somebody involved who has, understands the care of the pediatric patient in terms of EMS planning, it can be really, really helpful. I can tell you that during the Northridge earthquake, one of the biggest issues when we had a large number of people displaced in Los Angeles, what we found is that nobody thought about water to mix formula or even formula at all, or diapers. And there was a huge number of families that were displaced, and that turned out to be a big issue. So that's just a minor example, but there's other examples as well, such as patient reunification. And I mentioned collaborating with other experts. And the other thing is just to develop treatment guidelines. These are very important. As we know, we've had discussions about evidence-based guidelines here today. And I think that's really critical as well in the pre-hospital setting, as already demonstrated today by Dr. Shah. The other thing was medical oversight, and you want to incorporate those into both indirect, which is your kind of your offline protocols and your quality improvement, as well as your online or direct medical oversight, in which paramedics or a provider in the field is calling to get additional direction on what to do. The final thing is, what's the best destination? And I think here that's going to be critical, as hospitals have various resources. You certainly would want to deliver a patient to the appropriate hospital, such as you may want to come to King Faisal, especially for medical conditions, or if you're close enough, you may want to go to a trauma center. Some of the other recommendations I mentioned is having specific equipment, and there are national guidelines. And you can see on the right side of your slide is the national guidelines. And this, again, was a multidisciplinary collaborative to develop what is needed to carry on an ambulance. Because as you know, you don't want to carry a lot of things that you don't use, and you want to make sure that what you use is appropriate and makes a difference. I mentioned education, and I think developing comprehensive and pediatric specific education, but for the pre-hospital environment. You don't want to be teaching paramedics about doing thoracotomies, right? You want to teach paramedics about what they can do in the field that can make a difference, like positioning the head, opening the airway, begin back mass ventilation, checking for a pulse, doing chest compressions, IV access, IO access, and the appropriate drugs, and how to determine the appropriate dose. I think all of those are really important. One of the things I feel strongly would probably be an underestimation of how I feel about this, but I would say that the fact that we have asked paramedics to calculate under pressure with children of various ages is a travesty. I really do. And I think we have to ensure that you don't have to calculate it. You know this in the ED, you know, 2-year-old comes in, 14 kilos, is seizing, is in status. You have midazolam, it's 5 milligrams per mil. How many mils do you deliver? Anybody know? Of course you don't. Oh yeah, well you might be able to calculate it out, right? But it's nice to have something on hand so you don't have that cognitive load. And we actually evaluated this in the field, just standardizing the formulary and having paramedics not calculate. And we did a mixed methods. And what we found is, and it's very difficult to determine what the reduction in error is, but even with all the limitations that we had a 5% reduction in error. But most importantly, what happened is that the paramedics, when we did qualitative interviews, felt strongly that they felt they could take better care of patients, that they felt empowered to actually work with the family, that they didn't have to worry if they were going to make a mistake, and it actually helped them do a better job. So anyway, I'm off my soapbox now, but it is something we're going to continue to try to improve. The other thing that is a real challenge in the pre-hospital setting is, how do you transport children safely? And this can be a real challenge. I mean, obviously putting them in car seats, but not all children can be placed in car seats. And ambulances aren't really designed to carry pediatric patients. So this is still ongoing. There are some guidelines about the safe transport of children. But again, I think we have limitations in this area. The other thing that I think is really critical for any care of the child is ongoing quality improvement. And the recommendations from this is to include pediatric specific measures that can address issues relative to a potential downstream morbidity and mortality. The other thing is just collecting data, right? What we found that's most challenging for most systems is just understanding how many children they see. And that is a real problem, right? So if you don't collect any data and look for variances in data, there's no way for you to do improvement. So you must collect data. So developing good systems and database systems and being able to develop some of those indicators are critical. Family-centered care, I think it's very important to communicate to families. We all know this from the emergency department. The other thing is, do you speak the same language? Sometimes we don't. In Los Angeles, I don't know how many languages are spoken in Los Angeles. I think it's over 100 languages. I'm not kidding. It's very, very challenging to adequately talk to patients. And so developing strategies for being able to communicate with families, I think, is really critical to really understand what's going on. And then I mentioned family-centered care and involving families in the care of the patient and informing them appropriately. And this is really critical because the reason I say this is that a family, you want the family to accept the care, you want the family not to sign out against medical advice, and you want the family to have trust in the medical system. So all of those are critical. And in terms of disaster management, provisions of care, and I mentioned this briefly with families in terms of disaster management, planning to address the needs of children and separation of children from adults. And this has been absolutely one of the most critical things, are tracking unaccompanied children in any disaster. Now, briefly, I want to move on from pre-hospital pediatric readiness to the EMS agenda of the future. This was an effort that was led by NHTSA and many, many other organizations, as you can see listed here. I was a member of the technical expert panel for this, and this was a federally funded project to say where we are now with pre-hospital care and where do we want to be in 2050. And the idea was to be very visionary. What would we want the vision of EMS in the future? And we wanted it people-centered. We also wanted to try to keep people within their communities, and that can be a real challenge based on resources within those communities, right? You may have to drive to a regional center to care for a patient, but again, that might take a patient out of the community, and it might take an EMS resource out of their area as well, so they won't be able to respond to other calls. So one of the things we felt is that the vision is to have people-centered care, keep them in their communities, but what are the guiding principles that help us get there? We want to be inherently safe and effective, and I've already mentioned that relative to care of children. Integrated and seamless, meaning they need to be integrated within the healthcare system in order to be able to do seamless transitions of care, and also to make sure that there was seamless transfer of information about that patient that could be life-saving. As an example, just allergies to medications could be very important, right? Reliable and prepared, being available 24/7, prepared to handle any emergency. Socially equitable is a real tough nut to crack, but what that means is that for any patient anywhere, they have access to care, equal access to care, and no matter what the background of that patient is, they're going to get the same care, or they're going to get the most appropriate care for their condition. Sustainable can be a real challenge for EMS, and the reason is because the funding sources are so diverse. And now in the kingdom here, I know probably a lot is government sponsored, which I think is probably a good thing. What we do see is various types of models. Some are responsible, are municipalities. It can be state funded. There can be federal funds for this, but this is a real challenge. Even subscription based can occur. And adaptable, I think this is really key and innovative. We need to keep stretching the limits. We need to keep leaning in to the problems and trying to solve them. And we also need to be adaptable for any situation that may be changed in not only seasonal changes in terms of weather, but other changes in terms of traffic and other things. And we don't know what the problems are in the future, but we have to begin to anticipate them and plan for them. Physicians will lead, I think, in the future, a collaborative system. I'm sure it's going to involve the integration of technology, but it's also going to involve good communication skills amongst many providers. And I think that is really going to be key in the future. My vision would be that you'd be able to call. I would have all the information about you. I could actually reach out to one of your specialists and direct you to a place where that you would have care locally, or that you would be treated and someone would come to you in your home and take care of you. And that would all be recorded, part of the record, and that could be transferred from provider to provider. So achieving this vision is going to involve a lot of work on a global level. It's a huge lift. If 50% of the countries don't even have organized systems and the infrastructure's in place, we have to start from the ground up. For those who do have the infrastructure, what are the things that you can do? And I think one is to begin to plan, understand the resources, and meaning the hospitals, what kind of potential types of resources that you have available, what kind of training you would like to have, and really start working together to develop systems. And if you do, I ask you to think about children from the beginning and not as an afterthought. So what's going to happen? I think really everybody's involved in this. We have to solve this, be able to help people get and have access to hospitals in order to have emergency care. So it really begins now, and it begins with each of us. And thank you for your time, and I know we'll have questions and answers later. So thanks again.
So thank you. We'll leave in a day. The next speaker, Dr. Mark, he will present procedure, sedation, and anesthesia. Welcome, Dr. Mark.
Hello, everyone, again. So as my slides are coming up, it's great to see that we still have a lot of attendees online and some here in person. I'm going to be speaking about procedural sedation and analgesia, which may be different depending upon where you're located in terms of what your scope of practice is, what your agents are that are available. But I'm going to walk you through a little bit of how I approach this topic, and hopefully we can go through some cases in this discussion as well. They're going to pull my slides up, right? Or should I do it? I have control. This is much better. Yes, I like control. Okay. So here we go, procedural sedation in the emergency department. So again, no conflicts of interest. My hope today is to talk a little bit about analgesia, mostly about sedation, but we'll define those two terms. Then we'll move on to talk about the mechanisms of action, pharmacokinetics, and some of the side effects of some common agents. I think that it's really important, and sometimes bringing back some of our pharmacology lessons actually are something that I can apply both in rapid sequence intubation as well as in sedation. So some of those lessons that you're learning as students really can be applicable later on. And then describe approaches to choosing the appropriate sedations for the appropriate procedures. Lost control now. Let's see. I think he took control of that. Oh. Okay, so starting out with some definitions, and I think distinguishing between sedation and some of the other effects that we're looking for from these agents. Sedation is a reduction in activity, anxiety, stress, irritability, excitement. But then we have some other attributes that we can have in many of these medications and some attributes that we wouldn't have in some of these medications. So analgesia is a key one in the emergency department, that there are certain procedures that we would not need analgesia for, maybe something like an MRI. And then there's other procedures which absolutely it's really helpful and appropriate for that patient to sedate them together with an analgesic effect for something like a fracture reduction. So analgesia is the relief of pain or the alteration of the procession of stimuli. And then we have some other effects that we see with these agents, which we'll talk about later. One is amnesia, and I think a very helpful effect of some of these agents are actually both a retrograde and anterograde amnestic effect. So taking away some of the memories that they might have of some of the things that we did to them, maybe even putting in the IV for sedation. Anxiolysis, I do wish that we could give some of the anxiolytic effect to the parent, but unfortunately we cannot do that. But assuring the parent that we can address some of their child's fear and distress. And then a hypnotic related to drowsiness or sleepiness. So what are our goals? Again, it's to improve the both the psychological and physical outcomes, but I think the psychological comfort, decreasing their fear and anxiety and causing the amnesia can be very helpful. From a long-term perspective, even if they don't remember, we know that by appropriately treating pain, we can decrease both adverse medical outcomes as well as things like post-traumatic stress disorder that kids can have from some of these events. Lose control again. We oftentimes, for the goals of our procedures, want to facilitate the intervention. Sometimes we want the child to just to do nothing, like for an MRI, and sometimes we'll want that child to be relaxed to do something like reduce their fracture. Last effect that we can have from some of these agents is reducing metabolic demand. I would say that probably comes into the cases where this is a patient that is intubated, not really a procedural sedation, but when we do have patients that are requiring sedation and maybe want to decrease their metabolic demand, probably more of a patient that would be in the ICU or another location. So the levels of sedation, looking at this traffic light sort of tilted sideways here, I think are really important to think about when you're thinking about selecting an agent, but as importantly, or if not more importantly, think about when you're doing a consent or preparing the room. So this ranges from minimal to moderate to deep sedation. And where we want to be in the emergency department is within that green or yellow, but we need to be prepared to be in deep sedation or even for general anesthesia. So being prepared for one level up for the procedure and being prepared to manage the airway for that patient that's one level up. So our goal would be here for most of the patients that we're going to talk about as we go through some cases, either mild, moderate, or deep, but recognizing that any of those patients could move down to general anesthesia, might need an escalation in something like an airway. I tend to like AVPU for both trauma as well as sedation. This is something that you can use across the age continuum. Some of us will talk about tickles for the younger infants, looking at their tone, interactivity, consolability. But AVPU, I feel like, works pretty well for that overall assessment of that child. What is their level of sedation? There are some scales for this, but are they alert? Are they verbal and talking to you? Are they responding to painful procedures? Or are they unresponsive? And depending upon where you want to get them to, the agent might be quite different. So for something like an IV placement, we probably really are only aiming for them to get up to the painful. For something like a reduction, we might end up targeting unresponsiveness. So again, that's the levels of sedation. Minimal, to go back to that green light here, would be things that we often can do in the emergency department without the need for monitoring and invasive procedural events. So these might be things like giving a medication for a laceration repair. I'm not sure how often you're using intranasal medications here. It's become really commonplace for us to use intranasal Versed, and this is really, I think, almost gone so far that it's hard for me to do a suture repair without giving the patient intranasal Versed because it's part of our protocol. And sometimes the family is saying, do I really need that? And we'll hold off on it. But the patient should be responding normally and be in that alert category of AVPU. If we're moving to moderate, this is where you're going to get that drug-induced depression of consciousness. They should still maintain their airway reflex, and they really should respond when you touch or stimulate them. So this is what we sometimes would call light sedation. They should be responsive to, you shouting or yelling, and respond to some tactile stimuli without doing a sternal rub. The deep sedation, really, this is someone that would not purposely move, that might need a sternal rub. They're not going to be under general anesthesia, and they may respond to that severe painful event, but really they should have most of their airway reflexes intact. And it's when we're moving to general anesthesia where they would lose their airway reflexes. So before you sedate, just like before you take care of the trauma patient, as I mentioned earlier, preparation is really key. And you want to make a decision of whether or not this patient is safe to sedate. I think that some of the topics, and we'll come back to NPO status, which is really something that we, I think, overly focus on, really receive a lot of attention. Some of these other aspects of risk assessment sometimes don't receive the attention they deserve. So I'm hoping that one of the key takeaways from this talk will be risk stratifying these patients and looking at why we need to collect some of this information when we consent for sedation, but that this isn't just consent, it's actually a risk assessment to decide, is this patient safe from a provider standpoint to do this procedure in the emergency department. So weight, your exam, you may do an ASA score, you get the history, you may look at when they've been NPO from, you then will use that information only if that information suggests that they're safe to sedate, would you move on to get consent. And based on that discussion with the subspecialist, you might actually decide this procedure is not worthy of an emergency department sedation because of the duration. And I think that's somewhere where I really struggle to say what my cutoff is. I would say a half hour is usually what I'm aiming for. If they get up to 45 minutes to an hour, it is a difficult conversation, but needing to move that procedure to the operating room, just from the fact that the risk of sedation goes up quite dramatically as you increase that duration of time. It also pulls you away from the rest of the ED. So these are my red flags. So not in the ED. These are the patients that I would suggest avoiding. Less than 12 months. This is a population we don't as often need to sedate. I think I would just think very closely about what resources and services you have for those patients. I wouldn't say that's a hard and fast rule. Certainly a population you could sedate, probably the weakest of the ones I'll mention. Obesity is one that I think that people are a little bit cavalier about, in our department at least, where these patients with over the 95th percentile BMI really do have an evidence that supports that they're much higher risk for complications. History of snoring or sleep apnea and difficult airway craniofacial abnormalities, I'd say is probably one that we do respect and that many of us are aware of in our emergency department and health system. We now have a difficult airway flag that comes up in EPIC. So sometimes this is intuitive, you see it from the outside. Sometimes in a chronic patient, this is someone that's been hospitalized a few times and maybe been to difficult airway in the past. You're going to look, listen, feel. We have the Lemon score. We have other techniques, but really looking at that child's face, I think if you look at this child with micrognathia and Pierre-Robin here, it's pretty clear to me that that would be a difficult to intubate child. If you ask them to open their mouth, and this is an obese child, and you're seeing what you see in items 3 or 4, or in case 3 or 4 there for the Malampati, both of those should really heighten your concern, because if you see on the right side of the scale there, your POGO score, percent of glottic opening score that you would expect to see in that Malampati class 3 or class 4 is going to be very poor, and it's going to be a difficult airway. So looking at the ASA classification, again, using this green, yellow, red, I would say that in the ED, we're going to aim for that green or yellow population. I think one of the populations that causes some consternation for outpatient anesthesia in the US, and I think we need to think about in the emergency department, is active wheezing or active URI symptoms. These are patients that I struggle with to decide whether or not they're safe to sedate. I think we often do sedate them, but this patient that has a minimal wheeze that is right between that level 2 and 3, I think is a really difficult patient to make that decision in. I can tell you that our anesthesiologist would send that patient home and not do the procedure on them. This also depends on the procedure itself. If this is something like an orthopedic procedure that could be done in the morning or at a later date, that patient may be better served by deferring the sedation. As we move into class 3, 4, 5, and these are patients with things like Down syndrome, patients with things like complex congenital heart disease, these discussions, I think, are things that need to happen probably more often in many of our departments, just risk stratifying those patients. While it's common to us to see that population is not necessarily the common type of patients that's included in most of our sedation research and studies. So MPO is a old habit that's hard to crack. We talked about de-implementation science a little bit in the last session, and I'd just like to reiterate that when something has been practiced and is in our guidelines and is often in our policies, and you even hear horror stories about, it's very hard to take that practice away. So when we look at MPO status, there's no association of adverse events in the people that break the rules and provide sedation in that 2 to 4 hour mark compared to those that follow the rules in the 4 to 6+ hour mark. So I think a 2 hour cutoff is something that many of us need to consider. Certainly using common sense, if someone's eating a Big Mac as you're coming in because their parents brought them that because they hadn't eaten since this morning, certainly someone that you want to consider deferring. And if that procedure is not as time sensitive, considering deferring. Looking at the ASAAP guidelines that are listed here, I would argue that these probably could use some updating and may not be consistent with the current best evidence. But these are existing guidelines, which causes a challenge for many of us because it is difficult to deviate from the guidelines. And again, in some of our institutions, this is a policy where the nurses will say, this patient's not been MPO for 4 hours. I would say that giving a patient, ice chips or water is quite different than that patient having French fries or a hamburger. And again, 30 minutes is quite different than 2 minutes, which is quite different than 2 hours. So my, comment on MPO is that the evidence really does not support where the guidelines are. And we want to think about this both within the research evidence as well as within our clinical practice of our institution, because we often need to adhere to, particularly if it's a policy statement. We need to prepare our teams. So our teams should be aware of not only the patient's weight, but what equipment they might need. And I would say for the moderate and deeper sedations or general anesthesia, this would be a full set of airway equipment and a full setup for that. The staffing is something that I have been very happy to see a change, at least in the US and in the institutions I've worked in over time, where the proceduralist and the sedation provider are two independent practitioners. Unfortunately, when that person is concurrently trying to do both tasks, that can be quite problematic. And there are cases where, a deterioration in that patient is missed for a period of time. And ensuring that the proceduralist is prepared for the next level up. So it's not really helpful to have a proceduralist in the room. A sedation doctor in the room that does not know how to manage an airway should that happen, even though that is an uncommon event. Preparing our equipment, I like this pneumatic soap me. So getting out your suction, that's something that I often forget. I think the oxygen, your backup airway equipment, so the nasopharyngeal or oropharyngeal airway, the laryngeal mask airway that are age appropriate in size. The medications usually do come into the room. Different individuals have a different threshold related to when they would bring in a medication like a paralytic, and we'll come back to that with ketamine. I would say that, reversal agents are potentially available within the department is my philosophy, that that's reasonable, don't necessarily need to be in the room with the patient. And then from a monitoring and equipment standpoint, we have a checklist, and we're very fortunate that our nursing staff is very diligent about getting these resources set up, all the way down to end-tidal carbon dioxide monitoring, but making sure that you do have those backup supplies like the intubation equipment, again, available, not necessarily in the room, but accessible should you have an untoward event. I think preparing the patient and the parent concurrently is really important here. We do have child life staff. I'm not sure, do we have, in the kingdom, do you have child life staff as well, or is that a familiar tone? Okay, so I'll come back to that a little bit later, but this is a group of master's trained professionals that have degrees in child development and are very, very helpful in helping the child to understand what the procedure is and what the sedation will entail, as well as the parent. So they, you want to decrease their fear, stress, and anxiety. One of the things that Child Life is very helpful with is bringing distractions, games, turning down the lights, playing music, things of that nature, and really encouraging us to have the family present, at least for the induction of the procedure, and sometimes even if after the procedure starts. I would say I've learned the lesson the hard way, that you want to always have the family sit down. I've had 3 or 4 people that have fallen and either ripped the sink off the wall or knocked their child off the bed because the parent passed out during the procedure. So I would argue you should always have the parent sit down. So just to go through some patient cases. So we have a 4-year-old male, they fell at the playground. They have a very displaced and angulated fracture of the radius and ulna. What would your agent of choice be in this case? So I'll give some options here. Okay, so I see a ketamine. That's a good choice. I like ketamine for this patient, and there's a variety of reasons why. And we'll come back to some of these other agents later on. But the mechanism of ketamine as a dissociative, amnestic, and analgesic effect, I really couldn't think of a better recipe than that for this condition, which is a very common condition that we see. And the other benefit is the pharmacokinetics and pharmacodynamics fit really nicely. We want about 15 to 20 minutes, and we get just about that with our ketamine, and we sometimes can give an extra dose and don't have it as much, while we have a slight increased risk of side effects. Once we get up to 4 or 5 mg per kg, we do have the ability to repeat dosing without as much concern as other agents. It also has some hypertension and tachycardia effects just to be aware of, not something that usually causes much harm in our patients, but that sympathomimetic effect with the sedation is just something to be aware of. I think also for the family, making them aware of both the flushing and the nystagmus, because that's something that without warning the parent can be quite disconcerting to them. I am a little bit more old-fashioned in terms of ketamine and a little bit more nervous about the use of intramuscular ketamine. It's just the way that I was trained. So we tend to not use intramuscular or intranasal in my department. We tend to start with intravenous in that 1 to 1.5 mg per kg. One of the other downsides of intramuscular ketamine, it's very interesting, in a US study, the nurses expressed some resistance because the patients were having a much longer duration of stay in the emergency department to recovery. So while it seems easier not to have an IV, it actually might prolong the stay of that patient and the recovery of that patient. So I typically go with a intravenous dose, and recognizing that as we get to 5 mg per kg and above, that really is getting into general anesthesia. And we'll see, I'm not sure if your cardiac anesthetist here like ketamine, but for certain procedures, our cardiac team is using that at the 5 mg per kg range. There's a number of different adverse events, and I think one of the ones that I really try to impress upon our learners to talk about is recovery agitation and sleep issues. I think this is something that's not as brought up as commonly. The recovery agitation, when and if it does happen, up to 10%, really nice to warn the parents that your child might wake up to be a beast and act like they've never acted before, and letting them know that's a risk, and being prepared for that. I think some of the sleep things later on, just warning them of that. The emesis is also quite a common thing. So having Zofran ready, not necessarily something you need to give to start off, but letting the parent know about that. And it increases quite significantly with a higher dose, and again with the intramuscular, so something that might potentiate the vomiting. The airway adverse events are clumped, unfortunately, into some earlier studies as airway-associated adverse events, and included things that I care about, like laryngospasm, as well as things that I don't care about, like transient apnea. So I think if I need to do something to that patient, which might involve moving their head, moving the oxygen so that it's still on them, I care. If it's something that I need to do something like push on Larson's notch, which we'll talk about, or intubate that patient, I really care. So, for the laryngospasm, depending upon the study, it can be 1 in thousands to 1 in 10,000s. And I think something to be aware of. And certainly, I know when a nurse has experienced it before, because typically that nurse will be bringing in the succinylcholine into the room. I think you never forget that. In the younger kids, so certainly that less than a year, more likely to see some of the adverse event, but really the dosing related. And this is why, as we get up to that hour-long procedure, 4 to 5 mg per kg, I need to go see my other patients, but I also let the orthopedic surgeons know they need to call their attending and do this in the OR because of the higher risk of adverse events. Co-medications with atropine as an anticholinergic and with a benzodiazepine as a relaxant are two things that I was taught. This atropine versus ketamine was the old school 0.01, 0.1, and 1 mg per kg. The evidence really does not support that. I would say that the selected populations where we are using benzodiazepines is a child that maybe is very fearful of an IV, giving them some intranasal benzodiazepines. And if a child has a very difficult reduction, sometimes giving some benzodiazepines will help in terms of getting them basically back into anatomic position. So my practice is actually not to use either of those agents based on the increased risk of adverse events, other than in selected situations. The intraocular pressure is still correct, and I think something to consider that could be a harmful side effect. I would say it's not something that we are typically doing anything that involves the globe itself in the ED. That's typically going to the OR in our institution. And then intracranial pressure, we talked about earlier this morning, not something that I would change my management for. So this is, I think, a nice, trivia piece. I'm not sure if I have personally experienced use of Larson's point to be effective, but it is something that seems a little bit voodoo, so I think is always worth talking about. So the first thing you're going to do with laryngospasm is call for help. The next thing you're going to do is have them call for help again and make sure that people are on their way. The next thing you're going to do is make sure you heard the alert over the loudspeaker calling for anesthesia. And then you could start, as someone's repositioning the airway, as someone is doing all these other things in the room. And then if you really are bagging, can't get anything through, you could start to think about putting this painful inward and anterior pressure on Larson's point bilaterally. So a little bit like the Vulcan death grip from Star Trek. But there is some very weak evidence that that might actually mitigate the laryngospasm. I would say that if you're at the point where the laryngospasm is not mitigated with bag valve mask and repositioning, this is someone that, ideally someone is running to get the paralytic while you're trying to remember or Google Larson's point. If no response, you're going to deepen that sedation and paralyze, as I mentioned, and then consider intubating. Another, pearl that is out there is a chest thrust maneuver that by putting a very deep pressure on the chest and causing that positive intrathoracic pressure to go upwards, that might actually open the vocal cords and allow tube passage if you don't have a paralytic present and ready to administer. This is a nightmare situation. I would say that the few times that I've had laryngospasm, I'm very fortunate. I don't know if this is wood, but knocking on something, that this is someone that you can bag through and reposition. So ketamine, I would say, is really our drug of choice for that patient with an orthopedic injury, and what we're going to go through with quite commonly. There hasn't been an emergence, and I think we're on the downslope of this, fortunately, of ketofol and the use of propofol and ketamine together. And the reviews that we have done, there has not really been any improvement, and there are potentially some additional side effects. The hope was that this would reduce sedation time, potentially reduce the dose of ketamine that you need to be giving. It does sound nice. It's a neat word to say, ketofol, but it's not something that has become within my practice. The mechanism of propofol as an agent is the activation of GABA. So the important thing to recognize here is it does not have much analgesia effect. So for procedures that require analgesia as well as sedation, this is not an effective agent. The one use case that I can think about in our department that we are using this quite commonly with is for prolonged imaging, something like an MRI procedure. The pharmacokinetics and dynamics of propofol, the really great thing is the quick on, quick off. So the fact that you can have this agent turned off and stop functioning within 60 to 90 seconds is really phenomenal, particularly if you have someone with like a neuro injury where you need to reassess their neurologic exam. And as we get up from that, 50 going up to 75 to 150, that's where you're starting to get into the general anesthesia effect. And the great thing is recovery is very rapid. So while we do see pretty profound hypotension in our pediatric patients with propofol, that hypotension is short-lived and something that my intensivists get me a little bit nervous with, because they're pretty generous with pushing it and they'll see the blood pressure come down. And my wife's a pediatric oncologist and does a lot of bone marrows. And all the time she's saying that they'll see the pressure come down, they don't even worry about it. They just stop pushing the propofol as much. Other effects that you can see other than the hypotension, which is probably the most common thing we see in pediatrics, the respiratory depression, which is expected, pain or burning at the infusion site, which can be relieved by administering slower or some lidocaine. And then there is a black box warning, and I think depending upon your duration of sedation, this is really important, that if you are looking at sedation over greater than 24 hours, this propofol infusion syndrome in pediatrics is a real entity, leads to refractory and irreversible metabolic acidosis. So certainly for that prolonged sedation, if you are thinking about, I would say greater than 24 hours is the black box, but I would say not something I'd want to be using if I was waiting for a transport 4 or 6 hours. I want to switch that agent over. So ketofol, as I mentioned, little significant superiority. You do get the combined effects of both medications, but because the child can tolerate the hypertension pretty well, I don't think that there's as much of a benefit to using them both concurrently. So another case, a much more common case, as I mentioned before, a fall with a laceration. I heard that oftentimes you're needing to have plastic surgeons come here. So in some of the departments at the military hospital, I was hearing this, that you might need to get the plastic surgeon to come down even for a minor facial laceration. So if you have this patient with a facial laceration, what type of agent would you use? The parents saying, I want something for my child. You can't do surgery on them without, someone mentioned surgeons, so you can't do surgery on them without any medicines. 2, so child life, okay. So child life can be very effective. Unfortunately, it sounds like you don't have that here, but we can do some of the child life procedures ourselves, or nothing. So nothing, I call this brutane, and I think depending upon how we do nothing, there's a big difference. So if we use a little bit of those child life techniques, blow bubbles, turn on some music, do some distraction, that's very different than using, on the right side here, what we used to use quite commonly when I was training, a papoose board, where you're basically strapping the patient down, not letting them move at all, shining a bright light at them, having a lot of people yell, doesn't work so well, causes some PTSD. The non-pharmacologic methods that are very effective, really good explanations by the staff. Lighting is something that I think is much easier to do than we respect. So turning the rest of the lights off in the room, just using the procedural light, decreasing the noise level, sometimes turning the temperature either up or down to get the room at a comfortable temperature. And iPhones have completely changed this. So it used to be that we need to try to find a TV or find a channel on TV with a cartoon. Now every parent has the iPhone with the show that the child likes. And I think that you can really get some of that audio and visual distraction. And the younger infants, sweeties, it does have an opioid-like effect, and certainly something that has become our standard for even a catheterization in young infants, a urine catheterization. It has demonstrated analgesic properties up to probably about 6 months, sweeties. So for this patient, child life and benzodiazepines are probably what would happen in my department. I had mentioned benzodiazepines before and child life before. So just to quickly mention what child life is, when I was leaving for this meeting, I walked past the sign and was actually thinking, do they have child life in Saudi Arabia? And I was astounded to see that our hospital is celebrating its 56th year of child life in the hospital. So it's been around for longer than I had thought. It's a master's degree. They actually have 600 clinical hours of internship, so quite a lot of onboarding experience. And they learn about both child development, distraction techniques, education techniques, and depending upon the study, up to 20% of patients, you can obviate the need for the higher level of sedation. It is costly. This is a group of individuals that you need to have around 24/7. I would say in our children's hospitals, all it takes is a couple of angry parents writing letters. We have something called patient satisfaction surveys. So when parents report that the staff was using brutane, that leads to actually more child life funding, I would say. The mechanism of benzodiazepines are inhibitory. Really, the clinical effect here is an anxiolytic sedative and does not have analgesic effects. I find that letting the parents know about the amnestic effect, again, is really important here, because when we're getting prepared for the procedure, even giving the intranasal and the child freaks out, most of those children will wake up and say, when are you going to start the procedure? And they don't look at you pissed off or upset or looking at you like you just hurt them. So I think it is evidence, and I'm comfortable telling the parents, while some of the things we'll be doing when we are trying to get your child calm might be looking like they're really hurting them, you might actually be able to tell them that the child's not going to remember that. We have an expert here in Dr. Shah in seizure use of midazolam, but midazolam from an IV or intramuscular route is effective and can have a max effect in somewhere between 5 minutes for IV, a little bit longer for IM. But one of the benefits that we have with our atomizers is that giving it intranasally, it's pretty quick on. We do need to wait that 5 minutes. I've had a number of residents where I come into the room and I find that the midazolam is just starting to kick in after they finish the procedure. So you probably want to make sure that you have the 5 minutes. Another time child life is really helpful. Well, they'll usually come grab me and say, hey, someone's in the room about to start the procedure. The nurse just gave them midazolam. So it needs about 5 minutes. Quick off, so about 10 minutes to turn off, as opposed to the oral, which will be a little bit longer to turn on and a little bit longer to turn off, but oral can work as well. So in this case, we would use intranasal midazolam in my department. Very uncommon, you would need the reversal agent. I think it is important to let parents know again about the paradoxical reaction, particularly in the younger infants, less than 2, or children with developmental delay. Respiratory depression, very uncommon. More often, what we'll see is mild transient respiratory depression and not something that requires any type of intervention. So nitrous oxide is an agent that unfortunately we don't have in my department. I know that some of my colleagues have this in their department. Do you guys have nitrous oxide in the department here? So there's an expense to some of the systems to reclaim and make it this from the atmosphere and make this safe. It's GABA inhibition. It has very nice sedative, amnestic, and analgesic effects, although those are mild. So very helpful for something like a dental procedure. That's why many dentists' offices have this. If you do have it available, it's very helpful for other things like IV placement or short minor procedures. The pharmacology, super fast onset. So now we're talking about 30 seconds. It's a good adjunctive as, again, if you're putting that IV in. You need that equipment both for the administration as well as the reclamation of it. And the adverse effects are vomiting, dysphoria. You can have some transient respiratory depression, and there are some contraindications related to the fact that this is an inhaled agent listed there. So now case 3, we have a 26-month-old female. She fell, she's got a big laceration and expanding hematoma. She fell from 15 feet. So a number of us are involved in PCAR, and she has a greater than 2 centimeter hematoma on the parietal area of her scalp. So you're pretty worried about her. She's now vomited a few times, isn't acting normally. So you are deciding that you might need to do something. Or you might not need to do something. So you could start with the PCAR decision rule, and if that does lead you to get a CT, that doesn't always obviate the need for sedation. So even that child that's screaming, yelling, my experience has been with the appropriate CT technician and doing this in a way that is child friendly and maybe again channeling some of that child life, that the CT itself is usually less than a minute, but the preparation for the procedure and making sure that child is in a calm environment, potentially has the parent coming in there with them, helping them calm down, is something that can set you up for success. So the safest thing is nothing at all. I would say that we want to avoid repeating the radiation. So that child that's continuing to go bananas every time they start to try the CT scout is certainly a child that you would consider another agent. Propofol can be an effective agent. A benzodiazepine can be an effective agent. Here, we're not needing an analgesic effect, but involvement of the parent, I think, has gone a long way. In our center, we are starting to use some virtual reality goggles, which can help quite a bit as well, and they can keep those on during some procedures, but really that might affect your head CT imaging here. So probably using other techniques for distraction like video. So, we think that the child sees that the child's going to be calm and cooperative. Sometimes the child will look like that, but I want to remind us that oftentimes we look like the devil to the child, and we might really look like a monster or a devil and be scaring that child. And changing that frame can really help us in terms of the success with our CT. So etomidate, as I mentioned before, is a sedative, anxiolytic, amnestic. Really doesn't have as many side effects. It's quick on, quick off. Important thing to know about etomidate in these patients with head injuries, myoclonus. I've had a few times where the CT scan group thought that the patient was having a seizure. So just be prepared that there might be some myoclonus. Onset is very rapid. Offset is not as rapid as propofol, but reasonable. And this is a drug that we'd like to avoid if we're thinking about something like sepsis, might affect the adrenal axis, but really something that is more in a prolonged history of sepsis, not in a minor head injury or fall like we're mentioning here. So when and how are you going to make a decision to discharge a patient? I think return to baseline is very different than return to baseline respiratory status. And I think the most challenging time for this is the middle of the night. So many times our patients are waiting for imaging after their injury in the afternoon. By the time the imaging happens and the specialists are able to come from the OR, the family, the patient, and I am all very tired. So after giving the sedative, oftentimes that patient might not return to their normal baseline and be running around the department. But if they're back to their baseline respiratory status, they seem to be able to have adequate hydration prior, even though they've been MPO now, we might want to have them drink something. You have a responsible parent or guardian. They may have a level of consciousness that's below what their baseline is or what they came in, but in the context of this being an overnight, if you give good discharge instructions, and then importantly, make some informed decisions about pain, because I do have many of these patients that might come back if they haven't received adequate pain control as the ketamine wears off. So there's not a perfect answer here, but I would say waiting until the patient is walking and acting at baseline, which some of the guidelines say might lead to quite a long duration of stay in your department. I've taken you through a brief journey here, hopefully distinguishing sedation from analgesia and when you want one versus when you want both. Talked a little bit about the mechanism of action for some of these agents, both the time of onset and offset, as well as the side effects, and then describing some approaches to choosing either pharmacologic or non-pharmacologic methods for sedation. And with that, I guess I'll take questions at the very end. Thank you.
No.
Okay, whoops. Okay, excellent. This is an area near and dear to my heart. When I initially started, I was in general surgery. I did a year of general surgery, and then I was going to be an orthopedic surgeon. And I discovered emergency medicine and thus changed the trajectory of my whole career. So that's pretty exciting, a little known fact or a known fact. But anyway, I have nothing to disclose relative to this. And I'll start out with talking about fractures in childhood. And some of the principles that we have to consider is the age and the mechanism, because that's going to make a difference, because there's certain fractures based on age. You always have to consider the possibility of intentional injury. Unfortunately, this is something that is our responsibility as mandated reporters. So we're going to have to think about these things. What type of injuries are possible child abuse? We'll cover that briefly. And then consider soft tissue injury. Is it open or closed? That's going to be important in terms of management strategies. Consider fractures involving joints, because that also made a difference in terms of the need for closed reduction or open reduction. And you always want to make sure that the exam includes neurovascular function. I think this is really critical because some fractures, especially a very common fracture like supracondylar fractures, can involve neurovascular compromise. And then I think I want to say is a real important take home is you always want at least two views, okay? So a singular view can be very, very misleading. And we've had a number of incidents where you took the baby gram or whatever, or you took the one shot and they said, oh, this looks good enough, but you always want to get two views because you can be fooled. And then you will also want to consider x-rays above and below. And if you look to the right, this is from Up to Date, but it's kind of nice because it shows the wrist and all the types of shots you should get in terms of x-rays, AP lateral and oblique, and say the shoulder, AP scapular and Y. We always do 3 views of the shoulder. And you can see that the types of x-rays that one would order. The other thing I think to consider is what fractures, as I mentioned, are more common to be considered for child abuse. And certainly multiple fractures of different ages that are healing, I think, or anytime there's multiple fractures involved, I think that's important, but certainly those at different stages of healing. Skull fractures, I think, can be considered, especially complex skull fractures. A story of a fall striking the head with a single linear skull fracture is unlikely to be child abuse, as an example. Some other things to consider are rib fractures. As you know, the ribs aren't fully calcified. It takes some great force to break the ribs. The most common, multiple rib fractures, you really need, without a really high kinetic mechanism, you really have to think about child abuse. The other thing to think about is humerus fractures other than supracondylar fractures. Those are typically a direct blow to the humerus. And it has been reported that 100% of those under the age of 3, it's not really 100%. I have seen some accidental. As an example, little Johnny's with the older brother, and little Johnny runs in front of older brother who swings a baseball bat, at the baseball field and strikes little Johnny, and it's witnessed by 5 people. I mean, this is not something that I would report, but I do believe that you have to think strongly about humerus fractures. And the one thing I will say that I think is also really critical is that we have found that it is really important to look at all of your x-rays, and the classic one are chest x-rays. And it was interesting, a child came in with a fever and I looked at the chest x-ray and I realized it was a 2-year-old with a healing humerus fracture. And if you focus on just what you're interested in, you're going to miss these types of things. So just a point of fact, when I think of humerus fractures, I think of that 2-year-old with fever and I go, oh, she doesn't have pneumonia, but you always want to go from the outside in, and she ended up having child abuse. So fractures of long bones, it may be those who are not walking. I would be very, very concerned about fractures of long bones. And then again, fracture without any trauma history that presents with evidence of healing, it's a consideration. None of these are basically 100%, but these are considerations. And then I had mentioned this in the case review when we went over the 3 cases, that it has to be a fall from a significant height in order to break a femur. And it has to be at least greater than 2 feet. So anything less than 2 feet, it's highly unlikely to break a femur. And generally, kids break femurs as they get older and they get enough kinetic energy to be able to twist or fall or run enough with enough speed to have that happen. Can it happen that the child rolls off the changing table? I would say yes. But again, you want to put everything into context. And these are some examples, as you can see on your left, that's a healing femur fracture. And this is a kid who family brought him in and for leg swelling, and had a healing humerus fracture, which was child abuse. Again, skull fractures, they typically are going to be complex. They may have multiple components to them. Rib fractures, especially posterior rib fractures. This is a kid, this is from the AAP slide set, not only has a humerus fracture, I'm afraid you can't see it, but also has a healing forearm fracture. And the classic ones that we see are the metaphyseal chip fracture, as well as something called a bucket handle fracture. Generally, these are torsive or twisting mechanisms. Now, moving on to something that we see every day as most common fracture, green stick fractures. There's about 50% of children. And they're incomplete fractures, typically the metaphyseal, diaphyseal junction, as you can see from the diagram there. There's also bowing fractures, which are microfractures all along that metaphyseal junction. And the classic ones that I've seen with that are kids that come in and you look at their arm, let's just say, and you go, that kid has, that kid has a fracture hands down. And you get the x-ray and you can't find the fracture. This is a kid that's like, get the comparison view, you'll see it, or just you can make the assumption that that's a bowing fracture. And angulation and rotation can be common with these, so sometimes they cause or necessitate closed reduction. So the classic green stick, pain control, closed reduction to either complete the fracture. If it involves both bones, you may not need to do that, and then immobilize. And this is an example of, you can see the comparison view and the bowing fracture. These can be pretty subtle. And again, what I've seen with the bowing fracture, I don't know if my colleagues will comment, but again, they look like they have a fracture and you don't see it on it, and then you get the comparison view. And these actually require operative reduction. The ones that we see all the time that you can manage pretty handily are the torus fracture. These, I love these. You can pick them up. They can be pretty subtle, as you can see here. They often just have, it looks like they have just a little bump in the cortical bone. And you can see a couple examples here. And these are really, really common. We see on an outstretched hand. This is a common one. The distal form is really, really common because kids fall down and go boom a lot, and they try to, not all kids, some kids don't put their hands down, right? Depends on their age, but if they put their hand down, then they're gonna break something, and it often is the distal form. Studies have shown that you can use removable splints for these, which is really nice for parents, although it can drive you crazy because the child is constantly trying to remove the splint. But I will say they're great, and because you can bathe them and then put it back on, and I think these are really useful. And there is probably in the distal form, they're as good as casting. Otherwise, they'll have casting. And the classic Salter fracture, I can tell you you can see the normal. The type 1, it's a fracture through the physis. And what you see on x-ray is a widening of the physis, or you don't see any abnormality. And this can be really tough. If you don't see any abnormality, but they have significant pain, one thing you can do is just splint them and then bring them back for a re-x-ray or refer them for a re-x-ray. But we typically would like to immobilize the type 1 fractures. And I think they're more common than you see here. The most common is type 2 fractures, which is fracture through the physis and into the metaphysis. These are by far the most common of the Salter fractures and the ones we see all the time. Type 3 are through the physis and into the epiphysis, as demonstrated with the diagram there. And type 4 are also about 10%. That's through the physis and into the metaphysis as well as the epiphysis. So through, so it's split, meaning going through the physis, above, meaning into the metaphysis, although it may be below, but let's just say it's into the metaphysis. And then lower is into the epiphysis, through is through both. And then finally 5, thank goodness these are the most uncommon. And this is a crush. Usually it's a significant axial load that results in crush of the area of the epiphysis. And the reason why these are the most challenging is because you get different areas of the physis will have increased blood flow, and that results in abnormal growth, either no growth in one area and growth in another, which can lead to deformities. And you can also have discrepancies, especially in the lower extremity in terms of leg length. So Salter 1 split, this is an x-ray. I don't know if you can see it that well, but if you look on the right, let me see, it's hard for me to point on this because it's, but on the right, it is in the posterior part. You can see widening of this physis as compared to this part. This was a kid who came in with a shoulder injury, and I got the comparison view because I highly suspected that he had a fracture, and he did. He had a Salter-Harris type 1 fracture. And in the other diagram, which I got from Up to Date, you can see there's a little bit of widening of the physis, but I think it's super subtle. And so again, if there's significant pain, you can splint, refer, and then re-examine. So here's the one with the Salter-Harris one. Again, the most common, as you can see in the x-ray, there's a both bone fracture of the forearm, and you can see how it goes from the physis into the metaphysis. And all I can say is that with something like this that is displaced, if you have any question, any displacement, considered certainly rotational effects, I would call ortho for potential. In this case, there's angulation as well as displacement that you might want to consider calling ortho here. I would call ortho for closed reduction. One comment about closed reduction in children, if you're going to do it, I like to do it pretty quickly. they heal really fast. So within the first week, it's sticky and it's very difficult to close these and reduce these. So I would do it certainly under a week. They can be referred for this, but we got so good at sedation now, everybody leans on us, right? And we end up sedating these kids in the ED. Here's a Salter-Harris type 3 in the distal tibia. You can see it goes in to the epiphysis. And in general, unless there's significant displacement, as in the diagram, if there's non-displaced, in this case, the mortise is disrupted, so you would want some type of closed reduction. Salter-Harris 4 is through. And this one's non-displaced. The mortise actually looks really good. So I would still talk to ortho about these, but this is one. The only problem with this is that there may be some movement. So this may be something that certainly they're going to want to cast in the question. I don't think they can do much in terms of closed reduction here. So probably casting and non-weight bear. And finally, Salter-Harris type 5, this is in the wrist. And what you see is bone on bone. And if you notice, these can be really subtle, but what you see here is, see this white line? This is crush. This is bone impacting bone. And so this is a classic Salter-Harris type 5. And these are quite unusual, definitely a very poor prognosis because of various growth arrest that occurs at the level, because the osteoclasts get disrupted and there's abnormal, basically vascular response. So you do see some hypervascularity and low vascularity sites. Okay, can you name those Salter-Harris? I'll let you think about that. And this is Salter-Harris type 4. And again, it doesn't look really disrupted. Anything that involves the mortise, I like ortho to have eyes on it. All right, next is a classic scenario, a 16-month-old with a limp. The mother brings her 16-month-old girl to the ED because the child refuses to bear weight. Usually these kids bear some weight, but they're limping. So the classic is limping. I do have a little bit more concern when they're fully non-weight bearer. I have to think about something else. One of the things you have to do is, especially with limp, and I'm not going to get into a big differential on limp because that would take an hour, but the bottom line is that has no medical problems, no fever, no systemic signs. That's all really good in terms of thinking about other things like transient synovitis, septic arthritis, etc. This is a classic story of a toddler's fracture. What I find tough about some of these kids who come in is you're trying to figure out where anatomically is the problem, right? Is it in the foot? Is it in the ankle? And you got to think of what's common. Kids don't break their feet often or their forefoot, right? Or their tarsal bones. They just don't do it. So you take the mechanism or lack of mechanism, the fact that this is a toddler and they often are running in one direction and they change their mind, but their foot is planted and cause a torsive force, which results in a toddler's fracture. And these are oblique, sometimes spiral fractures of the tibia. And the problem with this is that because it's caused by their own kinetic forces, it's not enough force to cause displacement. And so they get a torsive force which causes the fracture, but not enough to cause displacement. So this can be problematic. And here you see a view of this right now. So what do you do for toddlers fractures? Pain control, below the knee, walking cast for 3 weeks. What if you don't know? You could do a comparison view. I typically don't like CT them or anything. I mean, a CT would pick it up, but I mean, you could potentially try to ultrasound them and see if you see the fracture. I don't think I'm that good at ultrasound to do that, but I would splint and consider just repeat films, usually in about 10 days. We used to do bone scans, but those are I'd say passe MRI, but then you got to sedate them. So I don't know. I just typically just get good follow-up for these kids. And my last case, just to keep us going and try to get us on time here. This is a 7-year-old boy brought in by paramedics after falling off his bike. Patient holds his right arm in slight flexion with obvious swelling at the elbow, and the distal neurovascular is intact. Otherwise, the trauma is negative. And this child, this is a classic supracondylar fracture. You look for this notching here, and there's some other signs radiographically, which I'll show you, but here's the notch, and you really look for that. You also look for this figure of 8. Some people call this an hourglass. And on a true lateral, it should just be perfect. And there's some disruption here. So not only is there's disruption in the hourglass, the anterior humeral line, I'll show you that in a bit, is off, and there's a bit of notching. So this is a supracondylar fracture. And the problem is if it's displaced like it is here, then you can get vascular injury. And if it's displaced, up to 7% will have neurovascular injuries. So the markedly displaced supracondylars, these are the ones we always admit. And I'll talk about the classification. We call it Gartland classification, class 3A or 3B. Anytime they're markedly displaced, we will admit those patients. Not only do they need operative reduction, but they need frequent neuro checks. And this is, going back, this just shows you the fat pads. This is your olecranon fat pad. And generally this is invisible on a true lateral. And what happens with the fracture is that the blood pushes the fat pad outward. Here's the anterior sail sign. We do see these, and it's demonstrated here. But the anterior sail sign can be normal, but it also can be expanded in fracture. But a posterior fat pad that is visible on a true lateral, okay, is always abnormal, and it can be that you just can't find the fracture. If you can't find the fracture, I would splint and refer. Okay. Let's look at the x-ray here. This is called the anterior humeral line. If you draw a line along the anterior humerus, it should bisect the capitellum, okay? And you can see it here. This is the supracondylar fracture I showed you. If you draw down, it does not bisect the capitellum. That's because there's mild angulation going posteriorly. So this is a hinge. This is a type 2 Gartland supracondylar fracture. These need closed reduction, but they can be sedate, closed reduction, and send them home. Here's the teardrop. Again, you can see it nicely here. This does not look like a nice little teardrop. You see some notching both in the front, and you can see a fracture line in the back, and it also has fat pad signs. So this has essentially all the signs. Here's the classifications. We used to admit all supracondylar fractures, but that was many years ago. We don't do it anymore. And the reason is because the type 1 supracondylar fractures that are non-displaced without significant hinging or displacement, as you can see with type 2, those are splint and refer. You can send them home. The type 2, as you can see here, anytime there's hinging and posterior displacement, that's closed reduction and send them home. And type 3, A or B, these are patients that need to be admitted. So anybody guess the type of Gartland fracture this is? You see there is some notching here, and the question is there a hinge or not? I would suggest that there is a slight hinge in this. This is somebody I would call ortho on. So this is a type 2. And this is certainly concerning whenever you get any type of type 3 Gartland fracture. All right, here's something is important for you to know about, and this is something emergency physicians miss, not infrequently, and this is a very important radiographic sign, which I think you're going to use this, I hope, every day in your practice when you do elbow films. And this is the radial head should always, it's hard to say always in medicine, but should always line up with the capitellum. And as you see it here, you see it there. You can't see it there, but it's there. It should line up in every single view. And if it does not, you have a dislocation. So this is very important for the distinguishing certain types of fracture dislocations. And so let's use our skills on this lateral with an ulna fracture. It's not quite a proximal ulna fracture, but the radial head should always line up with the capitellum. It does not. One could look at this x-ray and say, oh, there's an ulnar fracture, I'll splint and refer. But this is a child can have significant morbidity because this is a radial head dislocation. And this is called a Montesia injury. And it's generally fracture of the ulna, often the proximal ulna with radial head dislocation. And here's an example of that. And again, on the same view, the radial head should always line up with the capitellum. And this is from Lauren Yamamoto's site I took a number of years ago. But you can see this. This is super cool. If you just practice this, looking at this all the time, you're not going to miss this ever in your practice because you'll look for it. This is a Galeazzi fracture, and what you can see, fracture of the distal third of the radius with dislocation of the ulna. This is pretty brutal too, although I find that this is not often missed like a Montesia injury. So I didn't cover a lot like Toulouse fractures and avulsion fractures and other things, but hopefully I gave you a good overview of the most common fractures in childhood. So thank you very much.
Thank you. For the workshop, questions for determination.
Okay.
For this topic, or for the aims for children, and for the sedation.
You want to come up?
Do you have any questions?
Should we come up or stay where we are? Okay. Mark, you want to? No? Okay. Any questions?
Yeah. Go ahead.
I've heard different opinions about that outdoor fracture, and some people say it would be safe to just watch it. I heard different opinion about outdoor fracture. Oh, yeah. And what some people say we can watch.
I think if you can't see the fracture, then you consider watching. If you find the fracture, you
question for procedural sedation and any recommendation for situations
autism without other medical conditions or physical conditions, certainly can use information like ketamine, like emergency, but I think just being cautious, just work with have a child their way. I think that one of the things that has changed is what we call autism technique, helping decrease not just for the sedation, but actually when they're coming in and working with the family to understand what either triggers the child. So I think for minor procedures, making sure that we're not getting in a spiral, getting the child agitated, perhaps that needs physical restraint. Having parents and some EDs or ED must not have this, but some EDs actually.
Hepatitis E, influenza, this HIV, malaria, measles, meningococcal, meningitis, MMR, how vaccine work. The body is exposed to weakened or dead pathogen. The body's amino cells make antibodies to attach the pathogen. If the body is exposed to the pathogen again, the body will be prepared to antibodies. Vaccines protect the community. Community immunity when sufficient populations of population is immune to infectious disease to make it is spread from person to person unlikely. Coverage 3, the minimum percentage of individual immune to disease needed type of vaccine life attenuated contain weakened pathogen required 1 to 2 dose. Example MMR rotavirus varicella. Inactivated contain killed pathogen required several dose booster shot. Example hepatitis A. Inactivated polio vaccine subunit contain killed antigenic component of pathogen required several dose booster shot. Example HIV, HBV, pneumococcal. Toxoid contain toxin made by pathogen may require booster shot. Example diphtheria, pertussis. Vaccine component safe and effective. Provide immunity, antigens, adjuvants, keep vaccine safe and long lasting. Preservative, stabilizer, used during the production of vaccine. Cell culture materials, inactivating ingredients, antibodies. Immunization schedules based on scientific evidence designed to best protect public health, formulated using robust scientific evidence. Contraindication and precaution. Contraindication and precautions are conditions under which vaccine should not be administered. The majority of these conditions are temporary, so immunization often can be administered later when the condition no common methods. It is better to base out childhood vaccine using an alternative schedule. From birth, baby immune system is well equipped to respond to vaccine. There is no evidence that spreading out the schedule improved health outcome. Delaying the vaccine increase the times children will be susceptible to disease. Vaccine cause the disease they are designed to prevent. Inactivated vaccine cannot be cause disease. It is nearly unheard of for life attenuated vaccine to cause disease. Mild symptoms are rare but can indicate immune response, not infection. Common methods may child is at greater risk of harm from vaccine than from the disease itself. The risk of natural infection are greater than the risk of immunization of every recommended vaccine. Severe side effects from immunization are incredibly rare. Immunization is the best protection against the disease. Immunization protective individual illness and large scale outbreak. Communication with the patient to bolster vaccine confidence. Presume acceptance. Listen, validate concern. Response to concern with the positive message about vaccine information. Debunking method. Communication risk of delaying immunization. Share experience about share experience about immunization, have follow-up conversation, provide additional resource about vaccine. Thank you.
Any question? Question? Okay. Okay, I think she went. Look, always was child with a special infection, chickenpox, they need to be isolated because remember always the immune system of the child is not mature. It's very easy just to mature. Now, if you have, for example, two rooms, one is a private room and you have shared room, that one with a high acuity or the high level of infection needs to be in the private room. The other, they need to be in the shared room. Always, yes, we need to isolate the cases. Even the waiting area at some point, they need to have if you suspect a patient with any type of infection, shouldn't be in the waiting area, should be directly to a private room or isolation. You shouldn't. Okay. It's not weak, it's a normal response. No. This is a normal response to because you are giving. Yeah, it's a normal response. It doesn't mean that the immune system it's weak. Totally different. Have fever, child. All you need just to give fluid and Panadol. That's it for a few days. No. It doesn't mean that because now the immune system is weak. No, it's another source.
Assalamu alaikum.
Okay. Yes, please start.
Assalamu alaikum.
Alaikum assalam. Fadal.
I'm Major Dr. Aladdin Al-Ali from Hashemite Kingdom of Jordan. I'm working as a neonatologist in King Hussein Medical City in Royal Jordanian Medical Services.
Okay.
I'm going to talk about a study which was published about 2 years ago titled the role of magnesium sulfate in the treatment of persistent pulmonary hypertension in neonates.
Okay.
This is our experience in King Hussein Medical Center. I'm showing here the poster. It is just in few words, but I will talk more, inshallah. So this study focus on current knowledge of effectiveness of magnesium sulfate treatment in PPHN. What I mean, PPHN, it is a persistent pulmonary hypertension in neonate, and the outcome, as well as the recent progress regarding clinical evidence on potential therapeutic approaches for management of PPHN. So as we know, persistent pulmonary hypertension of a newborn, in other name, it is persistent of the fetal circulation, is defined as a failure of the normal circulatory transition that occurs after birth. It is a syndrome characterized by marked pulmonary hypertension that causes hypoxemia secondary to right to left shunting of blood at the foramen ovale and ductus arteriosus. So the PPHN is one of the main causes of neonatal morbidity and mortality. It is characterized by sustained elevation of pulmonary vascular resistance, preventing an increase in pulmonary blood flow after birth. The affected neonates fail to establish blood oxygenation and precipitating severe respiratory distress and hypoxemia, and eventually death. As we know, inhaled nitric oxide, the only approved pulmonary vasodilator for PPHN with supportive therapy. However, nearly about 40% of infants are inhaled nitric oxide resistant. The cornerstone in this condition of increased pulmonary vascular resistance in PPHN are pulmonary vasoconstriction and vascular remodeling. So one of the other medications can help in this condition. It is sildenafil, prostaglandin, and milrinone, and which acting as a vasodilator. Besides, glucocorticoid also can play a role in reducing inflammation and can give a potential beneficial effect on the PPHN. There is many alternative and novel experimental therapy in PPHN, but still unapproved. Pulmonary hypertension, persistent pulmonary hypertension, it is a critical condition caused by failure in normal cardiac pulmonary adjustment after birth. Many factors can interfere with this process, such as meconium aspiration, parenchymal lung disease, sepsis, and intrauterine or perinatal hypoxia, and abnormal pulmonary development. This study was conducted to evaluate the effect of magnesium sulfate as a treatment for persistent pulmonary hypertension of a newborn and its outcome. This study was a retrospective review of a neonate with PPHN treated with magnesium sulfate at King Hussein Medical Center, a neonatal intensive care unit during the period of January to December of 2018. Our samples covers about 19 newborns during 1 year, admitted to an ICU, all of the 19 out of about more than 1,000 deliveries, with respiratory failure and profound hypoxemia resulting in persistent pulmonary hypertension were enrolled in the study. All patients underwent the following tests: CBC, kidney function, blood gases, chest X-rays, and echocardiogram. All patients with congenital heart disease excluded from this study. The persistent pulmonary hypertension of a newborn described as a circulatory pattern of right to left shunting across the patent ductus arteriosus and patent foramen ovale as a result of excessive pulmonary artery resistance. This in turn leads to extreme hypoxemia that might not respond to standard respiratory support. There are many factors and causes that lead to newborns with high pulmonary artery pressure, including a primary causes, which is rare, and secondary causes like severe lung disease and meconium syndrome, meconium aspiration syndrome, surfactant deficiency, RDS, and infection like pneumonia, and perinatal asphyxia, structural abnormality, and congenital heart disease, which excluded from this study, and congenital diaphragmatic hernia. The incidence is about 1 to 1 over 500 to 1,500 live births, with a wide variation among clinical centers with an estimated mortality of more than 20%. And approximately 25 of survivors of neonatal display significant neurodevelopmental impairment when tested at 12 to 24 months of age. The initial finding of PPHN is respiratory distress and cyanosis, and this may occur despite adequate ventilation, in addition to tachypnea, retraction, and may have significant decrease in pulse oximeter readings with routine nursing care or minor stress. Other clinical findings are highly variable depending on the severity stages and other associated disorders, particularly pulmonary and cardiac diseases. The diagnostic criteria of PPHN include one, it is severe hypoxia, which means PO2 less than 50 with 100 inspired oxygen with appropriate ventilation. Suprasystemic and pulmonary blood pressure can be estimated by echocardiography, and normal cardiac anatomy. Cyanotic congenital heart defect should be excluded by echocardiography and cardiologist assessment. Evidence of right to left shunting with bidirectional flow across patent ductus arteriosus or foramen ovale on echocardiography. Also, one of the bedside examination, the difference between the autosat saturation, preductal and postductal should be more than 10. So the treatment approach for PPHN is still controversial, and various modalities of treatment have been tried, including supplemental oxygen, intubation, mechanical ventilation, nitric oxide, sedation, analgesia, pharmacological agents, which can support also the pressure like dopamine, epinephrine, sildenafil, and magnesium sulfate, and finally extracorporeal membrane oxygenation, ECMO. Neonates who develop with PPHN are at approximately 20% risk of rehospitalization within 1 year of discharge and have a 20% to 46% risk of audiology and neurodevelopmental or cognitive impairment. So the methods for collection this data, it was retrospective review of neonates, care at retrospective review of a neonate with PPHN treated with magnesium sulfate in neonatal intensive care unit at King Hussein Medical City during the period of January to December 2018. The results showed that the total number of PPHN was 19 cases from more than 1,000 deliveries by 1 year, admitted to neonatal ICU. Here we see in the table 1 shows the descriptive study data such as gender, distribution, gestational age, and delivery mood. Male newborns with PPHN were about 52%, while the female 47%. Full-term cases more than 37 weeks, 47% of cases. The number of the gestational age between 30 to 37 weeks, about 21%, and the gestational age less than 30 weeks, 31%. The normal delivery number was 37%, while the cesarean section number was 12. It is about 63%. The babies with birth weight higher than 2.4 kg, 42%, and the babies with low birth weight, less than 2.4 kg, they were about 57%. The number of newborns with lung hypoplasia, which associated also with PPHN, about four cases. It is about 21%. Prematurity, also 36%. RDS, it is 63%. Sepsis, it is 47%. Congenital diaphragmatic hernia, it is 10%. Birth asphyxia, also 10%. All of these cases was managed with magnesium sulfate infusion. The only side effect registered in our cases, with a total number of about 8 cases, 42% of the cases using magnesium sulfate, it is only hypotension. We have also used combination of treatment, sildenafil with magnesium, when there is resistant to the magnesium sulfate. We used also sildenafil also in 4 cases. It is about 20%. The number of deaths, it was 36%. The primary outcome showed a significant drop of pulmonary artery pressure during first 48 hours, can be in some cases extended up to 5 days after initiation of magnesium sulfate therapy, compared to baseline pulmonary artery pressure. Significantly lower during these days. We can see this in table 3. The secondary outcome measures an essential factor indicating an improvement of the patient in the time interval to normalization of oxygen saturation and arterial blood gas. Unit treated with magnesium sulfate therapy showed significantly shorter interval to oxygen saturation normalization and arterial blood gas and duration of ventilation. We can see the duration of treatment and the improvement in the table 4. The mortality, as we said, it is about 7 cases, which mean 36.8%. Two of the cases showed congenital diaphragmatic hernia, and the other 5 showed sepsis. PPHN, I have time?
No, I think we exceed 10 minutes per.
What?
How many times do we need more?
I think just 1 minute. I can finish with 1 minute.
Okay.
Conclusion. Finally, I will talk about the conclusion. This study concluded that magnesium sulfate could be used as a safe and effective method for treatment of treating PPHN. It may have a place in the treatment of PPHN, especially in areas where nitric oxide and ECMO are not available. The magnesium sulfate treatment showed good result with regard to survival rate and side effect comparing to the other treatment. And the pulmonary artery pressure was significantly reduced after 5 days of therapy in unit receiving magnesium sulfate. This study provides evidence that magnesium sulfate can play part in the therapy of PPHN. It is a non-aggressive treatment of short duration and low cost. And I would like to mention there is not enough data about the treatment by magnesium sulfate, and it is not commonly used. So we decide to do this study, and this is our conclusion. Thank you.
Thank you, Doctor.
Thank you. Any question? Okay, thank you. Goodbye.